I'm Rusty Brown. I'm professor of radiology at Mayo Clinic in Rochester, Minnesota, and we're going to be talking about ultrasound of adnexal masses. We're going to review ovarian masses primarily. First, we'll talk about the normal ovary and several things that really should not be considered or reported as a mass. We'll talk about common benign masses, neoplasms, and particularly the most important indicators of malignancy. We'll review some extra ovarian masses, and a lot of the recommendations and criteria that we'll talk about are based on the SRU consensus conference on adnexal cyst and other masses, and the recommendations will be for asymptomatic patients. First of all, let's review the normal ovary. The ovary is unique in that it has small cysts, which are really follicles, as part of its normal structure. We know these follicles get up to, on average, about 2 to 2.5 almost centimeters at ovulation. From the consensus conference, we considered follicles up to 3 centimeters in maximum diameter to be normal in premenopausal women, and we just consider that a dominant follicle. You do not want to report those as cysts. The corpus luteum is another normal structure that we see after ovulation. The typical appearance is in this one, where you have a cystic lesion with kind of a thick crenulated wall, some internal echoes. If you put on color of power Doppler, it's often a vascular rim. That's quite typical. These are usually less than 2 to 3 centimeters in maximum diameter. And this is just a typical appearance of a corpus luteum that we expect to see after ovulation. And we don't want to report these as abnormal or masses that need follow-up. Occasionally you may not be sure about one, but most cases they have a characteristic enough appearance that you can be confident. I'd just like to mention the word cyst. I think it's problematic when we use the word cyst in the ovary, since we do have these follicles that are normal, and they appear basically as a simple cyst that we would describe as a cyst in any other organ. The problem with the ovary is it can be misinterpreted by our clinical colleagues. It can be misinterpreted by patients who now often can see the reports in many institutions. So I would encourage you to try not to use the word cyst for any structure in an ovary that you think is normal. So these dominant follicles, I would just call them a dominant follicle. If it's the corpus luteum, I prefer not to use the word even corpus luteum cyst. Just call it a corpus luteum. Even multiple follicles or physiologic cysts, I think, can be misunderstood. Normal is a great word. I would encourage you just to use normal. Or I'll often, when it's a cyst, a dominant follicle that is, that's getting close to 3 centimeters, just say normal ovary with a dominant follicle measuring X. Or normal ovary with a corpus luteum. And just try not to use that word cyst because it can be so misunderstood. What about the normal postmenopausal ovary? Often they're small and homogeneous like this. It makes it even harder sometimes to be confident that what you're looking at is truly the ovary. But you can see small cysts, and these probably are not follicles in the postmenopausal ovary, so I would call them cysts in this patient population. We know that about 20% of postmenopausal women have small, simple cysts, that is less than about 1 centimeter, and these are considered of no clinical importance. That was a recommendation from the SRU consensus conference also. So if you have this simple cyst in a postmenopausal patient that's less than 1 centimeter, you could ignore it, or if you want to describe it, you could just say it's considered of no clinical importance in a postmenopausal patient. So in general, the things that are normal and that we really don't want to call attention to and that do not need follow-up are in the premenopausal patient, a follicle less than 3 centimeters, a corpus luteum, again I would encourage you not to call these cysts, and in the postmenopausal patient, a simple cyst of 1 centimeter or less in maximum diameter. I want to mention a couple of other things that you may see in the normal ovary so they're not misinterpreted. These tiny echogenic foci are common. They're typically 1 to 3 millimeters. A few of them are pointed out here by the arrows. Sometimes they have no distal artifact. Occasionally there's a short comet tail artifact. They do not typically have acoustic shadowing. These are common. As best we know, they're clinically insignificant. Different studies have found different causes, from calcification to hemosiderin to tiny cysts, where we're seeing specular reflectors from the back walls of these tiny cysts. Regardless of the cause, as best we know at this point, they're generally insignificant. I'll admit occasionally they're very extensive in the ovary. There's just a few in this ovary. If they're unusually extensive, I might follow them, but even then, I doubt that they're clinically significant. Aside from these tiny, more common 1 to 3 millimeter echogenic foci, you'll occasionally see a larger calcification in the ovary like this. So these are larger. They're usually 5 millimeters or more. They do have acoustic shadowing, as in this case. So this is different than the more common tiny echogenic foci. What do they mean? A study from many years ago found that one patient developed a mucinous cyst adenoma, and one patient later developed a dermoid, though it was not clear that it was actually coming from this area of calcification. A later study looked at these calcifications of 5 millimeters or larger and found really no clinical significance. None of the patients developed tumors during follow-up. One patient had path correlation, and it showed calcification in the corpus albicans. So I think in general, when you see these isolated coarse calcifications with no associated mass, they're generally of little to no significance. Probably don't need follow-up, but if you are going to follow them, there's really no role for early follow-up. I'd wait at least a year, perhaps two, to follow these. I think it's important not to report these as masses, just as isolated calcification. And again, generally in my experience, they're of little to no clinical significance if there's no associated mass. So that is important to make sure it's not part of a mass. Dermoid, sometimes people will consider these. We know that dermoids can get calcification or ossification, but it's unusual for the dermoid just to be a focus of calcification by itself without any other component of a mass. So what's our approach to characterizing adnexal masses? Well, several different tacks have been tried. Subjective assessment is, I think, what many of us use, and it's been shown to work well when done by an experienced examiner. There are different mathematical models. There's a risk of malignancy index. There's an adnex mathematical model. Several different ones have been proposed using a combination of ultrasound features, sometimes clinical or laboratory features in addition. The International Ovarian Tumor Analysis, or IOTA group, has also done a lot of work in this area, and they have a simple rules approach that identifies specific sonographic features that predict malignancy, specific ones that predict malignancy, and then if they meet those criteria, you can confidently predict benign or malignant. I think many of us still use the subjective approach. We know what those features are, and we'll review those that indicate benign or malignant cause. And we pretty much, at this point, I rely on subjective assessment. First, I'd like to review the common benign ovarian masses. I kind of call these the big four because this is kind of the bread and butter of ovarian ultrasound. They account for the majority of masses that will be seen in most clinical practices, and they have a typical appearance in the majority of cases that strongly suggest the correct diagnosis. So it's really important that you know the typical appearance of these four masses. And they are the simple cyst, the hemorrhagic cyst, the endometrioma, and the dermoid, also termed mature cystic teratoma. So first we'll review the simple cyst. It needs the same criteria as a simple cyst in any other organ. It's anechoic, basically no perceptible wall. There's no solid component at all, and there's typically distal acoustic enhancement. So here we have an anechoic mass, no real wall. This is a rim ovarian tissue around it, and acoustic enhancement. Typical simple adnexal cyst, in this case coming from the ovary. Now, many years ago, used to think that we didn't get simple cyst in postmenopausal patient. I mentioned before in premenopausal patient, if it's over 3 centimeters, then I would refer to it as a simple cyst. In postmenopausal patients, we're generally going to follow them if they're over about 1 centimeter. We have learned that somewhere around 3 to 18% of postmenopausal women will have simple cyst in their ovaries. If we follow those simple cysts, what happens to them? Well, these numbers you'll see here don't add up quite to 100% because they're from different studies. But in general, near half will disappear, and most do so within 1 to 2 years. Another almost half, 10 tend to persist unchanged, and then a small percent, probably in the neighborhood of 10% or less, will increase in size. Interestingly, the ones that end up being removed surgically, and those obviously are going to be the larger ones in most cases, the majority, about 85%, are serous cystadenomas, which are benign neoplasm. So what about the follow-up for simple cyst? From the SRU Consensus Conference, yearly follow-up was recommended when it was over 5 centimeters but less than 7 in premenopausal patient, and over 1 centimeter but less than 7 in the postmenopausal patient. There are some centers that might up this number from 1 to perhaps 2 or 3 centimeters before following them yearly. That's not unreasonable either. You should consider that when the cyst is over 7 centimeters, regardless of menopausal status, that you should think about doing MRI or consider surgical evaluation. The reason for that is a study that found when they're over about 7 to 7.5 centimeters that small solid nodules along the wall can be missed sonographically. So I think as the cyst gets larger, it becomes more difficult to be confident that there's no small solid component, and as we'll talk about shortly, the solid component is the most important sonographic feature to predict malignancy. So what about the risk of malignancy in unilocular or simple cysts? First, it's important to realize that simple cysts are not necessarily the same as unilocular. We just talked about the definition of a simple cyst. However, the definition of unilocular in many studies, and including the IOTA definition of a unilocular cyst, allows for solid protrusions of less than 3 millimeters from the wall. That's considered an irregular wall and not a nodule or papilla in their scheme, but still qualifies as a unilocular cyst. Could also have internal echoes and be a unilocular cyst. So while they're sometimes the same, that is, all simple cysts will be unilocular, not all unilocular cysts are simple cysts. It's important to be aware of that distinction. Since the Society of Radiologists and Ultrasound Consensus Conference, there has been a study from the IOTA group that described 4 of 326 simple cysts, and they actually did pull out the simple cysts, not just the unilocular cysts that were malignant. They ranged in size from 4.5 to 4.8 to even 14, and those did have small papilla at pathology that were missed on ultrasound. One lesion at 5.8 centimeters had no papilla identified at path and was still malignant. So it did find a very small percent, about 1% of simple cysts that were malignant. I think, does this cause us to change our recommendation from the SRU Consensus Conference of 7 centimeters, that you should consider further evaluation? I think not. There's still good evidence that the majority of cysts that are simple, that are less than 10 centimeters, that malignancy is very unlikely. So I don't think we need to change that 7 centimeter threshold, but I think the studies do emphasize the importance of high scan quality and looking carefully for these small nodules along the wall. So it certainly should be true for any cyst that you think is a simple cyst on ultrasound. Look carefully along the wall for any solid component. And particularly as it gets larger, make sure you look at the entire wall. And that takes a little more time. You have to be a little more careful. But there is the potential that as you get larger, it's easier to overlook small nodules that would change your characterization of that adnexal mass. So just be careful. Make sure you really think it's a simple cyst. Paraovarian simple cysts are common. In the SRU recommendations, they were treated the same as ovarian. One could perhaps argue that paraovarian cysts are even less concerned than ovarian cysts. Part of the difficulty is some of the original studies actually lump them together, and admittedly, occasionally, it's hard to tell whether a simple cyst in the adnex is coming from the ovary or is outside the ovary. You could perhaps make an argument that, a 3.5 centimeter simple paraovarian cyst in a postmenopausal woman maybe doesn't need the same follow-up as an ovarian cyst. That's perhaps debatable, but they were treated the same in the SRU recommendations. Now, what about persistent simple ovarian cyst? And this is a great question, comes up a lot. So you follow these 2-3 years, they're stable. Can you stop following, or can you change the frequency? And I don't think we know the answer to that. It probably is related to some degree on cyst size. You know, I'd be more concerned about stop following a 6 centimeter cyst than I would a 2 centimeter cyst. How long? Is it just a couple of years? Is it 5 years? Does the patient have other risk factors? Some of this is patient preference too, whether they want to keep following it. So I don't know that we know enough to say stop completely following it. I think unless it's the larger ones that perhaps if they've been stable for 2 to 3 years, you might decrease the frequency of follow-up. I don't think that's unreasonable, but I don't think we know enough at this point to say not to follow them anymore after any period of time. So the other question is, how much measured size change is real? I'm not aware of a lot of data on the reproducibility of ovarian cyst measurement. I do think it's important, if you think a cyst has changed in size, not just to look at pure numbers, but look at those images, see how it was measured, see how it was measured on the prior study, see if you think you're measuring it in similar planes before concluding whether it's changed or not. And slight differences, I think, are often technical and probably not a real change. But before you say it's really changed, I would look carefully at the images and how the cyst was measured on both studies. So that's the simple cyst. The other one of the big 4 common benign cysts is the hemorrhagic ovarian cyst. This is typically due to hemorrhage in a corpus luteum or a follicular cyst. Majority will resolve within 8 weeks, sometimes sooner. There's anecdotal cases of them taking longer to resolve, but in the vast majority of patients, they will resolve within about 8 weeks. The typical ultrasound features is this reticular pattern of internal echoes. They're very fine linear echoes. Notice that they're not true septations. I would encourage you not to call these septations. The difference is with these reticular pattern, they're short linear to curvilinear echoes. They don't go all the way across the cyst wall, and they're not as thick as true septations. This has also been called lacy spider web pattern, and it's thought to be due to fibrin strands due to the hemorrhage and clot. So when you see this typical appearance of a hemorrhagic cyst, you can be confident that's what you're looking at. Another feature is sometimes in hemorrhagic cyst you get a solid component. If it has concave margins, as in this one, rather than bulging out, it's concave in, and you don't get flow in that area with color Doppler, that's also suggestive of a hemorrhagic ovarian cyst. What about follow-up of typical hemorrhagic ovarian cyst? Well, again, most resolve within 2 months. From the SRU consensus conference, we felt that in an asymptomatic patient, if it's less than 5 centimeters, you probably don't need to follow those on a routine basis. If it's over 5 centimeters, we suggested follow-up. We'd usually wait 6 to 12 weeks. Ideally, you would re-image the patient days 3 to 10 of the menstrual cycle, where you're less likely to get hemorrhage into another cyst or corpus luteum, although admittedly it's sometimes hard to plan the follow-up at that point of the menstrual cycle. What about early postmenopausal patients? Early postmenopause refers to the first 5 years since the final menstrual period. There is evidence that women in this time frame can occasionally ovulate. I haven't seen it very often, that is to see hemorrhagic cyst in this time period, though admittedly you have perimenopausal patients where sometimes you're not sure which group they really fall in. But if it's in the perimenopause to early postmenopausal period, I would follow those hemorrhagic cysts of any size at 6 to 12 weeks. Once you get 5 years past the final menstrual period into the so-called late postmenopausal phase, you really shouldn't have a hemorrhagic cyst anymore. And I don't think I've really encountered this, but I wouldn't be willing to accept it as a hemorrhagic cyst, even with the typical appearance, if they were over 5 years since the final menstrual period. And I would probably do further imaging with MRI or consider surgical evaluation. One pitfall with hemorrhagic cyst you want to be aware of is that acute to subacute clot can fool you for a solid component. Here's a big a mass in the ovary. It actually looks solid in the sense that it's got internal echoes, but with color Doppler, we're not seeing any flow inside of it. This should always be a tip-off to you in a premenopausal patient that you may be looking at clot rather than true solid tissue of a neoplasm. So always think about this in a younger patient, a premenopausal patient, before I call a solid ovarian mass. And the lack of flow would at least suggest, doesn't prove that it's not a neoplasm, but I would give this patient an interval follow-up ultrasound in 6 to 12 weeks to see if it resolves. Hopefully it does and you have your answer. Obviously if it's still there and looks the same in 6 to 12 weeks, hemorrhagic cyst becomes very unlikely. Another common benign mass is the endometrioma. These classically have these homogeneous, low to medium level internal echoes, sometimes referred to as a ground glass appearance, without a solid component. When you see this appearance, it's very typical of an endometrioma. You may have these small echogenic foci in the wall. I talked about these earlier, and a normal ovary is generally being insignificant. I'm still not certain whether they're truly in the wall or they just happen to be in the ovarian parenchyma next to the endometrioma. They have been described as a feature of endometrioma, but they are not a requirement to diagnose endometrioma. So just be aware you may see them, but it's not a requirement. The main thing you're looking for with endometriomas is this homogeneous, low to medium level echoes, ground glass appearance in some terminologies. Many are unilocular, but you can have septations. Here's one with 2 locules, both homogeneous internal echoes. Here's one that can fool you for solid mass. And I think, in my experience, this happens with the more chronic endometriomas. They're pretty homogeneous. There's actually 3 lesions here, and they can look like a solid mass. And I think these are just the ones that have been around longer. You get a little higher degree of internal echoes, and it can fool you for a solid mass. So I consider that when there's no internal flow detected in such a lesion. What about follow-up? At any age, we generally recommend a follow-up in 6 to 12 weeks. This is really more important if you're considering surgical removal because there is some overlap in the appearance of endometriomas and hemorrhagic cysts. So particularly if a patient is planning to have surgical removal of endometrioma, I think at least one follow-up ultrasound beforehand in the 6 to 12 week range is helpful just for the infrequent occurrence of a hemorrhagic cyst that might simulate an endometrioma and would resolve in that time frame. If it's not surgically removed, we consider yearly follow-up to look for enlargement or develop of any solid component that would be more concerning. There is a problem area with endometriomas. Occasionally, and it happens probably in about 5 to 20%, you see a small nodule along the wall of what otherwise has homogeneous internal echoes. So what do you do then? As we'll talk about further in a few minutes, these solid nodules are generally concerning for neoplasm and a malignant neoplasm, but we know they happen in a small percentage of endometriomas. This is a difficult area to sort out. This little slightly hyperechoic nodule could be due to clot, in which case with color power Doppler you would not expect to see flow, but sometimes it's due to focal areas of endometrial tissue, and you could see flow in these by color power Doppler ultrasound. If you did an MR, sometimes they will enhance too if it's due to focal endometrial tissue. So these unfortunately occur in a minority of endometriomas. They're problematic. We know that probably most of these are still benign endometriomas. But these are difficult ones to know how to manage and may end up requiring surgical removal to be certain that you're not dealing with a neoplasm instead. Even though, again, the majority of these, in my experience, are still going to turn out to be endometriomas. I think the ones I've seen have typically been small solid components like this, minimally hyperechoic compared to the adjacent ovarian parenchyma or cyst wall. We know that a small percentage, 1% or less, of endometriomas can become malignant. They typically evolve into an endometrioid or clear cell carcinoma. Here's such an example. This one has the homogeneous echoes, but the solid component in this malignancy is much larger, more irregular than what we just saw in the benign endometriomas. So you start seeing this larger solid component. This, I don't have the image available here, but did have flow by color power Doppler. Then you become concerned that you're dealing with an endometrioma that has become malignant, or occasionally there's other malignant neoplasms that can simulate this when they have the solid component. The majority of malignancies in endometriomas are larger masses, over about 9 centimeters, and the patients tend to be a little older age. So certainly you should suspect malignancy if you see rapid cyst growth or development of a solid component that was not present previously. So the last of the common, the big four as we referred to, common benign masses is the dermoid or mature cystic teratoma. It's been reported as the most common ovarian neoplasm. It is a benign lesion, can occur in pre or postmenopausal patients. Bilateral in 10 to 15%. The torsion or rupture risk is small. Torsion's been reported 3 to 16%, rupture 1 to 4%. I think these numbers are probably lower nowadays. I don't think we see even that percentage of patients with a dermoid who have torsion or rupture, but it is a small risk. The ultrasound features that are typical are focal or diffuse hyperechoic component, the hyperechoic lines and dots, which has been termed the dermoid mesh. You get areas of acoustic shadowing. You don't typically expect flow by Doppler ultrasound. And here's some examples of those. Here's a hyperechoic component, maybe faint acoustic shadowing. This had more pronounced acoustic shadowing. Here's the dermoid mesh. Here we see these little short linear echoes that actually are probably the hair fibers in a more liquid component of the dermoid. It's thought that when the hair fibers are in the more sebum or fatty part that you get a lot of interfaces, as in this part, that may cause a more uniformly hyperechoic appearance. Many dermoids will have more than one feature. If you'll notice in this one with the dermoid mesh over at the side, there's actually a hyperechoic component also, which would make you even more confident that this is a dermoid. So these three are the most typical appearances you're going to see for a dermoid. This last appearance has been described as floating fat balls or globules. If you'll notice, this is a transabdominal scan. These little spherical areas are non-dependent. That is, they're floating. It's been reported as a pathognomonic appearance of dermoids. However, it's not very common, tends to occur in larger masses, and you won't see this very often, but it probably is highly predictive when you do see it. If dermoids are not removed surgically, the SRU consensus recommendations were for yearly follow-up to look for growth. Admittedly, dermoids, if they grow, tend to do so very slowly. An average growth rate of only about 1 to 2 millimeters per year has been reported, and that's, I think, even tough to pick up, whether our measurement accuracy is even that good. But the main point is that dermoids, if they grow, tend to do so very slowly, and you would, of course, look for a change in morphology on follow-up too. Another appearance I just want to mention for dermoids is the fluid level. It's less common than the other appearances, other than perhaps the floating globules, which is pretty rare. This appearance is less common than the hyperechoic nodule or the dermoid mesh, but you may occasionally encounter it. Important thing about the fluid level in dermoids is what's been described as typical is that the non-dependent component, as in this, if it's the hyperechoic component, so if the non-dependent fluid is hyperechoic compared to the dependent fluid, that's what's predictive of a dermoid. Unfortunately, many dermoids that have a fluid level, it's often the opposite. The non-dependent fluid can be less echogenic, and in those cases, hemorrhagic cysts can do that too, so it becomes less useful. The fluid level, again, is uncommon. It's most helpful if the non-dependent area of fluid is the more echogenic fluid, as in this example. What about dermoids and malignancy? A small percentage of dermoids can also transform to malignancy. Is typically a squamous cell carcinoma. Not surprisingly, it tends to be larger masses, older patient. So what are the features that let you predict a malignant dermoid? It's actually not very clear. These branching structures that, if they're isoechoic rather than hyperechoic compared to the wall, have been reported as a feature to consider for malignancy. Obviously, if you saw invasion into adjacent organs, that would be concerning. Another feature that may be helpful is color power Doppler ultrasound, if you use it on the majority of dermoids, you typically don't see flow centrally, that is in the hyperechoic component or the dermoid mesh. You may see it peripherally in the wall, that's okay. But if you began to see flow in the hyperechoic central components, that would be more concerning. That's been reported uncommon in benign dermoids. So we'll look for that. If you saw flow centrally, it's not clear how predictive of malignancy that is, but I think it would be more concerning for malignancy. Again, peripheral flow only is okay for dermoids. So those are the four common benign masses that it's really important to know their sonographic features. We'll move on to ovarian neoplasms, now at least other neoplasms besides the dermoid. These are generally separated into four basic groups. The epithelial neoplasms, that's the most common, and that's the group that when we talk about ovarian cancer that most arise from. Then we've got the germ cell neoplasms. We've already talked about the dermoid, that's the most common one in that group. We've got the sex cord stromal neoplasms, and then the metastatic neoplasms. So for the epithelial group, most are going to be serous or mucinous or endometrioid cystadenomas or cystadenocarcinomas. At least the serous and mucinous can have a benign version, the cystadenoma. Then we've got the clear cell carcinoma, and the Brenner tumor is in this epithelial group. It's a less common tumor. Most of these epithelial neoplasms have a complex cystic appearance, that is, they have both cystic and solid components. There's also the borderline or low malignant potential group, which is malignant but has less stromal invasion. They may metastasize still, but these patients have a better prognosis than the frankly malignant tumors. Current thinking is that there's probably two types of epithelial ovarian cancer. They may actually arise outside the ovary. Type 1 is thought to have a more indolent course, earlier stage at diagnosis, and perhaps arises from precursor lesions such as endometriosis. The type 2 is the more aggressive form, more advanced stage typically at diagnosis, and may be the reason that screening has been difficult in some of the studies, that these have a very short lead time, develop rapidly and become advanced very quickly, and these actually may develop in the fallopian tube rather than the ovary itself. So what are the ultrasound features that make us most concerned for these malignant neoplasms, particularly that epithelial group? Well, it's a solid nodule that has blood flow by Doppler ultrasound, as in this patient who has a cystic mass. There's a septation, there's a lobular solid component, and there is blood flow within it. Just to mention one thing about blood flow, if you see a length of a vessel, as in this example, I think that's adequate for saying that there's flow in that solid tissue. If you only see a dot or two of color, that is a pixel or two of color, it's important, I think, that you put on spectral Doppler to make sure you see an arterial venous waveform. If it's just a couple of dots of color without seeing a distinct vessel, that could be noise. And since it's important to know whether there's blood flow detected in that solid area, just be careful when you don't see a distinct vessel and put on that spectral Doppler if it's only a few pixels of flow and see if you get a typical arterial or venous waveform. So again, the solid nodule with blood flow is the feature that's most concerning, has the highest likelihood for malignancy. Focal wall thickening, at least more than 3 millimeters, is considered similar to this as a solid component. The other thing that's concerning is thick septations or irregular septations. Here we have a cystic mass with a few septations that are a little over 3 millimeters. They're slightly irregular here, and this was also a malignant epithelial neoplasm, ovarian cancer. So these type lesions are pretty easy to characterize. We know they're very likely to be malignant. You really don't need to do any other imaging in most of these patients to characterize the mass. You may need to do other imaging such as CT for staging, but generally if it's got a solid component or thick irregular septations with blood flow, that's concerning enough for malignancy alone. What about the germ cell neoplasm group? We already talked about the dermoid or mature cystic teratoma. There are some rare subtypes such as the struma ovarii where thyroid tissue predominates. Those actually don't always have the typical dermoid look on ultrasound and may end up having a non-specific appearance. Dysgerminoma, yolk sac or endodermal sinus tumors are also in this group, as are embryonal cell and choriocarcinoma. Those are less frequent. The only other one we're going to mention today is the dysgerminoma. It's an uncommon malignant tumor, though generally a good prognosis. If you see a lobulated solid mass, pretty well-defined borders, it can have plenty of flow by Doppler in a younger patient, less than about 30 years old, that's a typical appearance of dysgerminoma. So I would consider that as a likely diagnosis if you encounter such a large solid mass in a younger patient. Obviously, the patient will probably still need histologic proof, but I would consider dysgerminoma as the most likely diagnosis in that instance. The sex cord stromal group also has several subtypes. These are the four most common. We'll talk about fibromas and thecomas. Granulosa cell we're really not going to go into. However, granulosa cell is the one that can secrete estrogen. Different tumors can secrete hormones, but the classic one that secretes estrogen is the granulosa cell tumor, and some patients also have endometrial abnormalities, including endometrial cancer, because of the high estrogen levels. In my experience, most of those are solid, though the literature would say that they can be both cystic and solid, particularly when larger. I'll just mention also the Sertoli Leydig cell tumor. Many of these small ones, or many are small solid masses, they can secrete androgens. This is the typical one that can cause virilization by secreting androgens in about a third of the cases. And these can be difficult to identify because they're small solid lesions. The main ones, the more common ones we're going to talk about in this group are the fibromas and the thecomas. They often coexist. The appearance is probably similar. So for the fibromas, these are benign neoplasms. They're most common in middle-aged, 40 to 50 to 60-year-old patients. They're typically solid, generally completely solid. They can be heterogeneous, as in this case, and be solid. They can be more homogeneous and solid. And also, a typical appearance is marked attenuation of sound. You can actually overlook the mass because you might think it's shadowing from bowel gas. But this occurs in a minority of fibromas, but it is pretty predictive when you see it. It's different from acoustic shadowing from, say, calcification or dermoid, because if you'll notice here, this acoustic shadowing, where is it coming from? Well, with calcification or a dermoid, you expect to see a hyperechoic area from which the acoustic shadowing originates. Here, it basically just looks like, if you will, a black hole. It just all of a sudden there's acoustic shadowing, there's no hyperechoic lead point, and that's a tip-off that you may be dealing with one of these fibromas that has marked attenuation of sound. And again, the thecomas can look similar. They often coexist histologically in the same mass. So this brings up another topic that it's important to know how to approach, and that's when you have a solid adnexal mass that is completely solid. If it's completely solid and ovarian in origin, you're probably dealing with the neoplasm, and in the appropriate age group, I'd think about the ovarian fibroma as the most likely cause. Now, some studies have suggested that solid masses increase the risk for malignancy. Part of the difficulty there is that in most of those studies, the definition of solid allowed for up to a 20% cystic component. So, and certainly, yes, some of those with the more cystic component have a higher chance of being malignant. In my experience, the completely solid mass, that is with no cystic component, particularly if you're dealing with a patient who's 40, 50 to perhaps 60 years old, the majority of those are going to be the benign fibroma. Admittedly, they'll still typically need surgical evaluation to confirm that, but I think the completely solid masses are often benign. So it's important to consider alternative diagnoses other than just an ovarian origin when you're faced with a patient who has a completely solid adnexal mass. What else do we consider? Well, pedunculated fibroids is the main one. Fibroids are just so common, and if they're pedunculated off the uterus, protruding out into the adnexa, they can simulate an ovarian mass. And this is particularly problematic if you cannot identify the ovary on the side of the solid adnexal mass. The thing that can be helpful here is to look for the vascular pedicle by Doppler ultrasound, connecting the mass to the uterus. Other things that I always like to consider before I attribute a solid adnexal mass as an ovarian cause is the subacute hemorrhagic cyst that we talked about earlier. It can simulate a solid mass, so just be suspicious in these younger patients where it looks solid and there's no flow detected in it. Think about that chronic endometrioma that might simulate a truly solid ovarian neoplasm, and MRI could be helpful in these patients. And this is an instance where if you're really unsure of the origin of the solid adnexal mass, that is particularly when you cannot find the ovary on that side by ultrasound, then MRI is often helpful. So here's a case, a solid adnexal mass, and this is an example of using a color Doppler to see that connecting vessel between the uterus and the mass, confirming that you're looking at the pedicle of a pedunculated fibroid. Because if you think about most pedunculated fibroids, do we see the pedicle with grayscale ultrasound? Typically not. You may occasionally, if you look hard and get a little bit lucky, you may find it in grayscale, but I think that color or power Doppler addition is what really helps you find the pedicle in a pedunculated fibroid and be confident of the diagnosis. If you don't see the connecting pedicle, it might still be a fibroid, maybe you just didn't find it, but you certainly would have to proceed then to either MRI or consider surgical evaluation if you cannot confirm that it's a pedunculated fibroid by ultrasound. The last general group of neoplasms to the ovary is the metastatic group. What are the most common primaries to metastasize to the ovary? Well, breast and GI tract are probably the biggest ones. With breast cancer, it's typically the patients with more advanced disease. Colon and stomach are also high up the list as primary sites that metastasize to the ovary. As we'll talk about in just a moment, many of these are thought to be solid masses. There's some evidence that mets from colon cancer are more likely to be cystic than other primary tumors. And then, of course, many primary tumors have been described. Breast, GI tract are the most common. Lymphoma, endometrial cancer have also been described. Can we really distinguish a primary from a metastatic neoplasm? It's not clear how good we are at that. A traditional teaching for many years is that solid and bilateral favors metastatic. It was certainly true in this patient who had a predominantly solid mass in the right ovary and the left. This was metastatic from gastric carcinoma. So in my experience, they often are solid and bilateral, but we know from the literature that's not always true. And in some cases, it will be difficult to know whether you're dealing with a primary or a metastatic lesion. Trying to find the primary cause may be helpful in those instances. So now we're going to move on to masses outside the ovary, because it's important when you see a mass in the adnexa to not assume it's coming from the ovary. Admittedly, most will come from the ovary, but if it's extra ovarian, we're going to be thinking about different causes. So always try to determine whether the mass you're looking at is truly coming from the ovary or not. Here's an example of a cyst. You can see a rim of ovary around it. Perhaps some would call this a claw sign, where you got this little rim or claw of ovarian tissue going around the edge. And so if we see that ovarian tissue around it, you could be confident it's coming from the ovary. And in the premenopausal patient, those small follicles in the ovarian parenchyma can help you. If it's not ovarian, sometimes it's obvious, as in this case. Here we've got an ovary with a follicle, a few of those insignificant echogenic foci. Here's this paraovarian cyst sitting off to the side. So sometimes it's easy, it's obvious that the lesion you're looking at is separate from the ovary. If it's not obviously coming from the ovary, it is important to try to tell its origin. You can use gentle transducer pressure with a transvaginal transducer, or your non-scanning hand on the patient's abdomen, and see if you can separate the lesion from the ovary. That can be helpful in some patients. If you don't find the ovary at all, then sometimes it is more difficult. I do think it's important to not only look transvaginally, but to look transabdominally, even without a full bladder, to at least look briefly, because sometimes the ovary is superiorly positioned in the pelvis, and you may only see it on transabdominal scanning. So when we're faced with an extra ovarian mass, what are the things we consider? Well, I've kind of put them into mostly cystic, mostly solid, and the more common and the less common. We're only going to talk about the more common ones. So for the mostly cystic extra ovarian mass, the more common lesions are the paraovarian cysts, hydrosalpinx, and the peritoneal inclusion cysts. The parovarian or paratubal, I'll use the term synonymously because we can't always tell the difference, but it's mainly you're seeing a simple cyst in the adnexa that's separate from the ovary. These are usually simple cysts, meet the same definition of a simple cyst we talked about earlier. And in this case, where it's just sitting right next to the ovary, it's an easy diagnosis to make. These are pretty common. Small ones we may overlook because of bowel gas, but these are generally of little to no significance. What about the hydrosalpinx? When do we suggest that diagnosis? Well, obviously a tubular shape, as in this case, an incomplete septation. The waist sign and these small nodules, also called beads on a string, have been described. So just to go back to this one, here's our tubular shape. This incomplete septation, it's not a true septation in most instances. It's really just the wall of the distended fallopian tube as it folds back on itself simulates an incomplete septation. It was originally reported as pathognomonic. It's since been found not to be. You can occasionally see these in other etiologies. But, in fact, if it's tubular shaped and has an incomplete septation, I think those frequently are hydrosalpinges. Another feature that's been described as perhaps one of the best signs is the so-called waist sign, and this refers to this indentation along opposite sides. It's like a waist. It kind of indents the cystic structure on opposite sides, and that's the waist sign, and that's a very useful feature for identifying hydrosalpinx also. So that tubular-shaped cystic mass with the waist sign, look for that. The other thing to be aware of with the hydrosalpinx is these small mural nodules. It's been called beads on a string. You know, here's a cystic mass, little nodules there. We'll see it here on the video clip on the same patient. This tubular-shaped mass, you see these little nodules along the wall here. If you did not recognize that this lesion was outside the ovary and you had these small nodules, you might confuse it for an ovarian neoplasm. But we know that hydrosalpinges can have these small nodules. They are thought to be due to the thickened endosalpingeal folds that become inflamed in the hydrosalpinx. So if you see these small nodules in what otherwise looks like a hydrosalpinx, that's okay. You don't have to be concerned about malignancy. Fallopian tube neoplasm is admittedly uncommon. It can have solid components. In my experience, they're typically larger solid components, not these tiny nodules along the wall. Peritoneal inclusion cyst, also been referred to as peritoneal pseudocysts. It's thought that you need two things to have one: a functioning ovary and adhesions. The most common risk factors for adhesions are surgery, endometriosis, and pelvic inflammatory disease. So the ultrasound features are it's typically a septated cystic mass, and you look for it extending around the ovary or the ovary suspended within it. They also frequently conform to the shape of adjacent structures. So here's a cystic mass, kind of a thick irregular septation on transabdominal scanning, but when we look transvaginally, you can actually see the ovary inside this cystic mass. And this was a peritoneal inclusion cyst in a patient with endometriosis. So always consider that option when I've got a septated cystic mass. They have risk factors for adhesions. Look and try to find that ovary somewhere within it, and that can help you make the diagnosis. Now, mostly solid extraovarian masses, we've already talked about this. Pedunculated fibroid is by far the most common entity that you'll deal with. Occasionally fibroids, as we know, can have cystic degeneration. You know, this one's solid, but here's one with cystic degeneration. This, if you didn't know the origin, would be very difficult to distinguish from ovarian carcinoma because admittedly it's got cystic components, irregular solid components. Whether fibroid or ovarian neoplasm, it could have flow. This was a pedunculated fibroid with cystic degeneration that simulated ovarian carcinoma. So just be aware of that. And again, try to look for that vascular pedicle that we looked at earlier. Admittedly, if it has cystic degeneration, that may be a little more problematic in making a confident diagnosis if you're not able to find the ipsilateral ovary. Now we're going to shift to cysts that have indeterminate features. We've talked about the benign features. We've talked about the malignant features. Occasionally there's cysts that are more problematic. And there's 4 general groups. 2 of them are less concerning. 2 of them are a little bit more concerning. The one that's less concerning is what I like to call the almost simple cyst, and that is it has one thin septation or it has a little calcification along the wall with nothing else. These we recommend following similar to simple cyst in the ovary. Occasionally you get these cysts that have some features that might look like a little bit like one of these benign ones that we talked about. For instance, it's a little hyperechoic here, but gee, am I really confident that's a dermoid? Or here's one, it's a little heterogeneous, and I'm thinking it has that reticular pattern of a hemorrhagic cyst, but it's not quite classic. So, these have features that make me think perhaps a dermoid, make me think perhaps a hemorrhagic cyst, but I'm not confident enough to be sure. And these are the ones that would probably follow up with ultrasound in 6 to 12 weeks, particularly in the premenopausal patient. If it persists unchanged in 6 to 12 weeks, then a hemorrhagic cyst is very unlikely, and I would do further evaluation at that time. The features that are a little more concerning and indeterminate are the multiple thin septations and the solid nodule, that is a non-hyperechoic solid nodule without flow. Then we think about neoplasm more, though usually benign neoplasms such as a cystadenofibroma. So here's an patient with multiple septations. There's different degrees of echogenicity in the various septations. That actually is typical of a mucinous cystadenoma. And another patient with a small solid nodule along the wall without detectable flow, and a patient with a cystadenofibroma. So these are features that are indeterminate, but again, probably are going to be benign, but we certainly can't be confident. We're going to have to do further evaluation or consider surgical evaluation. All right. And these recommendations were summarized in the report of the Adnexal Cyst Consensus Conference that was published in Radiology with Dr. Debbie Levine as the lead author. So those are available, and we keep those up in our reading room and refer to them frequently. A couple of miscellaneous lesions just to mention in closing. The tubovarian abscess and adnexal mass is unique to pregnancy. The tubovarian abscess, or TOA as it's often called, can really have a variety of appearances. There's typically nothing suggestive enough based on the ultrasound appearance alone. They have cystic and solid components, internal echoes, they can simulate a neoplasm, they can simulate a hemorrhagic cyst. One feature that may help you sonographically is if you see a tubular cystic component that would make you consider fallopian tube, that is a hydrosalpinx or a pyosalpinx because it's got internal echoes, that could suggest that you're dealing with a tubovarian abscess. Otherwise, the appearance again, is quite variable, and it's really the clinical setting of pelvic inflammatory disease that helps point to the correct diagnosis. So again, other than perhaps seeing a hydrosalpinx or pyosalpinx component, I think it's difficult to confidently diagnose a tubovarian abscess by ultrasound alone. You really need clinical information. I want to mention a few adnexal masses unique to pregnancy in closing. They're the thecalutean cyst, decidualized endometrioma, and the luteoma of pregnancy. The thecalutean cysts are typically bilateral, septated masses, multiple thin septations. It can simulate a multiloculated neoplasm. These basically occur with high serum beta-HCG levels. I think it's the bilateral nature and appearance of these when it occurs with a known association. And the most common associations are gestational trophoblastic disease. It's certainly the most common one we think about. Ovarian hyperstimulation and patients have undergone in vitro fertilization or other types of assisted reproductive techniques have a similar appearance. And then occasionally patients with multiple pregnancy or hydrops can also get these. That's sometimes referred to as hyperreactio luteinalis. It's a variably used term, but sometimes used when patients have these thecalutean cysts in the absence of trophoblastic disease and the absence of ovulation induction. Decidualized endometrioma is uncommon, but certainly important to consider as it can simulate malignancy. It's typically cystic with a solid component. We have the patient with an endometrioma that has the ectopic endometrial tissue in it, and when they're pregnant, the endometrial tissue can grow and appear similar to the solid component of a neoplasm. Here's a patient, it has that homogeneous echoes like many endometriomas do, but this has got a kind of lobulated, irregular, solid component, has some blood flow in it, so we would have to be concerned about malignancy in a patient like this. But she's pregnant and she has known endometriosis, and this actually was a decidualized endometrioma. That was past proven, ended up being removed. But can you make a confident diagnosis so that the patient can avoid surgery? It can be challenging. Doppler imaging probably isn't reliable, as the visualized endometrioma can have flow in the solid areas. It doesn't necessarily mean it's malignant. I think the reasons to suspect this diagnosis are if the patient has known endometriosis, particularly a known endometrioma, no other features of malignancy, and if on follow-up, it doesn't change, or they'll occasionally decrease in size, that's also suggestive. But admittedly, this just requires a high index of suspicion and can be difficult to make a confident diagnosis in these patients, but you should at least consider it, particularly when the patient has known endometriosis. Can MRI help? Perhaps it may show other features typical of an endometrioma. There's been some suggestion that the signal intensity of the solid parts similar to endometrium. That's supportive. We're probably not going to give gadolinium during pregnancy. So the MRI can give you some at least supportive evidence, but again, it's going to be difficult to make a confident diagnosis. Lastly, the luteolum of pregnancy is a very rare lesion. There's really no specific ultrasound appearance, though it's typically solid. The tip-off here is maternal virilization, that if you have hirsutism, elevated androgens, that's typical of luteolum of pregnancy. So it's really not so much the imaging appearance, but the associated clinical finding of maternal virilization that suggests luteolum of pregnancy. So just to sum up, I think that the key points are that it's important to understand what's normal and not to consider it a cyst or mass, and that gets back to what we call a follicle or corpus luteum. Please don't call it a cyst. When you're faced with an adnexal mass, don't assume it's ovarian. Really try to determine whether it's arising from the ovary or is extra-ovarian in origin, because that will certainly change your differential diagnosis. It's important to know the common ultrasound appearances of these benign lesions, the four I mentioned, the simple cyst, the hemorrhagic cyst, the endometrioma, and the dermoid, because those are the most common lesions you're likely to encounter, and they frequently have one of those typical appearances. And then lastly, the cystic mass that has a solid component with flow is the most predictive feature for malignancy. Thank you.
I'm Dr. Oksana Baltarowicz from Jefferson Ultrasound Research and Education Institute at Thomas Jefferson University in Philadelphia, and I'll be speaking about the sonography of uterine myometrial disorders. The objectives of this talk are for you to be able to list the sonographic findings suggestive of adenomyosis, to explain the common sonographic manifestations of uterine myomata, and to describe mechanisms for uncommon sonographic presentations of uterine myomata. First of all, let's start by reviewing the layers of the myometrium. The highest echogenicity is that of the endometrium. Right around it is a hypoechoic band, which is a thick band of compact hypoechoic inner myometrium. So that's the first layer of it's not the basal layer of the endometrium, it's the myometrial layer. Then comes the thickest part of the myometrium where the muscle is. It's moderately echogenic and where various circular and longitudinal muscle is located. Then comes a fairly thin outer layer, which is pretty much isoechoic with the intermediate layer, maybe slightly less echogenic, and you'll see vessels in between layer 2 and 3. And those vessels between layer 2 and 3 are the arcuate arteries and veins. Basically, there's really no visible vessels within the intermediate layer. Now, these arcuate vessels are located approximately 5 millimeters under the serosal surface of the uterus. As we can see here, the vessels come in along the lateral aspects of the uterus, come around the periphery, and send branches into the myometrium. Now, these vessels can be very prominent in some patients, especially the veins. They can be as prominent as in this patient, but this is still normal in women of childbearing years. These vessels are sometimes serpentine, very tortuous. They're tubular, fluid-filled structures that go along the periphery of the intermediate layer. Here's an example of a large vein coming across, and we can Doppler do a spectral tracing on it, proving that it is a venous structure. Now, the arteries, I mention these because the arcuate arteries are also located in there, and eventually they may calcify in older patients. And then they become hyperechoic foci, some with shadowing, some don't really shadow because they're very fine calcifications. And they really represent cystic medial necrosis, or this pathologically speaking Monckeberg sclerosis. So these dystrophic vascular calcifications represent the location of the arteries. And when we see these, they're usually postmenopausal women, so it's not unusual to see it. It is more common with diabetes and hypertension, although that's not to say that a patient who has these does have diabetes or hypertension. So just so that you are familiar with the distribution, 5 millimeters under the serosal surface echogenic foci. Now, sometimes the calcium is dense enough that it can cause acoustical shadowing, and that may actually cause so much attenuation, shadowing, that it may actually obscure the endometrial cavity line, and sometimes may even fool you and simulate a hydrometrium. This patient, you can still barely make out this endometrial line, but in some patients it looks like a hypoechoic center and should not be mistaken for a hydrometrium. Another little technical point about the myometrium is that sometimes you will see increased echogenicity within the myometrium, but you should make note, is it behind secretory endometrium? So when the secretory phase is present, these little glands fill with mucus. There's increased water content that then increases sound transmission and may make this posterior myometrium look hyperechoic. So that's just an artifact and should not be taken for pathology. We have little tiny so-called myometrial ditzels, the little tiny abnormalities in the myometrium, which really are clinically insignificant. Some of them have some pathologic significance, but you may see tiny punctate echodensities throughout the various layers of the myometrium. Most of the time we don't even know exactly what they come from. Sometimes we do think we know a specific cause for them, but here are some examples. This is probably along the inner layer. Here's a little clump of echogenic foci. Here's a little tiny calcification with shadowing. Here again, echogenic foci along the edge of the inner, the hypoechoic zone and around here. Now sometimes, and this has been proven pathologically, that this represents, quote, placental site nodules, which are these little focal echodensities at the endometrial-myometrial junction. They probably represent the site of a prior pregnancy implantation. When these were evaluated, the only thing they found in common was that the women had at least one pregnancy. This, if you look under the microscope, it's a benign lesion of intermediate trophoblast. Now, as soon as I say trophoblast, you're not supposed to think of potential for gestational trophoblastic disease or malignancy or anything like that. This is just how pathologists classify it. There have been no reports of this degenerating. Microscopically, they are well circumscribed nodules, and that's why we call them ditzels, because it's just a little collection of things. Sometimes these little ditzels are actually small fibroids, and these three examples here of old calcified involuted fibroids common in postmenopausal women. We can see scars. The first three here are representatives of cesarean section scars. That's in the lower uterine segment. Often you can see a puckering of the anterior contour and associated with some type of triangular defect. In this case, it's echogenic. In this case, possibly calcified. And here is a small cystic changes. So you will see a variety of appearances, sometimes just a fluid-filled cavity. One should pay attention to the thickness of the covering myometrium. If you see that it's extremely thin, that would be worth reporting to the clinician. And this is the site where ectopic pregnancies sometimes like to set up households. So that covering of myometrium, if it's extremely thin, that could be the site of a dehiscence. Here is another myometrial scar. This woman had a myomectomy, had a hysteroscopic removal of a fibroid, and an area, a small little scar calcified in her uterus. Here's a sonohysterogram that shows us filling of a myomectomy defect, sort of almost a diverticulum that comes off of the endometrial cavity. This has been described in the literature. Here's another patient who had had a surgical myomectomy and developed a hematoma and eventually an area of scarring within the myometrium. By the way, there have been reports of ectopic pregnancies establishing implantation in some of these sites as well. We used to think that it was impossible to have a pregnancy within the myometrium, but now with all these surgical procedures, it is actually possible. Now, sometimes the clinician may ask us to evaluate the uterus prior to endometrial ablation. What they're asking us to do is to comment on the myometrial thickness. They would like to have, or they need to have, more than 10 millimeter thickness of myometrium. So they're going to ask us to measure the thinnest myometrium, because if the myometrium is too thin, they will not be able to do the procedure. Because as they go into the endometrial cavity and wave around their instrument, which could be a number of different ways. It could be a laser beam. They can use thermal destruction, electrical destruction, freezing, microwaving of the endometrium. So whatever they use, that can actually penetrate, heat, or damage something beyond and cause further problems. So they want to have a nice thick covering of myometrium. So our job will be to measure the thinnest parts, not the thickest. So here would be the thinnest, not this thick part. Also make note of scars. So if there's a C-section scar, they will not be able to do that because of penetrating damage. A major area of abnormality in the uterus is adenomyosis. So I'd like to address this at this time. This is a common gynecologic disorder that affects premenopausal women. Usually these women are over 30 years of age. They've had pregnancies. Sometimes they're postmenopausal women. And the symptoms are variable, which include menorrhagia, dysmenorrhea, dyspareunia, pelvic tenderness, sometimes extremely serious to the point of being debilitating, that during the menstrual cycle the woman is incapacitated for a couple days and almost can't work. So it is a serious condition for some, and the prevalence varies. You can find different series. Look at this range. They range on surgical series from 5 to 70%, postmortem series, 10 to 50%. When you look at pathologic specimens, very often there will be a line saying adenomyosis present. So it can be present in small amounts or larger amounts. It's quite prevalent. It's a difficult diagnosis for us to make. It's an underdiagnosed condition in women. We are more and more aware of this and looking for better ways of diagnosing this. Years ago, this was not even a sonographic diagnosis until we developed better equipment, higher frequency, higher resolution, transvaginal scanning. We were able to start seeing things. And you always have to remember that you see what you know. So once we knew about it, we start looking for it. It is operator dependent. You have to do careful, meticulous scanning and using higher resolution. MRI has helped a lot in this diagnosis and certainly is a way to correlate and also heightened awareness among patients, clinicians, and diagnostic imagers. What is this adenomyosis? Well, this is actually ectopic endometrial glands and stroma that has gone backward into the myometrium, and as it has developed a focal site, it also has surrounding smooth muscle hyperplasia or hypertrophy around it. So there's two things that go with it. It's glands and stroma, and it's in the myometrium, so it's a focus of adenomyosis with adjacent smooth muscle hyperplasia hypertrophy. This can be in a diffuse form of foci scattered throughout the myometrium, and it can also be a focal, localized nodular aggregate that's called a focal adenomyoma. Sonographically, we're going to be looking for small echogenic foci islands, collections of heterotopic endometrial glands and stroma surrounded by this smooth muscle hyperplasia. And there are variable findings from solid to cystic areas, and we'll go through these. First of all, we may see asymmetrical wall thickening. Here we have a much thicker posterior wall than an anterior wall. Also notice that we have a fairly globular shaped uterus. This is the corresponding MRI scan, which shows us this markedly thickened posterior wall, these small little fluid areas, areas of bleeding. If you look carefully, you probably will see that there are little collections in this wall to correlate with the MRI. Another finding is heterogeneity. The echotexture of the myometrium is no longer homogeneous, but becomes more coarse. Here's another one that's globular, posterior wall is thick, but also notice this heterogeneity in the wall. The endometrial myometrial border may become indistinct to the point where you don't know where to measure it. Is this the endometrium? Should you measure it here? Should you measure it here? Where does it end exactly? So when you have that problem, you should think of possibility of adenomyosis. That can lead to this so-called pseudo-widening, where the endometrium looks too thick, and it's sometimes measured 2 to 3 centimeters, which, and the patient has no bleeding, particularly there's no evidence of a polyp, and that happens because you have these confluent echogenic abnormal areas. Sonohysterography becomes helpful in that case. So when you think there's endometrial thickening or you're not sure, the sonohysterogram can help us. So look at this uterus. Areas blend. We can't tell exactly where the endometrium ends. We put in a little bit of fluid, and we see that the endometrium is completely normal, and this is then the area involved with adenomyosis. Another finding is very thin shadows emanating from nowhere in the myometrium. You trace the shadows back, and there's nothing there. There's no calcification, there's no mass. So these are coming from these areas of smooth muscle hypertrophy or hyperplasia that are near these ectopic glands. So these kind of shadows. Now these thin shadows have been described with fibroids. So it's also possible you have to stand back and see, is this coming from a mass, a rounded area as it was in this large fibroid, or is this coming just from the wall with no evidence of a mass effect? Okay, another manifestation would be seeing subendometrial echogenic linear structures emanating out from the endometrium into the myometrium. Here, for example. So this is a track of adenomyosis going into the myometrium. Here, another representation. This patient had a lot of pain, and here she actually had 2 small tracts that we could find. Sometimes it's just rounded areas, these sort of hyperechoic echogenic type of nodules. You can imagine that that's a pocket of blood or endometrium in the wall. And multiple small hyperechoic kind of nodular distribution is another finding of adenomyosis. And notice here you're having difficulty delineating exactly where the endometrium is. Another not that well described finding is seeing through transmission, increased sound transmission. There are areas of shadowing, but sometimes you'll see hyperechoic kind of, these are actually reverberations, probably from a little cystic fluid area of bleeding in the myometrium. So that then leads us to subendometrial cysts. There can be actual cysts formed, and some papers in the literature have described that these are not visible until menses commences, and once the woman bleeds, then they turn cystic when fluid gets into them or blood. So that's a clue. So those are subendometrial, and here are myometrial cysts. Another finding, adenomyosis is the most common cause of myometrial cysts. Other findings in this patient, thickened posterior, in this case anterior wall, sorry, this is a retroverted uterus. So you have thickened wall, you have cystic changes, you have thin pencil-like shadows radiating, and a fairly globular appearance to this uterus. A pitfall here could be, at least for these myometrial cysts, could be a vessel. So in this case, it looks like a cyst, but remember, everything has to be confirmed in a 90-degree projection, and this is a patient I showed you earlier that has a huge arcuate vein underneath the outer layer. Here's a sonohysterogram where we actually filled a small cavity. At the beginning of the examination, there was no cystic change here at all. And as we introduced some fluid, eventually this area filled out. So this is a filling of this, there are cracks, so-called cracks in the myometrium, which were coined in an article that we had in 2009 showing that there are connections from the endometrium filling into these spaces. Also notice there are other changes of adenomyosis, thickened wall, shadowing from thin shadows emanating from the myometrium. The focal form of adenomyosis is an adenomyoma, which is this nodular aggregate of abnormality of adenomyosis. These should be differentiated from leiomyomas. They have ill-defined borders. They lack edge shadows because they're actually just abnormal tissue. They can be elliptical. They have very minimal mass effect. They do not calcify, and they have vessels coursing through them. That is in contrast to the myoma, which forms in the myometrium and pushes the normal myometrium around it. So I've contrasted this for you here. This is the features of adenomyomas, and here's a feature of leiomyomas. So the adenomyoma has poorly defined margins because it just blends with the myometrium, whereas the fibroid is rounded and has borders. The adenomyoma has mixed echogenicities, sometimes hard to even define it in the myometrium, whereas the leiomyoma can be hypoechoic to the myometrium, could be iso, could be hyperechoic. The adenomyoma has cystic areas, small cystic areas. Typically fibroids do not unless there's some degeneration. Vessels course through the adenomyoma. Vessels are displaced around a fibroid, which pushes them out to the periphery. No shadowing, except for these thin shadows once in a while, whereas fibroids have much more shadowing. The adenomyoma is tender. When you push with the uterus, fibroids tend not to be tender unless they've bled into themselves or become degenerated or become superinfected. All right, so now comes another very large area of myometrial sonography, and that is leiomyomata. Fibroids, myomas, myomata, those are the different words that we use, and we intermix them constantly. I think everybody pretty much knows the typical sonographic features of a fibroid. It's a round mass, heterogeneous, usually hypoechoic relative to myometrium. It tends to attenuate sound to the point of shadowing. It deforms the contour of the uterus, here in this case, lumpy, bumpy contour. Often they calcify, and usually they are multiple. Think of it as misery loves company. Well, when we describe this, we should actually try to pay more attention to describing the location of these myomas. It is very helpful for the clinician to know the precise location so that they can plan their surgery. So we should be using more precise terminology. Most fibroids start out intramural, of course, and a fibroid can be completely intramural. If the fibroid gets very large and abuts the mucosa and serosa, then it's a transmural fibroid with a small submucosal and subserosal component. That's important for the clinician because if you describe it that way, they know they're not going to be able to get this out hysteroscopically nor laparoscopically. They're probably going to have to do laparotomy to go in, remove it, and sew up the hole, or else there could be a uterine perforation if pregnancy forms, etc. Or they may try other methods of treatment. Submucous myomas can be so much covered by the mucosa that they can be completely intracavitary and polypoid. They look like a polyp, and they can be called pedunculated. They can be on a stalk. When you have pedunculated, there has to be a stalk there. So we would like to describe it. In this case, we should say that this is a fibroid which is over 50% submucosal, and the rest of it is intramural. And then if you tell the clinician there's a centimeter or 1.3 centimeter myometrial covering, then they know precisely they can go in hysteroscopically and take this out. If you describe a fibroid such as this one that has less than 50% submucosal component, but only has a very thin couple millimeter covering of myometrium, they will think twice about removing this hysteroscopically because the rate of perforation here would be quite high. They may want to use ultrasound during the procedure or may attempt something else. another therapy. Here are subserosal fibroids. So here's a fibroid that is more than 50% subserosal. The physician, then the gynecologist, will attempt this laparoscopically. It will not do hysteroscopic removal. And we can have a subserosal fibroid, it's covered with serosa, on a pedicle, on a stalk, so that's a pedunculated myoma. It's interesting that there can be cervical myomas. There have been vaginal leiomyomas described, tubal leiomyomas, and that's actually not surprising because these originate from smooth muscle. So wherever you have smooth muscle, that's where you can have a leiomyoma. Let's look at some of these sonographically. So here we have a myoma that is predominantly intramural with a less than 50% submucosal component. And I would tell the clinician that there's a good centimeter of myoma around the periphery. And they can then plan the resection. Here is a fibroid that is more than 50% subserosal. And the distance, I could tell them the distance to the endometrial cavity, which is very reassuring. They would go in this and do this fibroid laparoscopically. Here's a myoma. It's intramural. With it just abuts the endometrium. It really does not protrude into the cavity, and it has about a centimeter of myometrium covering it. So this is an intramural leiomyoma. Here is a transmural. This is a transabdominal scan showing this uterus with this large fibroid that extends from serosa with a small submucosal component. So this is a transmural. Such a fibroid will not be removed laparoscopically nor hysteroscopically. When there are multiple myomas and the uterus is enlarged, this may be a candidate for uterine artery embolization, or if the woman is trying to preserve her fertility, so this may not be an operative approach at all. Here's a submucous myoma, or submucosal myoma, sometimes called. This is a myoma that is half or 50% submucosal and 50% intramural with a covering of myometrium. This was a patient who had had 3 spontaneous abortions, and once this was removed, she eventually became pregnant. So this was removed hysteroscopically. Now, sometimes you can't tell. There's a fibroid here. It's difficult to tell how much of it is really in the cavity. Is it in the cavity at all, or is it just displacing the cavity? And in that case, one wonders, is it maybe completely in the cavity? The cavity comes here, and then it splits, and then the myoma's in the cavity? Or is it one of these that just pushes the endometrium and is intramural? So a great way to look at this is to do a sonohysterogram. Put a little bit of fluid in the cavity, and there you have fluid surrounding it. This was one of these, a completely intracavitary myoma. Very useful information. Another patient, this is a postmenopausal woman who had had some bleeding, and she has this myoma. She had bigger fibroids during her life, but they were shrinking. And here's the endometrial cavity. So the question is this submucosal? How much of it is submucosal? How much of it is really intramural? What can they do about this? Sonohysterogram helps us. Fluid delineates the cavity, and the myoma is seen to be completely transmural and with no submucosal component. So endometrium is cleared, and this patient's myoma is hopefully going to regress some more. Another one here, what is the submucosal intramural component? The sonohysterogram shows that about half of it is submucosal and the other half is intramural, and there is a good thick covering of myometrium. So this could be removed hysteroscopically. It is known that submucosal myomas do cause pregnancy problems. There are histories of recurrent miscarriages, premature labor, abnormal presentations. There are various complications of labor, so these are very important for the clinician to know about. Now, when the submucous myoma is on a stalk, that sets up a predisposition to a torsion of this myoma, and that can lead to a painful episode, necrosis, bleeding, etc., and the rest of the story you can imagine from this wonderful drawing of Dr. Netter. They can also prolapse. They prolapse out through the cervix, and here's transvaginal representation. Here's the cervix. Here's the anterocervical wall. This is the posterior cervical wall. Internal os is about here, and the fibroid bulges out through the external os. And color Doppler adds a very important piece of information that there's a thick vascular stalk feeding this fibroid. We can alert the clinician then that there could be excessive bleeding during the surgical removal. Now you could say, well, why do you have to do transvaginal sonography if the clinician can see this from a pelvic exam? Well, you certainly want to know what else is going on in this patient, and sometimes lately we find that our emergency rooms are just sending patients to us for whatever reason that they come without having a pelvic exam prior to the ultrasound. So this can be completely unexpected. And that is one of the reasons why the cervix has to be looked at separately from the rest of the corpus, because you could easily miss this protrusion if you do not include the entire cervix in your transvaginal image. The prolapsing submucous myoma can be, especially the ones coming from the fundal part of the uterus, if they're fairly big and on a thick stalk, they can, as they protrude, they can actually pull the soft uterus with it and cause an inversion. And here it protrudes out the vaginal introitus. And look what happens. I'll back that up again. This is the serosal lining. This is the endometrial lining. So as it pulls out, this is the exposed endometrium, and the serosal surface is now in here. So this can be quite a problem, can invert and pull a considerable amount of uterus with it. Subserosal myomas tend to be removed laparoscopically, so we have to tell them the percentage. In this case, over 50% of this myoma is subserosal. In this case here, it protrudes from the entire lateral wall, and one would have to think about this, how much of the wall would be exposed if this was removed. Perhaps this has to be converted into a laparotomy for surgical removal. When a subserosal myoma becomes very large, usually about over 8 centimeters in size, then it's usually removed by laparotomy. Subserosal myomas can be pedunculated. Now this is if they are on a stalk. So what is a pedicle? What exactly do we have to have? That's difficult to define, and many gynecologists don't exactly know when to call it a pedunculated myoma, but I have seen in the literature description that the diameter of the pedicle is, when it's less than 50% of the diameter of the myoma, then that's considered a stalk, a broad-based or thin stalk, whatever. This patient, these patients with these pedunculated myomas are considered not good candidates for uterine artery embolizations because they then may necrose and slough off the uterus and cause abdominal symptoms. Now, another problem with these is that if you do transvaginal sonography alone, you may only include the entire uterus, but cut off this large mass that's protruding from the fundus. So that's a pitfall of transvaginal sonography, such as here. Here we fit in the uterus, pretty much, not even the cervix, but there was a pedunculated myoma here attached. It was completely cut off the image. So if one has the transabdominal image first, it is very helpful then with your transvaginal exam. Now some of these pedicles, these stalks, can be very thin and long. Years ago, and this is many years ago, in the days of static scanning, and I often like to throw in a static scan just to remind us of the history of ultrasound, how far we've come with our technology. But this woman had a mass that wandered around her abdomen and pelvis. It was a solid mass that kept moving around. And one day she developed severe pain. They opened her up. It was a torsed pedunculated myoma on a very long stalk. So one day it just twisted somehow on its pedicle and necrosed. So this was kind of a wandering myoma, kind of similar to a wandering spleen, if you've ever heard of those. Now, the diagnosis of pedunculated myoma has to be made with caution because this is a solid mass adjacent to the uterus, and it could be an ovarian tumor. So it is crucial, before we call a pedunculated myoma, to find a separate ovary. Once we do this, we can then study the relationship of this solid mass to the uterus. One thing is to look for feeding vessels. The vessels coming through the stalk, these can be confirmed with color. Here in this case, this was the uterus. This is a pedunculated myoma. There was a separate ovary, and now we confirm that the blood supply to this mass is coming from the uterus. Masses are, if you don't know an origin of a mass, it's very helpful many times to find what vessel is feeding it, and that helps you sometimes define the origin. We know this from CT, for example. If there's a pelvic mass and we can trace the gonadal vessel, the ovarian vessels to that mass, then it's most likely of ovarian origin. It's a fairly good assessment. So in this case, we have vessels crossing through that vascular stalk, which then sets it up for possibility of a torsion. So if a patient has a known myoma and then one day comes in with severe pain, certainly you have to think of torsion. This lady came in with pain and didn't know she had one, but this is a solid mass, very solid, intimately related to the uterine wall. Ovaries were separate. There was no blood flow in this mass, very tender. Patient goes to surgery, and it is a torsed pedunculated myoma. Another patient, large myoma, no internal flow, now it's extremely tender, has to go to surgery. It's a torsed myoma. Sometimes the subserosal myomas have such a broad connection to the surface of the uterus that we have to provide this information to the gynecologist so they can plan, again, their surgery. Now look at this uterus. Here's the uterus. The ovary was separate and arising from the entire anterior wall with large feeding vessels, confirmed here with Doppler, feeding this huge mass. Something like this cannot be removed from the entire wall with so many vessels to deal with. Now, fibroids can undergo some secondary changes of degeneration, and there are various types of degeneration. There's hyaline degeneration, calcific degeneration, cystic degeneration, there's even fatty degeneration, and rare, but it's possible, sarcomatous degeneration, which happens in less than 1% myomas, and there's so many myomas, you can imagine that you might encounter one or two in your lifetime. So that's degeneration. They can necrose, outgrow their blood supply. They can have internal hemorrhage. They can become superinfected. So take the standard myoma and superimpose these changes. Now things start to get a little bit interesting. Hyaline degeneration is the most common type of degeneration. That's actually a pathologic kind of a diagnosis. We can't really make that diagnosis from sonography. It occurs typically at the center of the tumor because of the poor blood supply, and the smooth muscle whorls are replaced by homogeneous hyaline material. They stain that pink on their slides in pathology. And the tumor just becomes kind of soft, and patient can experience a dull pain. So it's not really a sonographic diagnosis, but I am showing you one that is here pathologically proven. Tends to be a bit echogenic. So sometimes they can be hyperechoic. They can liquefy and develop cystic change on top of that. Basically are removed only based on symptoms. Now, calcific degeneration is the it's a late result of vascular impairment. The fibroid becomes calcified and slowly involutes. And here are some different patterns. Here's kind of a peripheral calcification with a lot of attenuation. Here's sort of a tip of the iceberg appearance where you only see the top part with dense, strong shadowing, very few reverberations. And here a speckled kind of a pattern, the pattern of the so-called popcorn calcification. Cystic degeneration obviously shows a cystic change, again, the result of outgrowing a blood supply. And this can be a mimicker of a number of things. In this case, there was a pregnancy, and we thought there was a twin pregnancy, but it turned out that this was a cystic degeneration in a myoma, which fooled us. There's fatty degeneration. Fat is hyperechoic on sonography, and here's a couple examples of a hyperechoic change with acoustical shadowing, at least in that case. Now, there are a few types of fatty tumors in the uterus, so I want to just quickly talk about these for a second. When you see a hyperechoic mass, and you can prove it on CT that it's fat, this could be fatty degeneration in a myoma. It could be a so-called lipoleiomyoma with lipo and myo elements. It could be an actual pure lipoma. Could be a fibromyolipoma with fibrous myo and lipo elements, and myolipoma, any kind of combination that you can think of with the lipoma. A lipoleiomyoma is a rare benign tumor that contains fat. It's usually asymptomatic. It's not a surgical lesion. It does not degenerate into anything sarcomatous. It has mixtures of fat, smooth muscle, and fibrous tissue. It's highly echogenic. It attenuates sound. It kind of reminds you of what a dermoid looks like. Also reminds you of what an AML looks like in the kidney, angiomyolipoma, because that has fat in it. So there's fat with attenuation. And you can confirm this with CT or MR, and it's a benign condition, does not need to be removed. The only thing is you have to be sure that that's actually in the uterus and not, for example, an adnexal mass such as a dermoid. Here are a couple more examples. Hyperechoic mass with areas of sound attenuation. Here's another one, homogeneous hyperechoic with sound attenuation. Hyperechoic mass, here's a more complicated one, more mixed kind of a pattern, probably has more myomatous and fibrous kind of elements inside. The worst tumor that can occur in the myometrium is the leiomyosarcoma. It's very rare. It may arise de novo, or it can arise in a pre-existing myoma. It's indistinguishable from a leiomyoma. So the only thing that we have to go on is that there's symptoms, there's pain, there's bleeding, and there's rapid growth of a mass in the uterus, and changes in a postmenopausal woman. Postmenopausal women tend to shrink their myomas. If it's a postmenopausal woman and the myoma is getting larger or the myoma is degenerating, then one has to consider the presence of a leiomyosarcoma. They're locally invasive, and of course they metastasize. This is a leiomyosarcoma that occurred in a 22-year-old woman. She was nulliparous and went to see the doctor. Her uterus was enlarged and was told she has a fibroid. She was not followed, and the fibroid kept growing and growing, and eventually she came back. Diagnosis was made of a leiomyosarcoma. This is more typical of the presentation, a 68-year-old postmenopausal woman with a kind of a mixed pattern of a fibroid that was enlarging. Close follow-up is very important in these patients. Another example here, this was a 60-some-year-old woman with bleeding and a very heterogeneous kind of mass, cystic and solid elements in the myometrium, invading now the endometrium, and this was a leiomyosarcoma. This is in the differential endometrial sarcoma. Can look very much like a leiomyosarcoma. This is an unusual situation. The tumor begins in the endometrium, and this pathology in this patient revealed a high-grade sarcoma originating in the endometrium, and it invaded completely through the wall of the myometrium. So this was very difficult. At first we thought this was going to be a leiomyosarcoma because the bulk of it looked like it was in the wall. So that's kind of, in the back of your mind, an unusual tumor to differentiate, or at least not be surprised at the final impression of the pathologist. Now, more of these changes. We talked about these up here ending with sarcomatous degenerate. Now let's talk about necrosis, hemorrhage, infection. A fibroid can become superinfected. In that case, it's called a pyomyoma. You may see, of course, the patient will have a fever and there will be tenderness, but you may see bright reflectors that shadow that look like gas, and gas is gas. You can confirm this with a CT scan showing these gas bubbles. The way the bacteria get in is usually through a submucous myoma that's prone to infection. This, if not treated, can lead to sepsis and can become an extremely difficult situation to treat. And this has to be differentiated from necrosis. Now, necrosis, I've seen cases where the myoma outgrew its blood supply and actually had air or gas in it, some release, maybe some type of nitrogen gas, whatever, but there was no pain. I'm sorry, there was no fever. There was pain, but there was no fever. And this sometimes occurs with pregnancy when a fibroid begins to grow and may have a very similar appearance on ultrasound. Now, take the solitary myoma, mix up some secondary changes, and make it pedunculated. Now you have a setup for some very atypical sonographic appearances. And that's why fibroids have been called the pelvic mimicker, because they can mimic normal or abnormal pelvic conditions in up to 5% of cases. So let's look at some of these atypical presentations that we should be aware of. They can mimic an ovarian mass. Now here we have a pedunculated myoma with cystic changes, and it looks like an adnexal mass with linear septations and fluid and some solid elements. So it's crucial in this case to find a separate ovary. Here are some more atypical myomas mimicking adnexal masses. Here's an ovarian, quote, mass with the septation. It's just a pedunculated myoma. Here is a pedunculated myoma, another one that had mostly cystic degeneration. Here it looked like perhaps a dermoid because it had some calcification. Here was one that was thought to be a large lymph node lateral to the uterus. All of these are pedunculated myomas. They can even mimic an endometrioma. This was a pedunculated myoma. It had vessels feeding it, but it was so homogeneous that it looked like an endometrioma. Here, this was a huge mass extending up to the xiphoid, and everybody thought it was going to be a large ovarian solid mass. Turned out to be a large pedunculated myoma. Here is a solid mass in the cul-de-sac. Thought it was going to be a fibroma, and it was a pedunculated myoma. They can mimic dermoids. These are the fatty containing lesions with sound attenuation, especially when it's pedunculated off in the adnexa. In this case, it was clearly in the wall and there was endometrium, so the sonohystogram helped us see that it was a myometrial mass, not an adnexal mass. Here's a myoma with tip of the iceberg mimicking a dermoid. Here's another one, sound attenuation mimicking a dermoid. Here's a myoma mimicking adenomyosis. Looks like a bulgy, thick, heterogeneous uterus, and it was filled with these little small myomas. This one had uterine enlargement, was thought to be a sarcoma, and turned out to be just an atypical myoma with some bleeding. They can mimic uterine anomalies. Here seems like a bi-lobed uterus. Here's an endometrium. Something in here looked like an endometrium. Surgery showed this was just a pedunculated myoma. Another one where it was thought to be a bicornuate uterus. One of these, and I can't even remember which one, was the myoma. Can mimic pregnancy. Large uterus with a big fibroid and a cystic space. Want to do a pregnancy test. Here's that case I showed you, a little embryo here. We thought there was a twin. No, this one stayed the same, was a degenerated myoma, and this pregnancy continued to grow. Here's another one that looked like a little gestational sac. They can mimic ectopic pregnancies. Now here are two different cases, both of which mimicked ectopics. In the adnexa, there was a mass with a hyperechoic rim and something that possibly looked like an embryo inside, except that the vascular pedicle sign showed up here, that we have the vascular pedicle feeding the mass instead of a sort of ring of fire around the mass. And the pregnancy test was negative. This was a myoma, partially pedunculated. Now here was another case, completely separate individual having a very similar appearance. The pregnancy test is negative. This was not a cornual ectopic, which it simulated, but it was just a degenerated myoma. They can mimic fetal heads. This is always fun when you find a fetus inside the uterus and then you see something that looks like a calcified head and you study it and it's actually within the myometrium. And there's no body to go with it. There's no spine. Here in this patient, it bulges out. These are calcified myomas and not some weird type of demised fetus. A couple other things at the end here. Uterine arteriovenous malformation, that occurs in the myometrium. This is a rare vascular lesion. It's a vascular plexus of arteries and veins with some arteriovenous shunting. There's no intervening capillary network, so the blood goes directly from an artery into a vein. This can happen after some type of trauma, surgery, after a pregnancy, after an abortion, a D&C. So most of them are acquired. A few of them could be congenital. These patients have abnormal heavy bleeding to the point where about 30% of them require transfusions. Now you have to make the diagnosis cautiously, because if you make this diagnosis, D&C is not indicated, because that in itself could cause massive hemorrhage. So surgery would not be the approach. It's a conservative management of this, and nowadays can be even embolized in interventional radiology. So what could we see with ultrasound? Well, the findings are not always specific. Usually you'll see some kind of inhomogeneity in the uterus. Sometimes you may recognize tortuous, tubular, serpiginous kind of structures. Turn on the color Doppler and you see lighting up and a very hypervascular area in the uterus. And you take a tracing with spectral Doppler, and that shows us high velocity but very low resistance waveform. So you have this venous flow, continuous, and you have these little superimposed arterial peaks. The color is intense. There's a mosaic pattern with aliasing, and one should attempt to take a peak systolic velocity. Now, this can mimic retained products of conception. It can mimic abnormal placentation, and gestational trophoblastic disease is in the differential. These patients, so of course a beta would be indicated, a beta HCG level. Now, what about differentiating it from a retained product of conception? Now, that's difficult. There is some information in the literature that tells us that if you do a peak systolic velocity on these vessels, and if it's low, less than 40 centimeters per second, then these are reportedly not requiring any kind of therapy. This is these regress spontaneously. But if you get very high velocity flow, then these are the real arteriovenous malformations that may require treatment, especially if they're bleeding. So I hope that I've given you a spectrum of various myometrial disorders, especially focusing on adenomyosis and unusual manifestations of uterine fibroids. Hopefully this will improve your diagnostic accuracy and lead to the correct diagnosis and subsequently the proper management of your patient. Thank you for your attention.
My name is Tom Winter. I'm from the University of Utah, and we're going to be talking about ultrasound of the endometrium. Okay, well, we're going to be talking about ultrasound of the endometrium here. This is downtown Salt Lake City. You can see the eastern front of the western front of the Rocky Mountains in the background right there. And we'll divide the talk up into several sections. We'll talk about why we worry, a little bit on terminology and technique, what's abnormal in 4 or 5 different clinical scenarios. We'll talk about abnormalities seen on transvaginal ultrasound, the utility of other diagnostic modalities, and then we'll have a talk within a talk discussing saline infusion sonohysterography. Now, I'm a big fan of quotes, and I like this one. I think this is very important in medicine, but this is a quote from Louis Pasteur talking about how in the fields of observation, which is our business, chance favors only the prepared mind. And then as a counterpoint to that, you think this could come out yesterday, but this was published over a century ago by Sir William Osler. I could never get into the medical school with the proposed new standards. So why did we worry? Rough rule of tens. About 10% of postmenopausal women will bleed. It's one of the most common indications for seeing a gynecologist in the United States.
Of the 10% of women who bleed, 10% of these women will have endometrial cancer. And then remember that even though we think of endometrial cancer as a disease of older women, 5 to 10% of endometrial cancer occur in women under the age of 50. It's the most common GYN malignancy, about 40,000 cases per year in the United States, and it's the fourth most common cancer in women, following only breast, lung, and colon cancer. But it makes up a minority of the cancer deaths, despite its prevalence, because it presents early and because we have reasonable treatments for it. And just to scare us all, this is a case from last month where you can see a 35-year-old patient, and on her ultrasound you can see this large echogenic mass filling the endometrial cavity, and on the MR it's invading almost to the serosa. So again, endometrial cancer is generally a disease of postmenopausal women, but there are exceptions. Now, in terms of the terminology, this took me years to figure out here, and you can look at the handout there, but kind of a generic term that's nice is just AUB, or abnormal uterine bleeding, that kind of covers all of the above subcategories there. John Wooden, the most famous basketball coach in history, had a great quote. He was a wonderful life coach, but he used to say, "Attention to the little details is the foundation of excellence." And I think that's totally important in medicine. So how do we measure the endometrium? It's a transvaginal measurement, obviously with an empty bladder. It's sagittal plane, it's the thickest portion, it's a double thickness measurement, so if there's fluid in the cavity you exclude it, and you have to visualize the entire endometrium. This is something that's often forgotten, but 5 to 10% of the time you're not going to see the entire endometrium, and that's totally okay. We want to test that when we say it's normal, we're 100% or close to 100% sure that it's normal. So up to 1 in 10 times, you're just going to say there's a fibroid, the uterus is in a funny position, I don't see the entire endometrium, so we need to do something else there. And so here's just an example from Ruth's wonderful paper on this, talking about obviously transvaginal ultrasound is better than transabdominal. You want to exclude the hypoechoic inner myometrium, the junctional zone there. So your measurement is only the hyperechoic center. And if there's fluid in the center, this kind of makes sense. Just exclude it, measure both walls and add them together. And then again, we have to see the entire endometrium. It's so easy just to find a white line, put graticules on either side of it and measure it. But here you can see in the top left image there, it looks normal. But as you sweep to the side sagittally, and in the bottom we see a cine sweep coronally right there, there is a stage 1 adenocarcinoma not seen on the initial images. And again, remember, 5 to 10% of the time the exam is indeterminate. You know, it's just hard to see things right there. So here's an example of a bunch of fibroids right there. Sure, you can find a little bit of endometrium and put cursors on it, but there was a stage 2B endometrial cancer hiding behind one of those fibroids there. And don't accept indistinct endometrial margins. Endometrial cancer can be infiltrating. And this example here is pretty obvious there, but you can see just this ill-defined gradient of tissue going off into the myometrium right there, and that turned out to be an endometrial cancer. Okay, now let's talk about what's abnormal, and we'll go into 4 different categories here. The first is premenopausal, and we have the different phases of the cycle right there. Rough limit there is 15 millimeters is the upper limits of normal, depending who you read right there. Here's just a tour through various stages of the endometrium. This could be a postmenopausal patient, but it turns out to be a 20-year-old on OCPs who's day 4, and the endometrium looks totally atrophic. Then we start to get into the proliferative or follicular phase. Those are synonyms there. And you start to see some architecture in the stripe. Then as we get closer to mid-cycle there, you get this trilaminar appearance to the stripe where you see 3 layers to it right there. These are 2 different patients here. Then as we move on into the luteal or secretory phase, we lose the trilaminar appearance, and instead we have just a thick homogeneous mass right there. And remember that in a premenopausal patient, 15 millimeters is not a perfect threshold right there. This is a 2.5 centimeter endometrium, but your GYN friends are going to laugh at you if you call this abnormal because she's 29 years old. She's totally asymptomatic with normal cycles, normal periods there. So one of the key things to learn from this is we always want to do all our non-emergent pelvic ultrasounds on day 5 to 10 of the menstrual cycle there, and then we won't run into these issues. So again, look at this one here. We have a lumpy, bumpy appearance to the endometrium. We do an SIS here, and you can see, kind of a lumpy, bumpy appearance there. But if you did this on day 5 to 10, it would be totally normal. The endometrium does not hypertrophy homogeneously. Instead, it hypertrophies in a lumpy, bumpy fashion. Second scenario, and by far and away the most important, is what should the endometrium look like in a post-menopausal patient with bleeding? And we use 5 millimeters, ACOG uses 4 millimeters. There's arguments back and forth somewhere in there. If there's a focal endometrial abnormality, that's abnormal though. So if it goes 1, 1, 1, 4.9, 4.9, 1, 1, 1, that's abnormal. An indistinct appearance of the lining as we saw before. And again, remember that this is going to be non-diagnostic in 5 to 10% of the cases. Remember that an abnormal test doesn't mean the woman has cancer. We don't want to scare grandma. If she comes in and is bleeding and her stripe is over 5 millimeters, it's incumbent on us to rule out cancer, but there are certainly a bazillion other causes that could give her bleeding right there. So bottom line, we just need to say you need to see a GYN and get another test there. Third scenario, postmenopausal bleeding on hormone replacement therapy there. Stay at 5 millimeters. Don't go to the 8 millimeter threshold that you see tossed around. There's no data to back that up. Bottom line, we're going to have a higher false positive rate, but again, we want specificity. We want a test that when we say it's negative, grandma does not have cancer there, and there are enough cancers in the 5 to 8 millimeter range that we don't want to use that, so just stay at 5 millimeters. And here's a 55-year-old on unopposed estrogen for 5 years after menopause, kind of against her doc's wishes there. And she had this 1.6 centimeter endometrium that turned out to be benign. So again, an abnormal ultrasound doesn't mean cancer. It just means we need to deal with it. Next scenario, this one's very controversial. Postmenopausal but not bleeding. How thick is too thick? So the most important thing to remember from this is that we are not advocating a screening program. Nobody out there is saying that we should offer asymptomatic women ultrasounds to look for endometrial cancer there. But what if you're doing it for a fibroid or for diverticulitis or for 50 million other reasons? This is probably the best paper out there, and it's a meta-analysis published by the group at UCSF, and they say over 11 millimeters offer biopsy. If you're postmenopausal but not bleeding, cancer risk is around 5% there. Again, you can argue all these things, but most of our gynoncs seem comfortable with that number right there. Okay, last scenario, tamoxifen there. This selective estrogen receptor modulator halves the risk of breast cancer recurrence, but it is an estrogen agonist in the uterus and an antagonist elsewhere, so it increases the risk of hyperplasia, polyps, and cancer. If you do the math, though, the number of lives saved from preventing breast cancer far outweighs the morbidity and mortality from endometrial cancer, so it's a good thing right there. Because it's an estrogen agonist in the endometrium, most women on estrogen, their endometrium looks abnormal. So bottom line here, don't ask, don't tell. We don't want to do ultrasound in patients on tamoxifen if they're asymptomatic, and then if they're bleeding, they're going to go ahead and do a DNC. And so here's just a patient who had a 16 millimeter cystic endometrium on tamoxifen, and these turned out just to be polyps and not cancer there. And most of the gynecologists, and certainly all the gynoncs, know this. They're not sending us ultrasounds in patients on tamoxifen who are asymptomatic there. But still, some of our mid-level providers are sending us these ultrasounds, and then we're kind of stuck because everything looks abnormal and we don't know what to do with it. So we just don't want to look. Here's another one right here with a classic tamoxifen endometrium appearance. And here's a big one. Look at this. It was 3 centimeters and then went up to 5 centimeters a year later. But when they finally got around to doing a DNC, this was just benign polyps here. So numeric summary, basically remember 5 millimeters. So if you're postmenopausal and bleeding, you're postmenopausal bleeding and on hormones, you're on tamoxifen, we're using 5 millimeters. The idea being that if it's less than 5, It's almost never going to be cancer. If it's over 5, it doesn't mean it's cancer, but we need to do something else. And then postmenopausal patients who aren't bleeding, we use 11 millimeters. And premenopausal, we use 1.5 centimeters, but take that with a grain of salt. Okay, so what are the abnormalities we can see on just routine transvaginal ultrasound? And number 1 is atrophy. 60% of the patients who come in with postmenopausal bleeding have atrophy. Remember, 10% of the postmenopausal population comes in with bleeding, and 60% of those are going to have atrophy, as we see here. Some are going to have polyps. Here's a nice transvaginal appearance of a polyp right there. This one's kind of cool. You can see the uterus kind of peristalsing, if you will, trying to push this polyp out here. There's the solitary vascular stalk heading into it there. And then fibroids, we've all seen a million of these, hypoechoic with that hyperechoic cap. And then endometrial cancer. She had intermittent spotting. This looks like a polyp here. And unfortunately, as you section this, it's benign, 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 cancer, benign, 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 benign. So there was an article in the Green Journal a couple years ago making the point that what we were taught in medical school, that polyps are always benign, is not true. And depending whether you're premenopausal or postmenopausal, there's a 2 to 4% risk that any polyp taken out will have a small focus of cancer in it. It's really not that big a deal because you're going to take the polyp out anyways because of the symptomatic issues there. And then here's another one, 58-year-old with heavy bleeding. And where is the endometrium? There's just no stripe there whatsoever. And in the operating room, nearly every surface of the endometrial cavity was involved with cancer. So endometrial cancer tends to be kind of big and bulky most of the time. Here's another one right here, an 83-year-old with vaginal bleeding. And you can see the endometrial thickness of however many millimeters that is right there. And there's cystic change in it, and this turned out to be endometrial cancer. What are the other diagnostic modalities that we compete with? Well, in the old days, we used to do hysterosalpingograms. The only time that we do them now is to assess tubal patency, fill and spill in the infertility population. But hysterosalpingograms are awful for the endometrium. Here are 2 different patients that we did. One of these turned out to be a polyp, one turned out to be a cancer. But it turns out that these have many false positives and many false negatives there. So a lot of women with true pathology have normal HSGs. Many women with masses like this turn out to have no cancer there. So this has gone the way of the dodo. Another technique is the dilatation and curettage, or as my mother-in-law called it, dust and clean. This is now only being used as a therapeutic modality. We're not doing this for diagnostic purposes anymore. And even when you're doing it therapeutically, you're only sampling a subset of the endometrium, so you can miss focal abnormalities, whether they're cancer or polyps. The diagnostic DNC has been replaced with the endometrial biopsy right here. There's a bazillion different types out there. This is pretty good for endometrial cancer. It's not perfect, but most papers say it has a pretty good sensitivity right there. But again, you're only sampling a small subset of the endometrium there. So in Lucy Hahn's study, you're only picking up 4% of proven polyps. So this is a good test, but not perfect for cancer. It's awful for focal benign abnormalities there, and it hurts more than an SIS. The gold standard is hysteroscopy. You can do this diagnostically in the office or in the operating room. In the office, there's about a 10% failure rate right there. You can, just like virtual colonoscopy, sometimes SIS is better diagnostically there, but obviously the advantage of hysteroscopy is that if you find something, you can do something about it there. So now let's move into a talk within a talk on saline infusion sonohysterography right here. We'll have an overview, we'll talk about technique, and then we'll have a whole bunch of examples in there. If you like etymology, there's a bazillion different terms for this right here, and it's kind of a hybridization of both Latin and Greek that means literally writing on the uterus with sound right there. Primacy is always difficult to determine in medicine, but the first study that I could find was about 30 years ago. And there's still quite a bit of literature on this. We've averaged about, 70 or 80 a year for the past 10 years right there. One of the most important points I want to make is that this is not a difficult study to perform. There was a really nice study where they compared nurse practitioners, second-year residents, fourth-year residents, and fellows, found no difference right there. So that's what makes this such a good test. You may have a test that works for somebody from Harvard who's brilliant and does nothing but ultrasound, but that's not going to help us in rural Montana trying to help, the 300 million or 200 million women in America right there. We need a test that works well in non-expert hands, and that's what this test is. Now, we're not going to talk about it, but remember to always do a conventional transvaginal ultrasound, look at the uterus for fibroids, look at the ovaries and all that stuff. And one point, particularly in this era of cost containment, that people bring up is SIS overkill. Is transvaginal ultrasound alone good enough? And here's an ultrasound MR and hysteroscopy on a fibroid in the uterus. Here's another one. It's maybe a little bit subtle, but there's an obvious endometrial mass right there. You put fluid in, and there's the endometrial polyp right there. So you might say, well, is it really good enough? Or is it too much? But look at this case right here. There's a sagittal midline view of the uterus on the left, and then here's a sweep through the uterus from left to right, showing you that I'm not cheating. I'm showing you everything right there. And I would never call anything on this test. But she was bleeding, and then let's go ahead and look right here, and there's an obvious polyp right there. So transvaginal ultrasound, we don't see anything right there. And then on SIS, obvious polyp. So the overwhelming bulk of the literature says that transvaginal ultrasound is not good enough. And just picking one paper kind of randomly from the list there, a quarter of the women with a normal transvag had an abnormal SIS. What are the indications? Basically anything whatsoever to do with the endometrium. Discordance is a big one here. Here's a woman who had perimenopausal with irregular bleeding. The stripe was 17 millimeters. Her endometrial biopsy was negative, but remember, endometrial biopsies have a 4% sensitivity for polyps. And then we do the SIS, and there's a 4 centimeter polyp in there. So our primary goal is to determine whether something is surgical or medical. Is it atrophy, or is there a focal bump that needs something right there? And although we're pretty good, we want to be careful about not getting too cocky about distinguishing malignant from benign disease. In terms of technique, if you like military metaphors for medical procedures, 4-star patent said a pint of sweat will save a gallon of blood. So preparation. Schedule the study between day 4 and 7 of the patient's cycle. Have the patient take some Motrin half an hour to a couple hours ahead of time. Be a nice person. There's some minor things that you want to think about. We don't do SISs with an IUD and all that, but take a look at our article there for details. And more recent data from the National Heart Association says that we don't need to prophylax for SBE. Okay, and why are we doing this day 4 to 7? Number one, you don't like to do this when the patient's pregnant. You lose style points right there. Number two, remember we said that we do the entire pelvis. We look at the uterus for fibroids and we look at the ovaries. And you're just not going to run into those funky little, hemorrhagic corpus luteum cysts that make you worry there. So Drs. Goldstein and Timur Trish, had a nice paper saying just schedule all your non-emergent studies day 4 to 7. Most importantly, you avoid the endometrial false positives that occur when you're scanning in the late secretory phase because the endometrium is lumpy bumpy. And here's an example. Look at this endometrium, totally lumpy bumpy. One of these could be a polyp or cancer, and then you bring her back and it's totally atrophic. This was a beautiful paper by M.J. O'Neill a few years back right there. So schedule days 5 to 10. Another issue, though, is that if somebody has abnormal bleeding, they may not know when their period is. And so your secretary's like, well, come back on day 5 to 10. And they're like, I don't know what day 5 to 10 is. But once you get the catheter in, here's 2 different patients. You can often find the blood clots, kind of beat them up with the Foley balloon, suck out the fluid, put in fresh fluid. So it takes you longer, but even when somebody's bleeding, you can get a diagnostic study. What are the risks? The main one that people experience is some cramping right there, just because you're distending the uterus, get a little bit of spotting, have some tampons and pads in the department that you can give patients to go home with. Very rare, knock on wood, I've never had one of these, but you can have an infection right there. If you have dilated tubes, you may want to put them on antibiotics there. Vasovagal reactions are rare, but they do occur, so please, when you inflate the fluid in the balloon, do it slowly. One very high theoretical concern is endometriosis, because one of the theories for that is retrograde menstruation. And here you're putting fluid into the endometrium and potentially knocking endometrial cells out retrograde into the peritoneal cavity. Another one is upstaging if you have endometrial cancer, because we're doing these in older women, many of whom have endometrial cancer. Are you seeding the cells right there? And this was a beautiful study right here where they put baggies on the end of the fallopian tube there and then infused did an HSG in the operating room before they did a hysterectomy and looked at the cells in the fallopian tubes. And bottom line, there were some malignant cells, but they weren't viable. So even though endometriosis and endometrial cancer are risks, they are not real risks right there. They're theoretical risks. So we go ahead and we have very good data historically and also this OR study showing that we're not upstaging endometrial cancer. Okay, equipment. Here's a tray that we put together, with some ring forceps, a tenaculum, some sounds, and all that kind of stuff. Like most things in life, it's the operator, not the equipment. This was a really nice study that looked at 6 different catheters and 600 plus women, so about 100 patients per arm of the study there. And bottom line, they all worked. The Foley catheter was the cheapest, but it was a little bit more difficult to use. The Goldstein, which is this one in the middle here, is relatively cheap, works pretty well. We use the dedicated HSG catheters, which is more or less just a modified Foley. You can see here it has a balloon on the end of it. If you have somebody that has a stenotic cervix, you can use the patent embryo transfer catheter, or just use a 5 French catheter over an 038 glide wire right there. Choose the correct speculum. For radiologists, I think this is very intimidating, just doing these exams here. So there are 2 different types of speculums, the Peterson and the Graves. The Peterson has a straight margin. The Graves is kind of like a duck's bill right there. Each one of these comes in small, medium, and large sizes there. A medium Peterson is a good all-purpose one there. I work at a state institution, so we really have no choice over what central supply sends up to us. If you work at a private place, you can get a little bit more fancy and get these lucite catheters that have the LED lights on the end that are made for this. They're really, really nice, but I basically never get to use those. For a large woman who's had a lot of kids, a large Graves catheter is a good choice. Insert the speculum correctly. This is from Bates' Guide to Physical Diagnosis there. Lubricate the speculum, warm it with your hands there, put gel on it right there. Have the patient perform a Valsalva, depress the perineal body posteriorly there, and go in at about a 45-degree angle, cheating posteriorly because the anterior vagina, where the urethra is more tender right there. So perineal pressure, come in 45 degrees, cheat posteriorly. So there we are going in. Then we turn it 90 degrees, and this is what it looks like from the side. And then we open it up, and this is what we want. We want this sight picture right here. Spend your time getting this shot. A lot of the flails that I've seen over the years are when people get a shot like this, and the internal os is down to the left and at the bottom there, and you think, oh, I can sneak the catheter around the corner. Sometimes you can, and sometimes it turns into a flail. So just get this shot where it's right in the center right there, and it's much easier to do. Okay, that's the hardest part of the exam. The second most difficult is getting the catheter through the cervix into the endometrial cavity. And if you're dealing with a 35-year-old who's had 8 kids vaginally, it's probably going to be easy. If you're dealing with a 90-year-old who's never had kids or only had C-sections, it's going to be hard right there. So what do you do with a stenotic cervix? Number one is you can use a sound. I always use the smallest sound, and remember, we are not sounding the uterus. You don't want to perforate the uterus. You just put this in a couple centimeters right there, and oftentimes all that's obstructing you is a little piece of saran wrap like stuff. So just putting in this sound an inch will kind of break that up, show you which way the cervix is going. Option number 2 is to use one of these specialized catheters. This is the patent embryo transfer. You can use a 5 French wire or 5 French catheter on an 038 there, but just slide it up. You know, you think, oh, I'm going to have a lot of leakage there, and you might, but you're generally only going to do this in the setting of a stenotic cervix, so you're probably not going to have much leakage. Number 3, you can use a tenaculum. I've got a lot of very good friends who are GYNs. They tell me, textbooks tell me, oh, the cervix doesn't have pain sensors, it just has pressure sensors. I can tell you that if this is done wrong, it hurts right there. So we're not doing surgery. What we want to do is put the tenaculum at the noon position on the cervix, because the blood vessels are at 3 o'clock and 9 o'clock, and we want to stay away from those. Just slowly go down 1 click, slowly pull it out a little bit right there, just enough to get the catheter in right there. And then the 4th thing is to quit. This is from the literature there. A gynecologist who does this day in and day out with office hysteroscopy and the benefit of a little midazolam fentanyl, which we don't have, is going to fail 10% of the time. So we don't want to torture patients. We want an easy procedure. And if it turns into a flail, just quit. We can always go ahead and do hysteroscopy. So here's just an example of that egg transfer catheter. We tried and tried, couldn't get anything through. So you use this skinny, slippery little thing, and it slides right in, and we get a diagnostic study. Again, don't jab the fundal endometrium upon catheter insertion right there. Slowly descend the balloon. Slowly infuse the saline right there so that it's nice and slow there. Because you don't want a vasovagal response. And then remember, those of you in the room old enough to have done barium enemas, remember that the last thing that you did on a double contrast barium enema was deflate the balloon and image the rectum to rule out a rectal polyp that was obscured by the balloon. We need to do the same thing here. So deflate the balloon and pull it out at the end to clear the lower uterine segment. Another option, this is from the literature on a paper on SISs, on HSGs, but think of inflating the balloon in the cervical canal there, as you can see here. Now this sounds kind of funny, but we actually did a paper and we had all these psychologists involved and we measured pain and everything. Turns out that this hurt less than inflating in the endometrium. We used less saline because we didn't have to do pull-out imaging. You're not obscuring the lower uterine segment. This works really well when you can't get the catheter all the way up into the endometrium, but you can get it far enough up into the cervix to gain purchase. The only downside is that 10% of the time, 1 in 10 times, the balloon's going to pop out and you have to put the speculum back in and do it again there. So I would say when you start out learning these, put the balloon in the endometrial cavity, but as you get better, just put it in the cervix. Failures, here's kind of a quick meta-analysis I did from the literature, and the numbers are all over the spectrum there, depending whether it's OB, whether it's radiology, whether the patient's postmenopausal or premenopausal. But bottom line, remember, a gynecologist fails 10% of the time. After you've done some of these and used some of the tricks that we talked about, you'll see that it's much, much easier there. You'll just learn little tricks. What are some false positives and problems? Air bubbles are the enemy of ultrasound. So here we can see an air bubble up towards the fundus of the endometrium. Balloon obscuring the lower uterine segment, so deflate the balloon. Grunge that looks like a mass. You see that thing on the back of the uterus there. So we deflated the balloon and then just kind of scooped it around and sucked the fluid out, put some new fluid in, and by the time we were done, we had a beautiful look at the endometrium right there. Again, blood clots. You start out here and you're like, wow, that's a polyp, that's cancer. But you spend 5 or 10 minutes putting fluid in, sucking it out, putting it in, sucking it out, and you get a nice normal study. Mechanical shearing of the endometrium. This has been called a pseudopolyp here. And you can see you put the catheter in, you made a little shelf in the endometrium, but bottom line, you should not be doing this study in somebody who's in the luteal phase. If you do everybody on day 5 to 10, you won't have an issue. Color Doppler, how much does it help? Classic teaching is 1 vessel's polyp, multiple vessels is fibroids. That works, but you can't take it to the bank. 3D, more and more of us are getting that there. In reality, all you really need is a cine clip. Just get a sweep sagittal, a sweep coronal, and you're done. But if you have 3D, by all means use it. Here's a second polyp right there that we missed on the initial 2D scan. You can do this, kind of CT type imaging right here and get the C-plane so pretty. Okay, and let's finish up in the last 15 minutes with pathology right here. So SIS and endometrial polyps there. Most polyps are homogeneous and they're hyperechoic, and they have a narrow base of attachment. Oftentimes they're multiple, so you want to describe to your GYN friends how many they are, where they are, what the base of attachment is, so they know how to snare them. Here's another one here, just a big polyp, totally looks like a polyp, but remember that literature talking about 2 to 4% of supposedly benign polyps will have a small focus of cancer in them, and this one had a grade 1 adenocarcinoma within the polyp. So our job is surgical versus medical. Here's another one right here, just a pretty polyp, again, homogeneous, hyperechoic. Here's another one. This looked like Pac-Man, that old video game on the left there. And as we go through, you can see the Pac-Man appearance. But this, again, turned out to be a benign endometrial polyp. Really pathognomonic appearance almost. And then again, remember the second polyp, they're multiple. Here the balloon is obscuring the lower uterine segment. When we deflate the balloon, we see the second polyp there. Fibroids, incredibly common right there. Nice New England Journal paper a couple weeks ago talking about the pathophysiology of these here. Like most things in life, there are these obscure staging systems, but all you need to remember is it more than half in or half out? Because if it's more in the endometrial cavity, like the grade 0 and the grade 1, you can take them out hysteroscopically. If it's more than half in the myometrium, you have to do surgery there. That's the information they want, and we're good at giving it to them. This is from MJ's paper. You can see the classic appearance of a fibroid with this cap of endometrium and then the hypoechoic fibroid underneath. Here's another one on the right, cap of endometrium. Here's another one here. Hopefully I'd call this, but on a bad day I might miss it. But then you do the SIS and it's totally obvious. You get that cap of endometrium around it there. And solitary vessel. Here's another one, cap of endometrium, hypoechoic. The vast majority of it's in the endometrial cavity. These are the easy ones to take out hysteroscopically. Here's another one. You can see it transvaginally there. You do the SIS though, you see the multiple blood vessels characteristic of a fibroid, the cap of endometrium. And again, it's almost all in the cavity, so it's amenable to hysteroscopic resection. Here's another one, classic appearance of this thin cap of hyperechoic endometrium on this exophytic fibroid. Now we're going to start moving along the spectrum toward cancer, and there's endometrial hyperplasia, which makes up about 6% of postmenopausal bleeding. And there's a spectrum of endometrial hyperplasia, from simple without atypia through a few steps to severe atypia, which is 1 step short of cancer. So here you can see at transvag, and then with the SIS, we have this kind of uniform, lumpy, bumpy appearance to the endometrium, and this turned out to be simple endometrial hyperplasia. Here's another one right here. There's a little bit of a polyp, but this turned out to be complex endometrial hyperplasia without atypia within the polyp, so surgical versus medical disease. Here's a flat plaque-like one in MJ's paper right there. This turned out to be mild atypia. And then finally, the point of this whole talk is getting to endometrial cancer. And again, this is the most common GYN cancer, the 4th most common cancer in women. They tend to be large and broad-based, is this from our study patient right here there. So here's a classic appearance of this irregular, lumpy, bumpy, partially cystic appearance taking up much of the endometrium. Here's another one with a malignant hematometros with a regular, lumpy, bumpy appearance to the lining. Here's another one coming in, and we may start, there's been a change in Europe. We've been asking the gynocs for years to do MR for these, and they haven't done them. They've just taken the OR. But there's a real sea change out there in Europe that's starting to hit in the U.S. The idea being, if we can say that there's only minimal invasion of the uterus, then the hysterectomy can be done at your local community hospital. But if there's major invasion of the uterus, then you may need to go see a gynoc with nodal dissection. So take a stab at grading depth of invasion on your SIS or transvaginal ultrasound there, but in reality, MR is going to be much better. Another thing to think about is incomplete distension right there. Think of linitis plastica and gastric cancer there, those of you old enough to have done upper GIs there. The cancer, whether it's a primary gastric or metastatic breast, infiltrates the lining of the stomach, and it's thick like a leather bottle, and you can't distend it. The same thing often happens in endometrial cancer. The lining gets stiff, and you start putting in fluid, and the fluid just heads out the fallopian tubes or back leaks around your balloon, out the os, but you can't distend it. And the odds ratio for cancer is almost an order of magnitude there, 7.3. Here's another example. We had the balloon in down low, and no matter how much we pushed here, we just couldn't distend this, and this whole thing up here turned out to be endometrial cancer. And then here's one of our study patients who obviously didn't complain of pain after we took her uterus out. But in this case, I put Kelly's on the fallopian tubes, inflated the balloon all the way in the endometrial cavity, and put in fluid as much as I could, and I could barely distend it. So think of this stiff endometrium as being a risk factor for infiltrating endometrial cancer. Here's another one. This looks totally like a polyp there, and at path it was benign, 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 benign. Papillary serous endometrial carcinoma, benign, 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 benign. And also notice here how we have the single feeding vessel, kind of the classic appearance for a polyp. Here's another one here. You look at this, and this is a classic example of lumpy, bumpy endometrium. I would call this endometrial cancer every single time, and this turned out to be metastatic breast cancer to the uterus. I've seen 4 cases of this now. Tamoxifen, again, don't ask, don't tell. We just don't want to look in these situations right here, but here you can see this weird-looking, mass in there. This turned out to have severe atypia in it, but we really don't even want to look because most patients on tamoxifen are going to look abnormal, and the bottom line is if they're not bleeding, we're not going to do anything. Here's another one. This turned out to be a polyp with carcinoma in situ. There's a whole nother area of using SISs for infertility right there. You can see the uterine fusion abnormality here. Here's a patient who'd had multiple prior DNCs. This was an Asherman's right there. And then one of the really cool areas coming up that people are talking about is the only time we're doing HSGs now is for our infertility patients right there to see if the tubes fill and spill, because HSG is awful for the endometrium. Well, what if we could get the information with SIS? We'll get a much better look at the endometrium, and then we're not going to get detailed morphology of the tubes. We're not going to see SIN. But if all we want to see is tubal fill and spill, why don't we inject a contrast agent? And these contrast agents range from the cheap, just grabbing 60 cc's of room air and injecting it, to expensive. They're kind of like barbershop shaving creams that have little bubbles in them, or you can use Definity or Levavist or whatever. So there's a lot of work looking at this now to save women the radiation and 2 procedures there. Retained products, again, we said indications are anything to do with the endometrium there. So if you have a bunch of transvages that are normal and you're worried about something, this is from MJ's paper showing RPOC. Intervention, that is the weakness of SIS. Hysteroscopy, you can deal with it. I've got a buddy who's an inventor. He's an REI doc, and he's kind of come up with these Rube Goldberg contraptions with different balloons and snares and all that. But again, this works in his hands, and even in his hands, he admits it's really hard. But for the rest of us, it's never going to work there. So bottom line, not a lot of luck with intervention there. You know, one thing that you can do if you're doing this for cancer there, or you think it's malignancy, you just suck the fluid out after you're done and send it for cytology. And there's a fair amount of recent work just talking about, you know, positive cytology in endometrial cancer there. Okay, how good is SIS? Basically, it's as good as diagnostic hysteroscopy under general anesthesia at detecting things. So it's like optical colonoscopy versus virtual colonoscopy. Virtual colonoscopy is probably better at finding significant lesions there, but the issue is you can't deal with them there. But, you know, as you do the math, you go through, here's one paper that said 2 out of 3 hysteroscopies can be avoided. SIS hurts less, requires less medical intervention, and is a lot cheaper than doing ambulatory office hysteroscopy. So here's what we talked about here. We talked about why we worry, terminology and technique, what's abnormal, abnormalities seen on transvaginal ultrasound, other diagnostic modalities like DNC and endometrial biopsy. Then we had a lecture within a lecture of saline infusion sonohysterography, really emphasizing technique and how to do it. And then we showed a whole bunch of different examples that can be elucidated by SIS. So the take-home points, how to measure it. Remember John Wooden's quote, attention to little details is the foundation of excellence. Less than 5 millimeters reliably excludes endometrial cancer in the postmenopausal patient with bleeding. Use 11 millimeters in the asymptomatic postmenopausal patient. Take-home point, SIS is easy to perform, has a short learning curve, works for all of us there. I don't think it's quite as easy as Tom Cruise and Katie Holmes right there, where you can buy an ultrasound machine and use it at home right there, but it's a really good test. And I'd like to thank these folks for the help with the talk, and we're all done.
When Beverly told me the topic, I said, I could have changed the title of this talk to, what else can I tell you about premenopausal ovaries you don't already know? And I thought, okay, well, it's always fun to review what you know, and hopefully you can all come to a consensus that you agree on the same things. So, to begin, the ovary. What a wonderful organ. I didn't realize it is the most active organ in the body, or one of the most active organs in the body, and those of us who image the ovary appreciate the fact that it has progressed so many changes over the years. And if things go well, you see the diagram on your right, exactly the way the follicles behave when they're predicted to rupture at 14 days. Most of them hopefully do, and some of them may take a few days plus or minus, but life goes on. Every month, this whole cycle is repeated. The ovary has a complex embryology and histology, and to look at the number of cells that make up the ovary, you can understand how the potential of each of those cells to form a tumor makes the ovary a big organ to monitor for possible tumors, malignancies, or benign tumors. Now, it also is a favorite site for metastasis from other organs, especially the breast, colon, and stomach in about 5 to 30% of cases. And those of us who have looked at this diagram about the great synchronicity between the pituitary, the ovaries, the endometrium, and the hormones that go up and down as scheduled, realize that things don't always go exactly the way you want them to go. And so we are there to look for the reasons why these things do not happen. And this is part of the excitement of imaging the ovary. Now, ultrasound, of course, is recognized as the modality to monitor all the changes in the ovary, especially transvaginal sonography. It has allowed us to not only directly evaluate the many ovarian functions, more than any other modern technique, it also allows us to morphologically evaluate the ovary as an organ. It has allowed us to offer more assisted conception therapy services, and for the first time, we can better understand the physiology and pathophysiology of ovarian blood flow because of transvaginal color Doppler. So I hope in the next 20 minutes or so I could go over this outline of presentation that I thought would be a good review for all of us in this room. And I will skip through the ovarian masses pretty quickly because I know you've seen all of them already. So when I lecture to my residents, I always show them this beautiful diagram from Dr. Netter's Ciba-Geigy collection. But I always preface it with, do not expect to find the ovaries in exactly the location that this drawing tells you, because that's not reality. Like, sure, you can find the left ovary maybe a little more in a higher position than the right, but always remember to look for the right ovary in the cul-de-sac, because they have the propensity to hide in there when you could not find them in the adnexal area that you've been scanning. But I thought this diagram settles you on what the relationship of the organs ideally should be in the pelvis, if things are ideal as this. But you sometimes forget that the ovaries are usually posterior to an anteverted, anteflexed uterus, and the ovarian ligament attaches the ovary to the uterus. The fallopian tubes are supposed to be right next door. You don't see the fallopian tubes until it fills up with some fluid or blood. But look at the relationship of the ovary to the ureter and the vessels that go along with it. This is a good diagram to remind us that pelvic pain is not always the problem of the ovary or the uterus. There are other things in the pelvis adjacent to the ovary and the uterus that can produce that symptom. Now, nature made sure that the ovary will always be supplied. So it gave it 2 blood supplies. One is from the ovarian arteries that directly come off the aorta, crosses the pelvic brim at the level of the common iliac artery, and then enters the suspensory ligament to get into the ovary. The second one is the ovarian branch of the uterine artery that anastomoses with the ovarian artery from the aorta to provide the ovary with the blood supply it needs to carry on its function. Now, I'm not going to go through these ovarian volumes, but as you can see in a premenopausal woman, the ovary can go up to about 22 cc's maximum and still be normal, but on the average, I think it's about 11 to 12 cc's using the formula of the ellipse to compute ovarian volumes. Now, technically, the ovary is really part of the adnexa, but we don't just lump it with the adnexa. We always say the ovary and the adnexa, because we want to underline how important its function is compared to all the other things that belong to the adnexa. When we look for the ovaries, especially in patients who are a little challenging to image, we always use the external iliac vein or the internal iliac artery as our landmarks to say that this is where the ovaries should be, because they form the borders of the ovary when we try to find them. So yeah, we are one of the few people who image our ovaries this way, but we also read from many centers that do it the other way. But at least I know my residents can look at publications from the UK or other European era nations that display their images this way. So, premenopausal ovary. You go for the volume of the ellipse formula to get the volume. And so you always measure the longitudinal and the AP diameter on a sagittal view, and only use the transverse view or the coronal view for the transverse measurement. And here's one of our iliac vessels for guidance. Now, I used to think when I was in medical school that follicles don't begin until after menses has occurred. But we all now know that recruitment of follicles begin before the start of menses. We start seeing follicles about day 5 to 7, and the dominant follicles begins to show itself around day 8 to 12. And the non-dominant follicles usually stay no larger than about 14 millimeters in size. Now, sometimes you could have bleeding into the follicle at ovulation, called the corpus hemorrhagicum, but the corpus luteum can grow up to 2 to 3 centimeters over the next 4 to 5 days after ovulation. Now, my reproductive endocrinologist colleague told me that we only see corpus luteum cysts when the corpus luteum hemorrhages. He says otherwise you can just see the corpus luteum as a vacant spot in the ovary without necessarily forming a cyst. So here's an adolescent ovary. I promise not to talk about the uterus or the postmenopausal ovaries. And the only reason why we know they are ovaries is because there are follicles that we see, no matter how tiny they are, and that they're adjacent to the pelvic sidewall that is denoted by the artifact that you see from the bone. Now, in the early follicular phase, you can see the follicles start showing up, but they're pretty much uniform in size. In the late follicular or periovulatory phase, as reflected by the endometrium, you start seeing the dominant follicle. And on the other side, the follicles do not declare one dominant or the other, but because the other side is already determined to be the dominant ovary for the month. And the reproductive endocrinologists monitor these follicles very, very frequently because they don't want to harvest eggs beyond the follicle size of 2 centimeters. They said ideally they'd like to be at 1.5, between 1.5 and 2. So those of you who may work with reproductive endocrinologists know that you're at their beck and call whenever they need to find the ideal time to harvest the follicle. As you can see, on the non-active ovary of the month, there is no dominant follicle. Now, as you proceed to the luteal or secretory phase, you can see follicles that did not make it into being dominant. But on the other side, even if you don't see a corpus luteum cyst, you know that the ovulation has already occurred as declared by this vacant spot in the midst of the normal-looking follicles. Now, we don't do routine Doppler evaluation of the ovaries, but I do have a couple of colleagues who will call a patient back if the sonographer did not get a picture of the color Doppler of the ovaries. They just feel more comfortable if there's a picture that shows color within the ovary saying that there's flow. But what it teaches us is not only can you tell which one is the ovary of the month, because it always has a high velocity, low resistance flow, compared to the quiescent ovary that has a high resistance flow. And resistive indices of ovarian flow are the lowest just before ovulation, hours before the ovulation. And when corpus luteum is maintained, then the RI remains slow until the cycle starts all over again. You can also tell by using power Doppler which of the follicles are probably the ones that are going to ovulate because they receive the most flow. Now, in 2009, we all know that that's when the landmark consensus conference on the management of asymptomatic ovarian cysts happened. This was the program of the day that the experts from different specialties came together. I think it's over in the Sofitel Hotel now, over there across the street. And on the second day, they came to a consensus that was published a year later in Radiology. And we know that we keep this article in our reading room areas for reference for newbies or to show clinicians that this is where we come up with the idea of no recommendation for follow-up or suggest further evaluation depending on the criteria outlined in this article. And this is a must-read article for my residents. It also is interesting to find out that the Royal College of Obstetricians and Gynecologists, in cooperation with the British Society of Gynecological Endoscopy, came up with their own guidelines about a year after we came up with ours. And according to the background and introduction provided in that document, they claim that about up to 10% of women will have some form of surgery during their lifetime because of an ovarian mass. the premenopausal woman almost has ovarian masses and cysts that are predominantly benign, but the chances of a symptomatic ovarian cyst being malignant in a premenopausal woman is pegged at 1 in 1,000, increasing to about 3 to 1 in 1,000 at the age of 50 years. And it also agrees that differentiation between benign and malignant ovarian masses could be problematic, except for some germ cell tumors that have markers like HCG and alpha-fetoprotein that will more or less cue you on the nature of that ovarian mass. But there are a lot of masses, about 10% of them, that end up being non-ovarian in origin, and you can see the list of masses that they put in the first table of this guideline. So they also recommended that ultrasound is the primary imaging for assessing ovarian masses, and at the present time do not recommend CT or MRI because they do not improve sensitivity or specificity that we get by transvaginal sonography. And to me, what is most interesting is a year after we came out with our guidelines for the management of asymptomatic ovarian cysts, the British organization embraced our recommendations. So the SRU has done a great thing, and it's just not for US consumption. It is now also held by our colleagues across the channel. So we all know what a simple cyst looks like. We know it's an ovarian cyst because the follicles are squashed by this beautiful anechoic simple cyst. And obviously, trying to image the same cyst in a transabdominal approach is not going to give you the resolution and the beautiful definition of the walls of that simple cyst. And whenever we see a benign-looking simple cyst, we always assume that they're either follicular, corpus luteum, and maybe some paraovarian cysts, but these should all be reported as benign. In reproductive age women, corpus luteum cysts are common, especially when you see this rich blood supply that goes around it. Sometimes they could even be more than this and be called a ring of fire because corpus luteum cysts have been reported to have more of this ring of fire phenomenon more than an ectopic pregnancy. So we use the same criteria that we use for any cyst, but because it's associated with a pregnancy, we always assume it's a corpus luteum cyst, and if it's complicated, you may recommend a follow-up as needed, but most of the time, if you think it's a corpus luteum, you do not have to recommend a follow-up. Now, in the time of the oral boards for radiology, I still remember whenever we would go to Louisville to give oral boards, there is always a case of hemorrhagic cyst in the pile. Every half day, there's always a hemorrhagic cyst, but they're all given in different stages of development. And all we wanted to hear is the examinee mentioning hemorrhagic ovarian cysts, at least in their differential, being cognizant of the fact that they could change depending on the timing of the imaging versus the state of the clot retraction. So we are familiar with the so-called fish netting appearance, the retracting clot, no internal flow, and because they are not simple, we could recommend a remote follow-up for a cyst that is more than 5 centimeters because of the remote chance of malignancy. But when you have these very typical findings, especially when you follow them up later, they either decrease in size or convert from a low-resistance Doppler pattern to a high-resistance Doppler pattern, then you rest assured that you were dealing with a physiologic cyst that just happened to be hemorrhagic. Other benign cysts that we have encountered, endometriomas, they always look like that. No matter what you do, they always don't change. They look like that every time. Sometimes they might even show you this layered appearance because old blood and new blood can, come together. The chocolate cyst nomenclature refers to the fact that you always find thick blood clots and new blood combined when you open this cyst. There could be layering debris. They usually have thick walls. And again, no Doppler flow in the walls. Now, sometimes they may come to you in the middle of the night, be requested to do an ultrasound on a very tender abdominal lump that turns out to be an endometrial implant. And these are very, very tender. And sometimes if you have not seen one before, you might worry that this could be some kind of sarcoma or something, but it is known to appear as a lump that is very tender in the superficial abdomen. We know what dermoids look like, but again, to underline the fact that endovaginal is the way to go, this is the same cyst. You just don't see any of this detail in a transabdominal scan. So even if you see the problem transabdominally and you can measure it and you know where it is, it's always best to do a transvaginal to see the typical dermoid plug and the sebum that you see there, the hair floating in the sebum, the shadowing dense material like cartilage, bone, whatever, teeth. And to me, a dermoid is always a good differential for any mass that you see in the pelvis. And that's what I tell my residents all the time. When I give a lecture on dermoids, I always show this. This is my first dermoid. I was so proud of having made this, pickup early in my career. And just because we saw an incidental series of molars in the left side of the pelvis, and we decided to suggest an ultrasound and found this dermoid that has the typical strands of hair floating in it. But this is definitely dated because this was one of our very first ultrasound machines. What about solid ovarian tumors? It is said that predominantly solid ovarian neoplasms are a minority in the premenopausal woman, and they are predominantly benign. And you can see the list of what they are. 28% are epithelial in origin, 22% are germ cell tumor in origin. This is where the dysgerminomas and the teratomas come in. And you have 21% sex cord stromal tumor origin, and the metastatic tumors, the Krukenberg tumors, account for about 20% of all the predominantly solid ovarian tumors. Now we know what cancer looks like, and it is interesting that it is the most common cause of cancer death from gynecologic tumors in the United States, but it's barely mentioned in the incidence table that I'll show you in a minute. They include primary lesions arising from normal structures in the ovary, and again, epithelial ovarian cancer is the majority of ovarian malignancies, and the germ cell and sex cord and the metastatic tumors are in the minority. Now, if you look at the American Cancer Society graph, you can see that the ovary is not even on this list as far as estimated new cases go. But look at where it is in the estimated deaths. It's second to breast among the gynecologic cancers as the estimated cause of death. So that is why we still have a problem in putting out a reliable ovarian cancer screening program. And I know that we're still working in the era of genomics, so hopefully one of these days we will have a more efficient way of monitoring ovaries rather than answering phone calls asking for screening ultrasounds because somebody had a grandmother that died of ovarian cancer. We know what the malignant cystic ovarian tumors look like. Not only are they full of debris, they have very irregular, thick nodules. Confirm on CT, they could have flow, and this is probably one of the best evidence that you have that you're dealing with a aggressively growing tumors when you see blood flow in this thick septi. Sometimes when you have other diseases that invade the ovary, you could have a hypoechoic mass with very irregular borders mixed in with the follicles in the normal ovarian tissue. This one happens to be a lymphoma affecting the ovary. And the high velocity, low resistance blood flow that we see both in malignant tumors and in rip-roaring acute PID is always indicative of a rapidly metabolizing mass. So what about polycystic ovarian disease? My residents always ask me whether this is a diagnosis we should make, knowing that there's a series of laboratory and clinical scenarios that would make the diagnosis rather than us suggesting it. But we see this configuration all the time to where if there is no clinical indication for PCOS and the medical record doesn't say anything about PCOS, we always say something like the appearance of the ovaries are consistent with PCOS given the right clinical setting. So hopefully it calls the attention of the clinicians to look into that possibility even if there are no classic symptoms that go with it. One thing that I read lately, which I thought was eye-opening, because I always thought that polycystic ovarian syndrome was an ovarian issue. Nowadays, it is thought to be a result of endocrine disorders characterized by a series of hormone imbalances. So it's not really the ovary's fault. It's just called polycystic ovarian disease because of that manifestation. So hyperandrogenism and insulin resistance combine to produce the results of what we see in PCOS clinically. The hyperandrogenism is from the excess testosterone that's produced in this disease. They can prevent ovulation, thus the amenorrhea. And the insulin resistance component causes excessive insulin and glucose in the blood, and in turn continue to pump out excess estrogen, destabilizing the whole hormonal system. On top of that, the excess insulin causes the ovaries to produce excess testosterone and just confounding the whole problem. And it increases the conversion of testosterone to estrogen, which affects weight gain and the formation of ovarian cysts. So from a systemic point of view, PCOS is likely due to a continuing hormonal imbalance rather than the fault of the ovary. So they always look like this. And when you see a big, thick stroma with more than 10 follicles that are uniform in size, that rim the whole ovary, and you start suggesting that it may be PCOS, because it always looks like that. Many different patients always show you this beautiful pattern of a thick ovarian stroma and a lot of tiny follicles rimming the rim. What about torsion? There's a lot of literature in torsion that educates us about when we should call it. So torsion usually does not give you a normal-looking ovary picture. That's why, to me, if the ovary looks perfectly normal, chances are you're not dealing with an acute torsion at the time that the ER sends you the patient. But it constitutes 35% of GYN emergencies, happens more in premenopausal women, and if there is a mass that serves as the focal point, that's where the torsion tends to happen. That's why they say torsion of a normal adnexa is rare. We are familiar with the signs of patients that present with ovarian torsion, and from these articles, you can see this beautiful edematous ovary with free fluid. Usually these ovaries are so big and they're located in an unusual location for an ovary. And you should be looking for coiled or twisted vessels. Now, personally, I've never seen this, but this article in 2004 claimed that all 21 patients showed the whirlpool sign. And if you happen to cut them on a sagittal view, you can see the row of the twisted pedicle here and the vessels that go around the whirlpool sign. And this is correlated by a laparoscopic appearance of the torsed ovary in comparison to the normal ovary on the other side. Now, Doppler in torsion. I'm sure you must have, been called several times by sonographers and residents to say, well, there's flow in the ovary, so there couldn't be torsion. We are told that the presence of the central venous flow is predictive of ovarian viability, but just because you see arterial flow does not mean that torsion is absent. You got a bad-looking ovary and all you see is arterial flow, you have to keep looking for the central venous flow that would help you say that the ovary is probably viable. However, in partial torsion or repeated torsion and untorsion, this criteria could be a problematic thing. So this is my official ovarian torsion slide because there was a adnexal cyst right next to the torsed ovary. We did see some venous flow in the periphery, but this is the one place that we found it. It was never found within the big ovary. It was an occasional arterial flow, but most of the torsed ovary looked more like no flow at all, and it was proven to be torsion at surgery. So torsion, assess ovarian location. If there's a cyst or mass, be suspicious, look for the pedicle sign, and if the ovary looks perfectly normal, it's probably not torsed. How about ovarian hyperstimulation syndrome? I have seen a few of this, and to me they're fascinating because if they come in with a history of, yeah, I've had some fertility procedures done, then you can say, yeah, that's OHSS. And the ovary undergoes extensive luteinization, releasing large amounts of estrogen, progesterone, and that's what produces the shift of the intravascular compartment to the pleural and abdominal cavities. But sometimes you see this in normal pregnancies. I've seen several of these, and these are not palpable clinically, even at the size that they are. So what do? You wait, because even if they're 17, 20 centimeters bilaterally, patient is asymptomatic. Of course, you advise her just in case it becomes torsed or hemorrhagic, and you have to come to the ER for that. But if you just wait, they will regress. 2 months postpartum, they could look almost normal. And so this goes to the category of touch-me-not cysts. And finally, as rare as an ovarian ectopic is, they do occur. I've never seen one. So I had to borrow one from the internet. We thought at first this was an ovarian ectopic, but you can see that the ovary is clearly not part of this whole gestational sac. To have an ovarian ectopic, you should have one that is surrounded by ovarian tissue. And so from the internet, you get these pictures that have follicles that tell you that, yeah, that's definitely within the ovary. That's the only way that you could make the diagnosis of an ovarian ectopic. But most of the time, these are probably corpus luteum cysts or hemorrhagic cysts in the ovary. So in summary, to get good and adequate evaluation of the premenopausal ovary, we all have to be conscious of how dynamic these changes in the ovary are, and always know more or less where we are in that cycle related to the patient's last menstrual period, which should be the number one question you should ask your patient that comes in for a pelvic ultrasound. And to me, having the SRU consensus guidelines in your reading room pasted on the wall as reference before you follow up an ovarian cyst finding or recommend further evaluation has been very helpful. So if you don't have that in your reading room yet, just print the article, stick it on a transparent cover, and hang it with Velcro strips on the wall of your reading area, because you're going to need it. So with that, I end this lecture, and thank you very much.
Well, good morning, everybody, and thank you for coming to this lecture. And thank you, Bev, for inviting me to do this. And last summer, when I got the email inviting me to do this, I responded, yeah, sure, great, I'll do it. And then I thought to myself, how am I going to make this interesting? And what am I going to show everybody that they haven't seen already or that they don't know about? And Joe, everybody who was here for the last lecture has seen everything you need to see, probably. But just, I always like to survey the audience before we start. How many people have ever seen a cyst in an ovary? Come on. All right. How many people have seen a mural nodule? And how many people have seen a septation? All right. Good. I'm done. That's all there is to it. All right. So then I thought, well, I've always had the philosophy that if you don't think something is interesting, you probably don't know enough about it. And so I started reading and learning some stuff about it. And then I realized I really didn't know a whole lot about this compared to what's really out there. So I promise you a lecture like nothing you've really seen before. And we're going to go over some interesting stuff here. And what I'm going to do is we're going to talk about ovarian development. We're going to talk about the physiology of the ovary, both premenopausal and postmenopausal. We're going to talk about what happens during menopause that makes things change. And yeah, we'll talk about some ultrasound stuff, fluid, ovarian enlargement, cysts, masses. I guess you can't really give a talk about ultrasound of the ovary without at least talking about this. But we're really going to look at the literature and some of the pitfalls and problems with doing this. And then, of course, the real subject here is screening for ovarian cancer. And I discovered I didn't really know a whole lot about this, and I'm hoping that when I'm done with this lecture, you'll know something about this as well and be able to put all this into context. So we're going to talk about developmental biology, all right? And you're probably wondering to yourself, why would somebody who's talking about postmenopausal ovary start by talking about the developmental biology of the ovary in a fetus? Okay, anybody have any idea why? I promise you I'm going to tell you. Okay, I know we hear this a lot on TV lately that you're going to hear things, but I promise you I'm going to talk to you about this. So first of all of us basically start off as a 3-layer embryo. Okay, and if you remember this from your developmental biology days, we are ectoderm, mesoderm, and endoderm. And what developmental biology, what we are good at is making tubes. All right, so we make concentric tubes. Your your CNS is a tube, the cardiovascular system is a tube, the GI tract is a tube. But there is an exception to this, okay? And the only cells in the body that aren't formed from these 3 cell layers turn out to be gametes, okay? Gametes and peritoneal lining. Okay, and so when we're a little embryo, we're all little chickens, you know, and we have a yolk sac. And here's the yolk sac here connecting inside the body of the embryo. Here's endoderm, mesoderm, ectoderm. Okay, cells develop inside the yolk sac that actually migrate up into the peritoneal cavity of the embryo. And along with this, the lining of the yolk sac enters as well and actually develops along the inside of the GI tract. And this is going to be the future peritoneum. Okay, and you can see various stages of development here, but the real exception here are spermatozoa and oocytes, and they form from different cell line than everything else. Okay, well, why do we care about that? Well, I'm going to tell you why we care about that eventually. So here we go. We have these little cells that are going to be gametes. All right, they're moving up from the yolk sac, they're moving into the peritoneal cavity, and they settle, okay, in these urogenital grooves is what this is called here. Okay, and on this schematic, this is aorta here, this is the kidneys, there's a little glomerulus here, and some tubules. So this is going to be the kidney. In cross-section, this is going to be the GU tract, this is going to be the GI tract, the aorta, and here we are developing our ovary or our testes right here. And these cells that are going to be the gametes work their way up from the yolk sac and into the peritoneal cavity. And of course, early on, the development of the ovary or the testicle is very similar. Okay, and the difference that occurs is really the plumbing, the tubing that connects these organs to the rest of the body. And we know that the Wolffian duct is ultimately going to end up forming the vas deferens, all right, and the Mullerian duct will regress, whereas in a woman, the Wolffian duct regresses and the Mullerian ducts are going to ultimately form uterus and cervix and vagina. Now, one big difference between ovary and testes is that the testicle is much more vascularized, actually. The blood supply to the ovary is much less prominent, actually, than in an ovary. Okay. So we start off, okay, this is what an ovary looks like to begin with. We're on the urogenital groove here, and we have a lining of epithelium, okay, and then we have this basement membrane, and then we have the stroma, okay, and this is really important ultimately because this thing is what starts, okay, and then ultimately gametes, ovaries, oocytes, populate this structure, and they form, and this becomes more organized, and you have oocytes, you have stroma, and then you have this basement membrane. Okay, and so these are really the 3 cell types that are in the ovary, and these are the 3 types of cancers we're really going to talk about later towards the end of the discussion. But it's important to recognize that the ovary is a little unique in that this part of the ovary actually projects into the peritoneum. Okay, and keep in mind that the peritoneum also developed along with these oocytes, okay, because this is going to mean something ultimately. So you have, it's quite a bit like a tree. And the fruit of the tree, the oocytes, is really in the peritoneum, okay, whereas the stroma and the vascularity are really originating from the retroperitoneum when they enter the ovary. And ultimately, this is what a mature ovary would end up looking like. Okay, and this is important to recognize, and I'm going to go over this later, is that this is epithelium. This is the most common kind of ovarian cancer, is epithelial, but you can have germ cell cancers as well, less common, and then you can have stromal tumors as well, and we'll come back to that in a second. Well, all of us just heard about the premenopausal ovary. Terry gave a wonderful lecture, and we all know you have primordial follicles, they mature, ultimately they rupture, they ovulate, you get a corpus luteum, and then if fertilization and a pregnancy doesn't result, they degenerate. And these are the hormone levels that go along with this. This is luteinizing hormone, follicular stimulating hormone. Okay, you get a peak of luteinizing hormone, and that's when ovulation occurs, is right here. And this all comes from the pituitary, and the pituitary drives this, all right? And then this is estrogen and progesterone. And you notice estrogen, it has two peaks. Okay, there's the secretory phase, or the proliferative phase peak rather, and then we're at secretory phase, and this falls a little bit, and then it peaks again basically towards the end of secretory phase prior to menstruation, whereas progesterone really occurs just before ovulation. Okay, and this is what really allows the endometrium to receive an embryo if one is formed. So that's premenopausal physiology, okay? What happens in postmenopause? Well, in postmenopause, instead of having this cyclical process, a lot of these oocytes basically begin to degenerate, okay? And they become atretic, and we get small, basically non-functioning oocytes here, okay? And more of these start to develop. The ovary atrophies, and then we just end up with tiny little residual material from these oocytes, okay? The hormone levels, on the other hand, because we're not making estrogen and progesterone anymore, the pituitary gland gets quite upset about this. There's no feedback inhibition, and our follicular stimulating hormone and luteinizing hormones increase their levels throughout menopause. And so menopause can be defined basically as elevated levels of these pituitary hormones and very low levels of estrogen and progesterone. All right. Well, the reason I put this really busy looking slide in here is for a couple reasons. But one is this statement up here. Okay, so what is menopause? All right, seems reasonable to define it. Menopause is caused by depletion of primordial follicles in the ovaries. Okay, females have a maximum number of oocytes at 20 weeks of gestation. All right, so that's a clue as to why I talked about embryology a little bit. So the follicular pool decreases gradually throughout life until about age 52 when the pool runs out. So when you run out of active oocytes, that's when menopause occurs, okay? Most women will produce roughly 50,000, 100,000 to maybe even 1 million oocytes during fetal development, but only 500 of them will ovulate. And the remaining ones that never ovulate, that never do anything, are called the oocyte burden in these patients. And then if you look at these charts, these are the pathways of what occurs with these hormones. And the only thing I want to point out is what I said before: elevated follicular stimulating hormone, way high, okay, in postmenopausal women. Increased luteinizing hormone, way high in postmenopausal women as well. Okay, and this is all going to be related ultimately to the imaging of the ovary. Okay, and so we get these things called breakthrough cysts, and then what happens is these immature oocytes, and here's a clue, that happen to have double-strand breaks, induces ovarian epithelium to form tumors. All right, so we're going to get back to all this in just a second here. So the postmenopausal ultrasound exam in many ways can be considered the hunt for ovarian cancer. I think we all know that. We don't see most of the premenopausal stuff like dermoids and endometriomas and things like that in postmenopausal women, right? And so there are really 4 things that we really talk about and look for when we do the postmenopausal ovarian ultrasound exam. We look for ovarian size. Okay, these ovaries atrophy because they don't have mature oocytes in them anymore. So usually they're less than 5 cc's in volume. Okay, pretty small. Normal might be 12 during active ovulation, maybe up to 20. We do look for cysts. We're going to talk about cysts. As a distinction, we talk about cystic masses. Okay, and cystic masses are masses that have mural nodules, projections, septations, debris, echogenic fluid within them. And then we're going to talk about ascites as well. So these are really the ultrasound findings we're looking for, and this is really the basis for doing the ultrasound exam. So what I did is I went through the literature, and if you go through the literature, there are 50 to 100 articles published every year on various aspects of this subject. And so literally there are thousands of articles going back over time. And what I did is I took all the ones that were done within the last 6 months just to point out where we are in this. And I want to just point out some of the issues and problems that we keep seeing in the literature. So here's one. 99 postmenopausal women, 42 had surgery, and what they were looking at is what's the mean size of the lesions that they see when they're screening, okay? 5 cc's is the cutoff here. Well, what they found was that the majority of these were solid benign tumors. These are all stromal tumors in general, and the vast majority of them were benign, and then there were 2 invasive carcinomas in this series. So I think we know that increased ovarian size is a real marker for malignancy. The problem is we'd like to find them when they're small. Okay, this is the problem. And I don't know what size cutoffs people are using when we call them normal, but the real dilemma is if normal postmenopausal ovary is 5 cc's, what do you do when you have a 10 cc ovary or 20 cc ovary? And when do you become concerned about it? And what do we do about it? So I'm going to just talk about cysts for a second because cysts are a bit of a dilemma. And so I quote to you, this is the American College of Obstetricians and Gynecologists practice bulletin on the management of adnexal masses, and this is really in postmenopausal women. It's in 2015, and it says, with the exception of simple cysts on transvaginal ultrasound, most pelvic masses in postmenopausal women will require surgical intervention. Okay, so does this mean it doesn't matter what we say? If there's a mass, it's going to be taken out ultimately? I mean, this is what they were suggesting in 2015. So a group was formed to deliver a consensus report. Okay, the first international consensus report on adnexal masses, management recommendations. Okay, and you know, in Seattle we have a football team, the Seattle Seahawks, you know, and the defense is called the Legion of Boom. And if you look at the names on this consensus panel, we have Phyllis Glank here. Is Phyllis here? She was here at one point. We have Phyllis, we have Beryl, we have Beverly Coleman, we have Deb Levine. I mean, this is clearly as good a defense as you could possibly have representing the SRU, right? So what did they find? And what were their recommendations? Well, they found that in the United States, we perform 9.1 surgeries per malignancy that's discovered, okay? In European countries, based on their data, it's 2.3 surgeries per ovarian cancer found. In most centers around the world, it's 5.9 surgeries per ovarian cancer. So we have the distinction of doing the most surgeries per ovarian cancer found. And I don't think that's surprising, actually, the way our system is set up. So the panel concluded that patients would benefit not only from a more conservative approach to benign adnexal masses, but for optimization of physician referral as well. So it seems that most of the lesions that we're going to find are benign, okay, especially when they're simple cysts, and that we're doing too many surgeries per malignancy that's found. And so we all know that we developed an SRU criteria for following cysts, and in the postmenopausal arm of this, most of these come back for follow-up for anything bigger than a centimeter. Okay, when you're premenopausal, they can be bigger, but right now we're following every cyst that we see. Okay, I'm missing a slide here, but that's okay. So that's the recommendation now, and this is what the gynecologic surgeons wanted us to do. Now, we're going to make a distinction here between cysts and cystic masses. Okay, so a cystic mass has septations and nodules and plus or minus flow within them. And I'll just go over a couple of the data. Again, this is very recent. This is 2014. And this was the performance of ultrasound as a second-line test, the screening with CA-125. I said we'd talk about screening, and we will. 741 women, 1,219 cancers. This study was done over almost 7 years. And when we see these, ultrasound sensitivity was 100% for abnormal morphology, 90% for abnormal volume, and the highest specificity and positive predictive values were found for these findings. So ultrasound is very, very good at doing this, okay? So the question becomes, why don't screening programs using ultrasound really work, okay? If we look at another paper They basically developed a scoring system, and there have been lots and lots of scoring systems published in the literature for how to evaluate complex adnexal masses. Beryl published one. She has a scoring system of her own, but they pretty much have the same features. Cyst wall structure going from smooth to thick wall to papillary projections to solid, septa, thin septa, thick septa, solid areas within the septa, okay, and then the volume of the tumor. And you notice that you have to start getting pretty large before you get higher in the score here. So I think all of us here are very familiar with this gradient, if you will, of how suspicious a lesion is based on size and particularly based on papillary projections. Okay, papillary projections are more worrisome than septations in general. And I just throw this in here. We all do flow in these lesions. If a lesion has a mural nodule in it, it doesn't really matter whether it has flow in it or not. In a postmenopausal woman, it's going to be taken out. Okay, so this is the original paper. Thomas Bourne published this, 50 women. And I throw this in here. 7 out of 8 had cancer, had low RI flow. These were the kinds of things you could publish 20 or 30 years ago. Now I'm going to show you more literature to give you the kinds of numbers that people talk about. We're going to talk about the presence of ascites. Now, what I was really looking for, what I wanted to know is how much ascites needs to be present before you start worrying about the presence of an ovarian malignancy or particularly peritoneal disease. And so this paper from 2007, 372 patients with ascites specifically had cytological studies, and their survival was evaluated, and it was very clear that ascites is associated with omental metastases and metastatic lymph nodes. Okay, and I think we all know this. Okay, and so the question I really wanted to know was, what if I see 1 or 2 cc's of ascites in the cul-de-sac of a postmenopausal woman? Okay, is that suspicious? Okay, should that make me start looking around? Should that make the gynecologist do something to this patient? And I can tell you that I did not find a single paper that addressed that issue. Okay, and yet for me, if I do one of these exams and I see a tiny amount of ascites, it makes me worried. Okay, postmenopausal women really shouldn't have ascites. So whether I see an ovarian mass or not, or peritoneal disease, I'll report ascites, and I think these women have to have increased surveillance, certainly. And then that brings us to the final part of this, and that is the biochemical screening for ovarian carcinoma. And everybody is familiar with CA-125. Everybody's heard of CA-125, right? We use it all the time. What are the problems with it? Okay, the problem with it is that there's a lot of things that do it. Okay, in premenopausal women, it doesn't mean a whole lot. Endometriosis can do it, fibroids do it, PID, menstruation, hyperstimulation, pregnancy. Okay, and then there's a lot of non-gynecologic things that can elevate CA-125. CA-125 is really a marker of epithelial cells. Okay, and so things like congestive heart failure, renal disease, liver disease, appendicitis, pneumonia, pancreatitis, all of these can elevate CA-125. So the value it seems to have is it raises some suspicion in a postmenopausal woman that a malignancy could be present, and it's probably a better marker to follow as the woman gets treated than it is for really confirming that a patient has a malignancy here. And if you look at all these different markers related to epithelial cells, okay, you see CA-125 right here. Okay, it doesn't have great sensitivity for ovarian cancer, okay, at least in this data, which is from 2017, by the way, all right, about 13%. There's others of higher sensitivity, okay, but it does have the highest specificity, okay, so if it's elevated, well, this is even higher, actually, but it does have high specificity. So again, it's very useful for following tumors, but it's not so useful as a screening test in and of its own right. Now, how many people here have heard of BRCA1 and 2? Everybody's heard of this? Nobody's voted. It's like any other election, huh? Okay, people have heard of these, right? Okay, how many people really know what these do? Okay, how many people understand what it is that the genomics and proteomics that we're talking about for screening for cancer do? Okay, well, I didn't, I'll be honest with you, until I started looking at this. So what these genes do is they code for proteins that repair double-stranded DNA breaks. Okay, and I mentioned this in the very beginning, okay, about embryogenesis here. Okay, when do double-stranded DNA breaks occur? They occur during meiosis. Okay, they occur when the oocytes are developing. Okay, so why is it that we are screening for ovarian cancers for something that occurs during oogenesis, okay, for something that's a follicular disease, okay? There's a little bit of a paradox there. It's an epithelial disease, okay? It's not really a gamete disease, ovarian cancer, all right? And so, but what happens is you have these double-stranded breaks, okay, and then these cells are abnormal, and then ultimately when these cells start growing and become a cancer, all of these proteins that are supposed to be trying to repair these breaks multiply, okay, and they're elevated, and then this is how we're screening for ovarian cancer. I will point out that this is genetics of the BRCA1 and 2, and this was the original family who had the history of breast cancer, and the black, of course, are the ones who were infected. And by tracing these genes through this family and doing genetic studies on them, this is how the BRCA1 and 2 genes were developed. So basically, BRCA1 and 2 repair, homologous recombination repair, that means double-strand breaks. This only occurs during meiosis. Okay, and this is not the only incident time where something that occurs during developmental biology leads to disease 50 years later. The other big one is hypertension. Okay, all of us are born with all the nephrons we're ever going to have when we're neonates. Okay, and if you have fewer nephrons than you're supposed to have, even when you're a little baby, that actually predicts quite accurately who's going to get hypertension when they're age 50. The problem is, how do you count nephrons in somebody? It's not possible. Well, the same thing is happening here with the ovary and ovarian carcinoma. Okay, and so there are 4, and this is the only process that can repair double-stranded breaks, the only process that's known at the moment. And so there's 4 genes necessary to do this, so this forms the basis for the genomics that people are studying. And then there's all these proteins that get together. Here's our double-stranded DNA break, and we have telomere maintenance and homologous end joining and all this stuff that we don't really know about as radiologists. But here's our double-stranded break. Here's our complex of proteins forming a little bridge here and pulling the ends of this together, and this is how these get repaired, okay? And this occurs during meiosis. So what is the pathogenesis of ovarian carcinoma? And this came out blurry. I had actually replaced all these slides this morning, so all my new ones didn't get in here. But anyway, this is our surface epithelium. And just to emphasize that the formation of cysts in the postmenopausal ovary does not follow this oocyte ovulation pattern. Okay, it's a different process. Okay, in postmenopausal women, they don't have any active oocytes anymore to ovulate. So what happens is you get these inclusion cysts of epithelium. So there's little breaks in the surface of the ovary where the epithelium maybe has some kind of crater in it or some kind of ridge or irregularity. A little bit of epithelium gets trapped within the stroma of the ovary, and then this forms a cyst. Okay, and so then the question is, how is it that an epithelial cell like this, okay, ends up forming an ovarian cancer where all of the proteomics and genomics that we're looking at are for gametes, for oocytes, okay? There's no oocytes in these. Well, the answer to this is that all those little cells that migrated out from the yolk sac during development, okay, seed the peritoneum, seed the fallopian tubes. Some of these have double-stranded breaks. When these cells form, when these cysts form, some of these get a little inclusion of some of these cells within them, and it's these cells that then grow on to grow into ovarian cancers. Okay, and that's the paradox. How is it that if you don't have any oocytes left, that we're screening for cancers looking at oocyte-type genomics? And what this says here is epithelial cancers are the majority of the cancers. Terry said the same thing. Germ cells do not form ovarian cancers in postmenopausal women. This is younger women. And then the stromal tumors, by and large, produce hormones and manifest much earlier as well. So that is really the genesis, if you will, for ovarian cancer. It is actually double-strand breaks in the oocytes that are migrating from the yolk sac, okay, up along the peritoneum, okay, and then forming the ovaries. So here's the problem. Here's some literature, very recent literature here. Well, this one's from 2000, but it illustrates the problem. 14,000 women were screened So 46,000 screening years. Okay, we looked at volume, mural projections, only 17 cancers out of this group and 3 deaths. And while every cancer and every death is too many, this isn't very many, right? It's a pretty small volume. And then when you look at the literature, look at the numbers of patients these people are reporting. You know, Tom Bourne reported, 50 patients with color flow, 34,000, 50,000, 48,000. And yet look at the number of cancers here. Very small, 34, 24, 27. Most of them were stage 1 and 2, but here's the problem. Some of them really were stages 3 and 4. So we're looking at something that doesn't happen that often, okay? And even when we're screening for it using chemistry, genomics, proteomics, and ultrasound, a lot of the patients that we find still have advanced disease. And maybe this is the problem. Okay, this is an older study that really illustrates the issue. 22,000 women underwent screening. Only 40 were positive. Okay, out of the 40 that were positive, only 11 cancers were found at surgery. So there's 30 false positives. So we really are overcalling this in most of these women. And then the real issue is the 8 false negatives. 8 women who were screened in this study went on to have ovarian cancer, and that's the problem. And that's what I see in my own experience, is you'll do an exam on a patient, and it's totally normal. 6 months later, a year later, she comes back and has metastatic disease, and I find that very frustrating. Okay, and then this is more data, and you can look in your syllabus at this, but it says the same thing. Huge numbers of patients, small numbers of epithelial cancers, okay, and at various stages, all right? And so this is a problem, small numbers, all right? And yet, small numbers of cancers for large numbers of women screened. So there's been several groups that have published recommendations for ovarian cancer screening. This is from the New England Journal. And what does this one say? Does not recommend routine screening, does not recommend routine screening, does not recommend screening, does not recommend screening. Okay, this is why, is because it just doesn't really work very well. So it's not something we should really be trying, all right? And I don't like getting that phone call either. Grandma died of ovarian cancer, can you take a look at her ovaries? That makes me nervous, frankly. So contrast, okay, this is the big hope for the future, and small ovarian malignancies do have greater peak enhancement and longer washout times than normal ovary. Here's a little tumor here, all right, and there's been 10 independent studies, 579 ovarian tumors, and the pooled sensitivity, 91%, and specificity, 92%. And of course, Art Fleischer authored one of these papers, and he was just telling me this morning there's even more papers out. So maybe contrast will help us in this situation. I'm going to show you, these are the only images I'm going to show you in the study. Here's a patient I did, 50-year-old woman, asymptomatic, came in for ultrasound exam, okay, took these images, thought this was a cyst, and I thought this was reverberation artifact, and maybe it is, all right? But I said, come back, this is 5 centimeters, you need to come back in 3 months and let me look at this again. Well, she didn't come back, she never showed up again, and I'm just about to run out of time, but I'm almost done here. So she never came back. 9 months later, she shows up. Now she's symptomatic, and she's got mural nodules within the septation. She's got low resistance flow. And of course, this turned out to be an ovarian cancer, and it was stage 3 by the time we picked it up. So I can tell you that 25 years later, this bothers me. It still bothers me. It's the only time I've ever seen this happen in my own experience. And then this is the strangest cancer I've ever seen. This had all this strange material in it, big mass. Nobody would mistake this in a postmenopausal woman for anything benign. And it turned out it was stroma ovarii. It actually had thyroid tissue in it. So it's a very strange case in reality. So anyway, in conclusion, I just want to really emphasize that the event that results in ovarian cancer occurs during embryonic meiosis. Okay, as odd as that may seem, that's really when it happens. The peritoneum and the ovary are intimately related. Okay, and it explains the spread of peritoneal disease. The ovary forms along with the peritoneum. The cells move into the peritoneum, and it's no surprise that that's where a lot of the metastases go. Biochemical and genetic screening stratifies risk, and yet it's still not really routinely recommended for screening for ovarian cancer. We're familiar with the worrisome findings in ultrasound. That's why I showed you all this other stuff rather than images. We still overtreat simple cysts. Okay, really, simple cysts, the pathogenesis of these is inclusion of epithelium in the ovary. It's not ovulation, and just the cyst in itself, if it doesn't have the right cells in it, is not going to form a cancer. And in my mind, be wary of fluid. I think even small amounts of fluid are worrisome, and maybe contrast is the great hope here. And I thank you very much for your attention.
This is a video about ultrasound in the diagnosis of endometriosis, ABCDE. My name is Suzanne Johnson and I'm a gynecologist from Southampton. Endometriosis is a common gynecological condition affecting around 5% of women. It's defined by the presence of stroma and glands outside of the endometrial cavity, and this is hormonally responsive, leading to cyclical pain, bleeding, inflammation, fibrosis, and the formation of adhesions. Endometriosis is a cause of pelvic pain, dysmenorrhea, dyspareunia, dyschezia, subfertility, or it can be asymptomatic. There are 3 kinds of endometriosis. There is superficial endometriosis, ovarian endometrioma, and deeply infiltrating endometriosis, DIE. And DIE is when endometriotic lesions extend for more than 5 millimeters underneath the peritoneum, surrounded by inflammation and dense fibrosis. It's not certain what causes endometriosis, but there are theories of retrograde menstruation and/or metaplasia. The mean delay between a woman having symptoms and a diagnosis of endometriosis is 8 years. And 1 in 3 women had consulted their GP at least 6 times before referral and diagnosis. The symptoms can overlap with other conditions like irritable bowel syndrome, and it can be diagnosed on ultrasound, MRI, and laparoscopy. A pelvic ultrasound, though, is often said to be normal, and patients are told that there is nothing wrong, which leads to long delays in diagnosis. But you need to look for deep infiltrating endometriosis, mobility of frozen pelvis, and site-specific tenderness on ultrasound to make the diagnosis. In 2016, the International Deep Endometriosis Analysis Group published this paper, and it's a consensus opinion on terms, definitions, and measurements to diagnose endometriosis on pelvic ultrasound. They have defined this as being useful to do in 4 steps, and these can be done in any order. And the first step is a routine pelvic ultrasound of the uterus and adnexa, looking for signs of adenomyosis and ovarian endometrioma. The second step is looking for soft markers like site-specific tenderness and ovarian mobility. The third step is looking at the sliding sign as mobility in the pouch of Douglas. And lastly, looking for DIE nodules in the anterior and posterior compartments. But you can do these steps in any order. And this video is to tell you how I use the ID classification. I start with a systematic routine pelvic ultrasound looking for the features of endometriosis like adenomyosis, ovarian endometrioma, and ovarian adhesions. Then I look for the sliding sign in the pouch of Douglas. Then I look for nodules of deep infiltrating endometriosis, and lastly I look at the soft markers of site-specific tenderness and pelvic mobility. When I do a systematic transvaginal scan of the pelvis, I don't routinely ask the patients to have a bowel preparation. The main thing is to be really gentle and to have the patient's position in a good way, so that the patient's bottom overhangs the edge of the couch a little bit and either has knee supports or a chair for the feet. And then I always say, let your knees go floppy, as this really relaxes the legs and the pelvic floor. Then I slowly insert the transvaginal probe with plenty of gel on the outside of the probe and perform a normal systematic pelvic scan, looking also at mobility and tenderness. And in women in whom I diagnose DIE, I will also do a transabdominal renal scan, as 3% of women with DIE might have silent hydronephrosis. Most of my images are in the longitudinal view, and I'll mention in the video when it's in the transverse plane. But generally speaking, this is the way that I'm oriented, with bladder at the top, then uterus underneath that, and bowel below. The first thing I look for is what position the uterus is in. And so here you can see an anteverted uterus where the uterus tilts toward the bladder, B for bladder, or a retroverted uterus where it tips backwards away from the bladder. But in endometriosis, you often see a uterus that is anteverted but retroflexed, as the fundus of the uterus here is pulled backwards by adhesions. So in this orientation, the bladder is here. In this video, you can see a uterus with adenomyosis. You can see that it's bulky, it's globular, there's an indistinct endomyometrial junction, and there's stripy shadowing, a little bit like a Luxaflex blind. In this video, you can see a different uterus with adenomyosis where there are islands of endometrium in the myometrium. This is an adenomyosis. And on 3D, you can see those islands as little outpouchings from the cavity. In this view on 3D, this is the myometrial fundus, this is the right side, and this is the left side, and the cervix is at the bottom. You can see a very irregular endomyometrial junction. This is typical of adenomyosis. In this video, you can see an ovarian endometrioma, and it is adherent to the uterus, to the back of the cervix. You can see it there. And this now is in the transverse plane, where you can see this is low down level of the uterus, and this is an ovarian endometrioma, a unilocular cyst with no solid material, some shadowing and ground glass echogenicity adherent to the back of the uterus. And to compare that with the normal ovary on the patient's other side, you can see that when I very gently press the probe in and out, very gently, you can see that this ovary cantilevers a little bit. It's freely mobile. Here again is a transverse plane. This is the back of the cervix. The back of the cervix is here. And here you can see an ovarian endometrioma adherent to the back of the cervix and also adherent to the other ovary. And this is a less obvious endometrioma, and this is called kissing ovaries. Often in reports on women who later turn out to have endometriosis, there's a comment that the ovary is low. And at that point, the transverse view is very useful. You must suspect adhesions when you see an ovary this low. So here you can see the bladder again is at the front. This is the uterus, the cervix. This is the back of the cervix. And here is this ovary adherent to the back of the cervix. And in this plane, you will see that it is attached to uterosacral ligaments, but more of that later. And here is the difference between a heavy ovary, a polycystic ovary on this side, and an endometrioma, which is adherent to the uterosacral ligaments. Both are low in the pelvis, but one is freely mobile, and the other one is an endometrioma, and it is adherent to the uterus. The other thing you look for is hydrosalpinges, because the fallopian tubes can be affected by endometriosis, but mainly it's due to adhesions near the ovary, and you especially see this when you have kissing ovaries. So here again in this longitudinal view, you can see a uterus and then the ovary, and here is the hydrosalpinx. And if you do 3D of that area, sometimes it shows you very clearly that this is a definite hydrosalpinx, and it's a unilocular tubular mass with thick irregular walls, incomplete septa, an anechoic or echogenic fluid content, and you may have shadowing. The next thing I do is look for the sliding sign in the pouch of Douglas. Now these papers were published in 2013, almost simultaneously, talking about how to judge mobility in the pelvis. This is an example of an anteverted uterus, and if you have your probe in the anterior fornix, this is the plane that we're most familiar with, you can see the cervix, and you'll be able to see the sliding sign of the cervix against the bowel just there. If you put your probe in the posterior fornix, You won't be able to see the cervix because it's pushed over that way, but this is a very good way to look for bowel nodules and adhesions, but more of that later. So for the sliding sign in an anteverted uterus, the probe needs to be in the anterior fornix to look for mobility at the back of the cervix. But if the uterus is retroverted, then when you have your probe in the anterior fornix, you can see the cervix, but it's quite difficult to judge mobility at the back of the cervix, which is where we need to look in the pouch of Douglas. But if you put the probe in the posterior fornix, then again, you can't see the cervix because you've pushed that away, but you'll now be able to judge the sliding sign of the uterus against the bowel in the pouch of Douglas, and will also look and find bowel nodules and adhesions. So this is a normal sliding sign. It's an anteverted uterus. The uterus is tilted toward the bladder here, and the probe is in the anterior fornix. I can see the cervix, and I can see the back of the cervix moving freely against the bowel. Normal sliding sign. And here's an example of a normal sliding sign in a retroverted uterus. I've now put the probe in the posterior fornix, so the cervix is pushed to the side. But when I press very gently with my probe, you can see that the back of the uterus and the back of the cervix is entirely free from the posterior structures. So what does the pelvis look like at laparoscopy? We've seen a normal sliding sign. What would that patient's pelvis look like? You just have to understand that when you do an ultrasound, this is the patient's right and this is her left, and we're very familiar with that. But at laparoscopy, the pelvis is inspected from this way, so looking toward the patient's feet. So in this view, you're looking at the back of the uterus. The bladder is in front of the uterus, and on these sides you can see the ovaries, you can see the fallopian tubes, but most importantly here at the back of the uterus, this is the torus. This is an area where one uterosacral ligament and another, they join on the back of the cervix, and this is the pouch of Douglas just beneath it. And the torus is incredibly important in ultrasound for endometriosis. So the torus is the insertion of the uterosacral ligaments on the posterior cervix. So what does that look like as an abnormal sliding sign? You remember the normal sliding sign where we looked at the torus and the structures move freely. And this is an abnormal sliding sign. You can see here that the posterior structures are adherent to the back of the cervix. This is an abnormal sliding sign in an anteverted uterus. An abnormal sliding sign in a retroverted uterus, we've got the normal sliding sign on the left there, and you can see probe in the posterior fornix, gentle pressure. You can see that uterus is completely mobile. But then on this side, again, I'm pressing gently with my probe. You can see that all this is adherent to the back of the uterus and the back of the cervix, which is up there. So a frozen pelvis, what does that look like at laparoscopy? You can see here, this is the back of the uterus. These are the ovaries, which are adherent to the back of the cervix with dense adhesions, and the bowel is just behind there. And that was this sliding sign that was negative. So having done a systematic pelvic ultrasound and looked for the sliding sign, I'm now going to look for nodules of deep infiltrating endometriosis. As I said, DIE is when you have endometriotic lesions which extend for more than 5 millimeters underneath the peritoneum, and you get cyclical bleeding here with inflammation and fibrosis. The result of that is some irregular hypoechoic solid nodules which look dark, with minor vascularity usually, surrounded by brightly echogenic white fibrosis. So the nodules tend to stand out rather. Where can you find these lesions? You can find them in the bladder, ureter, posterior vaginal fornix, maybe involving the lower rectum, retrocervical area of the torus and uterosacral ligaments, a retrocervical nodule involving either the posterior vaginal fornix and or the lower rectal wall, a rectocervical nodule involving the rectal wall of the upper or lower rectum, and then it can be in the lower rectum, upper rectum, sigmoid, some other areas, and also cutaneous. Looking at the most common areas where we look for DIE, there's the anterior compartment comprising of bladder and ureters, and the posterior compartment of the posterior vaginal fornix, retrocervix, and rectum. So if you look at the area where the bladder joins the uterus and draw a line backwards, that will go through the internal os and behind that level at the torus. So you always look for where the bladder inserts on the uterus, internal os will be behind it, and torus will be behind that. So this is where the uterosacral ligaments attach to the back of the cervix. If you draw another line down the external cervical os, then the area between vagina and bowel up to that red line is called the rectovaginal septum. The bit of vagina that is here below the red line, or above the red line in reality, this is the posterior vaginal fornix, and this underneath is the pouch of Douglas, and this is peritoneum, which dips down to about the level of the external cervical os, and then of course covers the back of the uterus and the bowel. This green line showing you where the torus is divides the bowel into lower rectum and upper rectum. So a common location for DIE is in the bladder, in the posterior vaginal fornix, at the torus, in the lower rectum or the upper rectum. At laparoscopy, this is as far as you can see. You can only see as far as the pouch of Douglas is open. But if you have DIE, everything can become completely glued together, and this is called a frozen pelvis. And this is what a frozen pelvis looks like at laparoscopy. So again, we're looking at the back of the uterus. This is the right ovary, and here is the pouch of Douglas. There are adhesions here. And you can see that everything has got glued together. So looking now at the posterior vaginal fornix at lesions of DIE. The rectovaginal septum is the septum between the lower 2/3 of the vagina and the lower rectum and anal canal, and I have never seen endometriosis there. But the posterior vaginal fornix is the upper third of the posterior vaginal wall. It's above the level of the cervical external os, and in many papers the posterior vaginal fornix is called rectovaginal septum. But in fact the posterior vaginal fornix is a common location for DIE. So again, just looking at that again, with that red line that you draw past the external cervical os, the 2/3 of the tissue between the vagina and the bowel is called the rectovaginal septum, but the upper third here, this is the posterior vaginal fornix, and it is here that you can often find lesions of DIE. Here is an ultrasound image showing you the anatomy slightly better. This is the cervix, again seen in a longitudinal plane. There's the external os. This is the vagina. That's the lower bowel. That's the rectovaginal septum. And then this is the pouch of Douglas. So how does that fit in with the posterior vaginal fornix? This is a video showing you that. This is the posterior vaginal fornix. There is the external os, the internal os, and this is the posterior vaginal wall, and this is it as it merges onto the posterior cervix, just there. And it looks white here because there's a little bit of air in the vagina. So this is the posterior vaginal fornix, and then the rectovaginal septum will be just laterally to it there. And this is just a longitudinal plane going from one side to the other, just showing you where that posterior vaginal wall inserts on the cervix. So this is a common location for deep infiltrating endometriosis, and we're calling it the posterior fornix, but some people call it rectovaginal septum. And this is a video showing you that here is the posterior vaginal wall, this is the external os, that's the cervical canal, and here you'll see in a video in a minute a lump of deep infiltrating endometriosis in the posterior fornix. This is the probe being introduced. Always look carefully as you introduce the probe, very gently, and there you can see deep infiltrating endometriosis in the vagina with a nodule extending onto the lower bowel, but I'll show you more pictures of that in a moment. So for now, look at the posterior vaginal fornix. There's a lump of deep infiltrating endometriosis there, and you can see it almost immediately as you insert the probe, just there. And these lesions sometimes are a little bit vascular, usually not too strongly so. And if you do a speculum examination, looking at the posterior vaginal wall, just at the top third there, you can see this nodule of DIE, and it's kind of eroded through the vaginal epithelium. Next we come to the retrocervical area of the torus and the uterosacral ligaments. Looking for DIE, this is a really good trick. You start by visualizing the torus. So the torus is where the uterosacral ligaments attach on the back of the cervix. So I start with a longitudinal view, looking for the area where the bladder, which is this white echogenic line, attaches to the uterus. In a line behind that is the internal cervical os, and in a line behind that is the torus. This is more or less where the uterosacral ligaments attach, and I'll show you what this looks like live. Start longitudinally, and then I'll rotate on this point of the torus and go transverse. So this is the view in the longitudinal plane, going from one side to another. Now I'm rotating to the transverse plane. This is the torus, this is the right uterosacral ligament, and this is the left uterosacral ligament, just there. So rotate on the torus, go from longitudinal to transverse. I've got torus at the back, and I've got the right uterosacral ligament just there, and the left uterosacral ligament just there. And that looks like this. This is the back of the uterus again. This is the torus with the left uterosacral and the right uterosacral ligament, and there's an ovary and a bit of tube. Torus, very important area. So having looked at the torus, I then look at the uterosacral ligaments, both sides. You will see them if you look at the torus specifically. You can also stretch them over the posterior vaginal fornix during gentle pressure with the probe. The ligaments are white, and they can be very thick and white fibrotic, and if there are nodules of DIE in the ligaments, they will be dark, so they show up well. This is a transvaginal longitudinal view. This is the posterior fornix, the cervix is up there, and the uterus is retroverted. And here you can see just a little bit of normal fluid in the pouch of Douglas. This dark is the posterior vaginal wall, and then the white is the peritoneum overlying it. And I'm going to show you a uterosacral ligament, which will come into view here, that when I press slightly harder, it will blend with the peritoneum. I'll show you. There is the uterosacral ligament. I'm now pressing slightly harder, and you can see how it blends into the peritoneum. So again, looking at the torus, get a longitudinal view of the internal os, rotate to transverse, and then you're looking at the correct area with the uterosacral ligaments. So the retrocervix, the area at the torus, would look like this in a normal longitudinal view, but this is somebody with endometriosis, and you can see thick white fibrosis of the torus and the ligaments, and you can see a dark nodule at the torus. This is the normal transverse plane of the torus, and you can see here very thick and fibrotic uterosacral ligaments. So looking at the retrocervical area, looking at the torus, if you use high frequency, including harmonics, and move your focus up to very high, this is the posterior vaginal wall, then you can look at the torus and the ligaments in more detail, and you'll see a dark nodule there in this white fibrotic region. So you need to be sure to move your focus up to the area that you're actually interested in and go for high frequency. Of course, if you use harmonics, you have relatively higher frequency still, and that will examine that area nicely. So here we're a little bit high, you can see a bit of cavity, but this is essentially a normal torus. And in this torus, you can see a dark nodule of DIE with very thickened fibrotic uterosacral ligaments. And the image underneath is the same patient seen at laparoscopy. And you can see here is a nodule of endometriosis at the torus with very thick ligaments just nearby, and a lot of adhesions. So once you've found a retrocervical nodule, then we need to think, does it involve the posterior fornix and or the lower rectal wall? Here again is the uterus, the cervix is up there somewhere. Here we've got the vagina, and I'm looking at this white area in the longitudinal view. This is all fibrosis. And here this retrocervical DIE is adherent to the posterior vaginal fornix and adherent to bowel, and you can see an ovary is stuck into this area as well. Here we've got a nodule of deep infiltrating endometriosis, which is adherent to the posterior vaginal fornix and adherent to bowel and involving bowel. And I'll show you that in a moment. There's the nodule of DIE at the torus. There is the attached but not involved posterior vaginal fornix, and here is the bowel wall. And in a video, this is what that looks like. There's the probe going down the vagina into the posterior fornix, and there you can see a bowel nodule just there. You can see it's going down, you can see some fibrosis, and you can see the bowel nodule. This would be lower rectum, and in this video I'm just looking at the bowel nodule in a bit more detail. We'll talk about those more in a moment. There's the retrocervical nodule, and it's attached to bowel and involving the bowel. There is the nodule at the torus. And you can look at the bowel nodule and you can see that the lumen there is quite narrow and the lumen there is much wider. And at laparoscopy you can see here that there's bowel adherent to the torus. Here we can see some retrocervical DIE, which is adherent to the posterior fornix but also involving it, and adherent and involving the bowel wall too. There is the posterior fornix DIE, there is the retrocervical nodule, and here is the bowel nodule in the lower bowel, lower rectum. And this is what that looks like on ultrasound. So the probe is in the posterior fornix. You can see there's a lump of DIE in the posterior fornix. You can see a nodule in the ligaments, and you can see a bowel nodule too. So when you're describing retrocervical DIE at the torus, you have to say, is it in the torus or maybe in the uterosacral ligaments or in all of them? And what does it extend onto? Does it extend onto the posterior vaginal fornix, and is it maybe also involved with DIE? Does it extend onto the bowel? That would be lower rectum and or upper rectum. And is it only adherent, serosa, or is it involved, a muscularis layer of the bowel? Or any combination of the above, especially when people have had previous surgery. Looking for bowel nodules now in the lower rectum, upper rectum and sigmoid. A bowel nodule is again ectopic endometrial tissue in the muscularis layer this time, resulting in inflammation, smooth muscle hyperplasia and fibrosis. And it results in a hypoechoic mass in the muscularis layer. Mostly this is in the rectum, whether it's upper or lower. 20% of cases are in the sigmoid, 15% in the right iliac fossa, either appendix, ileum or cecum, and it's often multifocal. Looking at normal bowel first, the probe is in the posterior fornix, and you can see here again, you can see normal posterior vaginal wall. You can see here the normal overlying peritoneum, and it's not thickened. This is the pouch of Douglas, tiny little bit of fluid. And then you can see that this white layer is the serosa. The dark layer here with the white line in between, that's the muscularis layer. And the white layer is where the outer longitudinal and inner circular fibers join each other, and you get a little white line of connective tissue that makes you realize that's got to be the muscularis. Deep to that, you've got the submucosa and mucosa, and then it repeats again on the other side, submucosa and mucosa, and this one is the muscularis, this layer, and then here you've got the serosa. So the lumen of the bowel is here. Endometriosis is always in the anterior wall, and this is what it looks like. A little bit of normal muscularis. So this is the layer that we're looking for, muscularis. There it's normal, there it's normal, and here you can see this thick lump of DIE that has caused smooth muscle hyperplasia. So you can find bowel nodules particularly through the posterior fornix. So we're used to looking through the anterior fornix because you can see the cervix, you can see the sliding sign of the cervix against bowel, but you'll struggle to see bowel nodules because they will be hidden by the cervix. Whereas if you put your probe in the posterior fornix for both an anteverted and a retroverted uterus, you can't see the cervix because you've pushed it that way, but you will be able to see bowel nodules and adhesions. So this is how we do it in the longitudinal view. This is a cervix. You can see the external os, the cervical canal, the internal os. There's a little bit of dark, that's just some mucus. You can see the posterior vaginal wall, and then this bit is the posterior vaginal fornix. And the probe here is in the anterior fornix because I can see the cervix. What I need to do is move it from the anterior fornix into the posterior fornix, and the way we do that is we very gently withdraw the probe a little bit and then angle it more in a posterior direction and gently insert it, and this is what that looks like. So there's the normal sliding sign. I'm pulling it out slightly, angling it backwards, and there you can see posterior vaginal wall, and the probe is now going into the posterior fornix, and that allows me to see the pouch of Douglas and the bowel in a lot more detail. It's much easier this way to see bowel nodules. I'll just show you that one more time. There is the cervix in the longitudinal plane. I'm going to pull the probe out a little bit, then angle it more backwards toward the sacrum, and very gently nudge the cervix out of the way, stretching the posterior vaginal fornix over the tip of the probe, and now I can see the pouch of Douglas really clearly. So I'm in the posterior compartment now, and I'm looking for DIE. So again, draw the line where the bladder attaches to the anterior uterus. Then here is the internal os. Behind that is the torus. And then I've drawn a line past the external cervical os. This is the rectovaginal septum, where I've never seen endometriosis. Here is the posterior vaginal fornix, where I often see endometriosis. This is the peritoneum lining the pouch of Douglas. I've got, through this line separates out lower rectum from upper rectum, and that is at the point of the uterosacral ligament insertion on the cervix. And any bowel that's beyond the level of the uterine fundus is called sigmoid. So common locations for DIE in the posterior compartment are the posterior vaginal fornix, the retrocervical area of torus and uterosacral ligaments, and the rectum with the lower rectum and the upper rectum. But the disease is often multifocal and it can attach everything together, resulting in frozen pelvis. So the classification for bowel DIE is that superficial bowel endometriosis affecting the serosa only is not DIE. To have DIE, you need to have an involved muscularis layer. And as we just saw in the diagram, the lower rectum is below the torus, the upper rectum is above the torus, and it is this that is visible at laparoscopy, and the sigmoid is above the level of the uterine fundus. So here you can see the dark muscularis layer, and here you can see a very superficial nodule of endometriosis that's not made the muscularis layer thick, so it's not DIE. But here you will see a nodule of DIE in the lower rectum. There's the probe going into the posterior fornix, that's posterior vaginal wall, bit of fibrosis there, and here is a nodule in the lower rectum. It's connected to the posterior vaginal fornix, but not involving it, because you can see that the posterior vaginal fornix itself is very white, very dark and thin. So it's not thickened and it's not involved. And here you can see the bowel nodule, and this is the muscularis layer. If you look, overlying it is the submucosa, and it's white and it looks quite regular, so it's probably not involved. And this is the muscularis layer of the posterior wall. And when you put colour on, you can see this nodule does not have much vascularity, it's not suspicious. So this is an example of involved lower and upper rectum. Looking at the picture here, uterus in the longitudinal plane, draw that line of bladder, internal os, torus, and you can see that this bowel nodule affects both the level below this line, below the torus, which is lower rectum, and above it, which is upper rectum. And this is what that will look like on the moving image. There's the probe going into the posterior fornix. You can already see the bowel nodule. It's very large just there. I'll just let that play one more time. Coming into the posterior fornix, you can already see it. There's dense fibrosis behind the cervix and an attached nodule which stretches from lower to upper rectum. Here I've got a uterus with a very large plaque of endometriosis affecting the upper rectum and the sigmoid, and this is what that looks like. There's the uterus, and there comes this really thick dark plaque of DIE and the huge ovarian endometrium are all attached to one another. So this is upper rectum and sigmoid. Sometimes you see separate bowel nodules. So in this example, we've got nodules in the lower rectum and in the sigmoid colon. And I'll play this one. Here we are in the posterior fornix. The cervix is up there somewhere. And you can see sweeping from side to side, there's a very large bowel nodule there in the lower rectum, in the anterior wall. It was a nodule that's attached to the torus and the uterosacral ligaments, but it centers on the insertion of the posterior fornix to the back of the cervix. And then when we looked a little bit further, near the left ovary, as you can see, there are two nodules in the sigmoid colon. There they come again, just 1 and 2 there. You can see some normal muscularis in between. There's some normal muscularis there. So 2 nodules in the sigmoid colon and 1 very large retrozoical lower rectal nodule. How to measure a bowel nodule? A lot of people measure the distance from the anal verge, but I find this very difficult. The most common location for bowel DIE is at the torus, and at that point you're around 8 centimeters from the anal verge. What we do in Southampton is we measure the distance of the nodule to the torus, whether it's mainly above the torus, and that's upper rectum and it's intraperitoneal, or whether the nodule is below the torus, which is lower rectum or retroperitoneal. And this is where bowel surgery can be very difficult, and people often use a bowel surgeon for endometriosis surgery in this area. We then measure the nodule in 3 dimensions, length, depth and width, on 2D and on 3D, and it's important to measure the length of a lesion as a curved line if the lesion is not linear. I'll show you. We then measure the angle of the involved muscularis layer and the degree of affected circumference in the transverse plane, and these are markers for the risk of bowel stenosis from the lesion, and comment on submucosal involvement. So this is what it looks like. Here again is a retroverted uterus. The torus is around there somewhere, but you can see here that there is something attached to the back of the uterine wall above the level of the torus. And in this plane you can see this is the bowel nodule. There's some normal muscularis there. It becomes normal again here, and it's at here and here. So this is, and it's flat. You can see how this is entirely flat. And in the transverse plane, this is the normal bowel, and then this is the bowel nodule, and you can see it's less than half of the diameter there. You can also see the nodule of DIE in the very thick fibrotic torus uterosacral ligaments just attached to it. But this is a curved bowel nodule, and so you have to draw a curved line following the length of it. In this case, the angle here is 90 degrees or less, which is a worrying sign. This is the depth of the nodule, and you mustn't include the depth of the torus nodule. It has to be just muscularis. And then in the transverse view, you can see this is transverse bowel, and here you can see the endometriosis. And again, you need to measure as a curved line and work out whether or not it's what percentage of the circumference you think is being affected. And we suspect bowel stenosis if you have this kind of a mushroom nodule where the angle is 90 degrees or less, or if more than half of the circumference is affected, or if the AP diameter is more than 1 centimeter. These are signs suspicious for the nodule in the bowel causing bowel stenosis. You can also do 3D. If you look here at the bowel nodule, I've applied 3D to it and I've rendered that, and here I've got a nice bowel nodule, and there is the nodule, retrocervical nodule attached to it. I quite like to do 3D because it improves the view of the DIE in the uterosacral ligaments, and it gives you a nice submucosal view usually. You have an improved view to measure the width of the bowel involvement, which is, as I've said, a surrogate marker for stenosis. And you have to know that colonoscopy of this lesion, where the colonoscope comes in this way, is usually normal. So it's very handy to be able to look at it with 2D, 3D and 4D. If you rotate your image around, it gives you a slightly better idea that this lesion, as you can see, it's very, very retracted, might well be causing significant stenosis. So when I report on a bowel nodule, I'll say the number of bowel lesions and where they are, what the relationship of the nodule is to the torus. Is it below the level of the torus or above it? What is the size of the lesion, excluding any superficial disease? Saying the length, depth and width, the angle of the lesion, and then whether it's likely to be stenosing or not, and if there's submucosal involvement. And so you can see that on frozen pelvis, ultrasound can see so much more than a laparoscopy. Here we've got the back of a normal pelvis, a normal uterus, a normal torus and uterosacral ligaments. And here you can see a frozen pelvis where everything is glued together. And views of the pouch of Douglas are very challenging. You can't really see what's going on down there. Whereas on ultrasound, we could see that the sliding sign was negative. The ovary, the uterus, and all the bowel behind are all attached to each other. In this transverse plane, you can see an ovarian endometrioma and a normal ovary. They're kissing ovaries and they're attached to the back of the cervix. But then significantly on ultrasound, we can see that there was also a nodule of DIE in the bowel wall that was not visible at laparoscopy. Ultrasound can see deeper than laparoscopy. Looking for DIE in the bladder and ureter, I usually do this last because I ask people to come with an empty bladder, and so during the rest of the scan the bladder's been filling up a little bit, allowing me to see it better at this moment. So this is where I'm looking in the area of the trigone and the base, and looking at the lower ureters, and this is what it looks like. In a longitudinal view again, there's the urethra, there's the bladder, and that is where one of the ureters is inserting into the posterior bladder wall at the trigone. And I'll show you, I'm going to do in the longitudinal plane, I'm sweeping from left to right, and you'll see both ureters enter the bladder. So this is where you need to look. This is where the ureter there comes into the bladder. There it goes. Ureter into bladder. There's the urethra. I'm going out the other way now. And there is the other ureter. There's the left one. Passing through the urethra, out the other side. And there is the right ureter. This is how you know it's ureter. This is the lower ureter, and you can see vermiculation. Completely normal. It's like peristalsis of the bowel. And so this is urine that's entering the bladder here at the top of the trigone. And if you look transversely, it looks like this. So this is the right ureter entering the bladder, so the top of the trigone, This is a jet of urine seen on colour Doppler, and the other side is also emptying beautifully. So that's normal. This is DIE in the posterior bladder wall, and here you can see a huge lump of DIE in the posterior bladder wall. Quite unusual, and quite unusual to have it that badly. It's usually a lot more subtle. The ureters can also get involved with DIE. It can be at the point where they enter the bladder, or it can be much more commonly at the back of the cervix, and that's where you need to be looking. And most ureters that are affected by DIE is by external compression and fibrosis of the surrounding tissues, and occasionally it's muscularis in the DIE in the muscularis layer itself. And here you can see there's that ureter as it just comes out of the bladder. I'm tracking it laterally. There's the ovary, and there it becomes very wide. This is where it's being pinched. So you just go to the bladder and you look at where the ureter enters the trigone, and you track it laterally toward the pelvic side wall, toward the ovary, and then you have to look above the ovary. And you can see that here. This is the lower end of the ureter. This is as it's glued to the ovary, and it's dilated at this point, and you can see that here. You can see that the ovary is fixed to the pelvic side wall, and it is trapping the ureter there. And this is a 3D image. You can see this is the nodule of DIE in the pelvic ligaments. You can see these little tongues, protrusions of tissue as they're almost look like they're invading the ligaments. But you have to look above that, so you need to increase your depth of field to look above the ovary. And you know it's ureter. You may or may not be able to see vermiculation. It's not a vessel, because on colour Doppler this is what a vessel looks like, and this is not lighting up, it's the ureter. There's the DIE. This is a different case. This is a longitudinal view of the uterus. This is an adherent ovary, and here you can see a dark lesion that doesn't light up with colour. You can see a nodule there with fibrosis, and if you look at the video then you can see there's some vermiculation, and the ureter becomes very adherent here to the back of the cervix. And when I looked at this patient's kidney, you can see that she's got moderate hydronephrosis. This is yet another case where, again, this is in the retrocervical area, where you can see that there's a nodule of deep infiltrating endometriosis. This is it on 3D, when you often get a more clear view, and you can see the ureter is very dilated above it and normal below it. And this patient had severe hydronephrosis on that side. And this is usually silent and asymptomatic, so you need to go and look for it in women who have got DIE. Lastly, there is cutaneous DIE and malignancy arising in endometriotic lesions, but that's for another talk. Lastly, I look for soft markers, site-specific tenderness and pelvic mobility. The main thing to say is be very gentle. I do this at the very end of the scan, and I go through the pelvis systematically again, asking whether it's painful in this area whilst you're looking exactly where you're scanning, so you can see what is it that's so tender. You can gently press on the uterus and gently press on the adnexa, then the ovary, then the bowel, then the pouch of Douglas. Go around it in a logical sequence, looking especially carefully for if an area is very tender. Look for DIE, because you'll probably find some if you haven't already seen it. And judge mobility once more in all these areas. And this, if sometimes I put a hand on the abdomen, so in this case left hand on the abdomen, right hand holding the probe, and you can see this ovary is extremely mobile. They're not normally as mobile as that, but that's nice. So having gone through all the different stages, this is a live scan where we're going, again, breaking it up piecemeal and showing you what it shows for the report at the end. So here you can see a longitudinal view of a uterus with islands of endometrium in the myometrium, and that's adenomyosis. You can already also see adherent ovaries with endometriomas at the back. So this is at the very start. Here you can see these islands of endometrium in the myometrium, and you can see an adherent ovarian endometrioma at the back of the uterine fundus. In the longitudinal view, this is the right ovary, and it's an endometrioma, a unilocular cyst with no solid component and some ground glass echogenicity adherent to the back of the uterus. And this is the same seen transversely now. This is the transverse measurement of the right ovary, a beautiful view of the islands of endometrium in the myometrium. This is very bad adenomyosis. So right ovarian endometrioma, and you can already see a left ovarian endometrioma, and both the ovaries, they're kissing and they're attached to the back of the uterus. There's the left one. And you can see these ovaries are called kissing ovaries. They're adherent to each other, they're adherent to the back of the uterus, and there's normally bowel adherent to this area as well. Looking at the sliding sign, we're in the longitudinal plane again. This is where bladder attaches to the uterus. It's that white line there. There's the internal os, there's the torus. You can see white fibrosis here, and you can see bowel glued to the back of the cervix, and you can see it's glued to the back of that endometrium as well. So this is a frozen pelvis. In the transverse plane, looking at the area nearer the torus, I've got two nodules there of deep infiltrating endometriosis surrounded by white fibrosis. This was an atypical endometrioma. And here, again, I can see a bowel nodule. Now, there's the bladder, internal os, torus. So it's above this line. So this nodule is in the upper rectum. You can see some normal muscularis here, some normal above. And this is a bowel nodule with the overlying submucosa. It looks intact in that view. So it's upper rectum. And this nodule, if you keep looking up, is attached to the underside of this ovarian endometrioma. And you can see all that here. You can see normal muscularis there. This is the anterior wall of the lower rectum here. And then in the upper rectum, you can see this bowel nodule in the anterior wall. Looking at the submucosa. Now I'm looking at the bladder. You can see that the bladder is freely mobile on the front of the uterus. If there's a caesarean scar here, then the bladder might be a bit adherent. But I'm also looking for nodules of DIE in the muscularis layer there of the bladder, and in the space between the bladder and the top of the vagina or the front of the uterus. This is all areas where you might see endometriosis, but not here. And I looked at her kidneys and they were normal too. So looking at the whole pelvis now from left to right in the longitudinal plane, we've seen them all piecemeal. You can say that she's got a normal anterior compartment, including kidneys, adenomyosis, bilateral ovarian endometriomas, kissing ovaries, retrocervical nodules in the torus or uterosacral ligaments, an upper rectal bowel nodule of DIE, and a frozen pelvis. So the ABC of IDEA ultrasound, how I do it, I break it up. I have a systematic routine pelvic ultrasound, looking logically the same way at the different organs. Then I look for the sliding sign in the pouch of Douglas. Then I look for nodules of DIE through the posterior fornix. Then I do the soft markers, pelvic mobility and site-specific tenderness. But when you're learning how to do this, start by just checking for the sliding sign in all patients. And remember to be gentle. I've got lots of recommended videos and a book. You can screenshot this or come back to it later. And a lot of papers. These are the most significant papers, I believe, in the last 16 years on endometriosis. You can freeze the video, you can screenshot it. I would really urge you to read these papers. They're very good. And that's it. Thank you very much.
Lori Strakowski, and on behalf of the ORADS Ultrasound Education Committee, I would like to welcome you to our webinar series on ORADS for ultrasound. This first of 3 lectures will begin with a brief review of why we need ORADS, what is included, and when it should be used. We will spend most of our time together discussing how to implement in everyday clinical practice, including reporting, and then conclude with several case examples, bringing it all together. I have no relevant financial disclosures for this lecture. So why do we need ORADS? We are all well aware that ovarian cancer is a relatively lethal malignancy, and this fear of missing ovarian cancer has contributed to unnecessary surgery, yielding processes that turn out to be physiologic, non-neoplastic, or benign neoplasms. Ovarian cancer is statistically quite rare, whereas the morbidity associated with these procedures is not, occurring in up to 15% of women. We also know that women who have ovarian cancer will do better long-term when their initial surgery is performed by a gynecologic oncologist. So we want to get them in the right hands early on in their care. Now, radiologists have fallen into a pattern of using these non-specific terms, such as complex and heterogeneous, in lieu of more specific descriptors, which is just not that helpful. Combine this with the excessive use of the phrase cannot exclude malignancy, and our reports are too often misleading. For example, here are 3 lesions with very different prognoses, from spontaneous resolution to malignant behavior. The terms complex or heterogeneous may well apply to all 3. However, the conundrum these terms pose is perhaps best summarized by the quote that when a word has many meanings, it has no meaning at all. We can and should do better by using a standardized lexicon, by providing a risk of malignancy, and offering management options to optimize care. Other adnexal reporting systems exist, but none really offer all of this but ORADS. ORADS is one of the more recent additions to the ACR RADS groups, as ultrasound is considered the primary imaging modality for the adnexa and MRI reserved for problem solving. There are complementary ultrasound and MRI arms in ORADS. Each has its own lexicon with many shared terms, common assessment categories, offering unique ranges for risk of malignancy, and for ultrasound management options are included. So let's start with the assessment categories. Similar to the other RADS groups, we have 6 categories, 0 being reserved for the technically incomplete exam, 1 for the normal or physiologic ovary, 2 when a lesion is considered almost certainly benign, and then 3, 4, and 5 for the low, intermediate, and high risk groups. Now, the numerical values for range of malignancy, risk of malignancy for each category is listed here for ultrasound. These ranges are justified by data on over 5,900 surgically excised lesions that were studied by the IOTA, the International Ovarian Tumor Analysis Group, where we matched our imaging lexicon terms and then determined their predictive value for malignancy and benignity. The ranges for MRI are listed here for comparison and result from outcomes on over 1,100 cases studied by the European Society of Urogenital Radiology Female Pelvic Imaging Group. The greater specificity and performance of MRI is no surprise given the superior soft tissue contrast of MR afforded by the use of both contrast and diffusion-weighted imaging, making it an excellent problem-solving tool. Now, in terms of the management recommendations for the technically incomplete exam, we are going to recommend repeat imaging. You can start with ultrasound if you think that will be fruitful, but if you think for whatever technical reasons, you just need to go right to MRI, that is an option. What we don't want people doing is using the 0 category when you are uncertain of where to place a lesion. If an exam is technically adequate, we want you to make every attempt to place it into one of the other categories. Now, 1 is the normal or physiologic ovary with 0% likelihood of malignancy, and so no imaging follow-up is needed. For the almost certainly benign category with a less than 1% likelihood of malignancy is the only category here where management options are going to vary, and that is going to be based on the lesion type, features, menopausal status, size, even the level of diagnostic confidence. And the management recommendations may vary from none with solely clinical follow-up all the way to MRI evaluation. Now, the management recommendations for all the other categories are the same for the lesions within that category, except for this one. With the low risk category, with the 1 to less than 10% likelihood of malignancy, you are going to recommend another opinion perhaps by an ultrasound specialist if you are not that familiar with pelvic ultrasound, or you can get further evaluation with an MRI. But given the low risk of malignancy, these patients can still be managed by a gynecologist. Once we hit the intermediate risk group with a 10 to less than 50% likelihood of malignancy, the imaging recommendations are the same. However, now we want to get a gynecologic oncologist on board. For the high risk category with a 50% likelihood of malignancy or greater, you're going to refer to a gynecologic oncologist. Many people have asked why we did not include imaging recommendations for this category, and that's because we felt that most gynecologic oncologists already have their protocol for staging that includes some sort of cross-sectional imaging, so we did not want to be too prescriptive. Now, a nuance I want to point out with imaging recommendations for lesions in the 3 and 4 category is that the operative word here is "or," in that an ultrasound specialist and MRI may sometimes both be needed. However, when assessment of an ultrasound specialist, it may suffice, and so MRI is certainly not required for all lesions in these categories, particularly when it is considered unlikely to add anything. All right, so the elephant in the room, ultrasound specialist, who are they? What does this mean? How do I qualify? And most importantly, where do I get the nifty tattoo branded across my forehead? All right, in all seriousness, while a new term to most of us, the concept of ultrasound specialist has been studied and reported, confirming that with experience, ultrasound assessment of adnexal lesions is more accurate. This is nothing new, similar to expertise in any field of radiology. Those who do it often will do it better over time. This designation was not intended in any way to be condescending, but rather a nod to the fact that this is hard stuff. Even with 20 plus years of experience, I find adnexal lesions on ultrasound the most challenging aspect of imaging. We cannot and do not expect every radiologist to be an expert here, but with clearly defined terms, categories, and management recommendations, along with the option to capitalize on the experience of those who do this regularly, we can aim to keep women out of the OR who don't need to be there, optimize referral patterns, and use MRI in a more cost-effective and judicious manner. So the definition of the ultrasound specialist is a physician whose practice includes a focus on ultrasound assessment of adnexal lesions. This is self-designated. There are no mandated requirements, training, or certification. For radiologists, and I say that because there will be other practitioners using ORADs, but for radiologists, it will probably be common that they completed a fellowship in body or women's imaging that includes pelvic ultrasound, but again, this is not required. How this role of the ultrasound specialist plays out will probably vary by institution, whether this is a curbside consult or a formal second read, but again, this is just relatively new for us. So when to use ORADs? There's probably 2 major ways in which how this will be used. One will be you have the option to use it on every pelvic ultrasound. Advantages being you will get used to the system, and you can use one standardized pelvic report for that. However, that's probably going to be a little bit cumbersome for most practices. Most people will probably use it case by case. This is just more practical. However, we recommend that when you do this, that you definitely want to use ORADs whenever you encounter a non-physiologic adnexal lesion. Now, you can also use it for physiologic lesions, and we recommend this when you are performing high-risk ultrasound screening, perhaps in the BRCA mutation carriers, or when ultrasound is being requested for further evaluation of a finding seen on another imaging modality, such as CT. Now, you're probably also wondering, wait a minute, high risk, I thought we weren't supposed to use ORADs in this scenario. So good time to just delve into the how to use and start with our governing concepts, or our 8 rules. You need to know the rules whenever you play a game. And so the first one is that recommendation should function as guidance. Individual case management may be modified by judgment. The second one, management is for the average risk patient with no acute symptoms, However, if present, it's the management that may vary from this system. The lexicon, the assessment categories do apply to all high-risk and symptomatic women were included in the IOTA studies. We've already talked about the ultrasound specialist. We need to categorize every patient as pre or postmenopausal. Postmenopausal will be amenorrheic for 1 year or greater. For lesion size, what's going to be important is the largest possible diameter. That ORADS only applies to lesions involving the ovaries and tubes. So for instance, not exophytic myomas, an exception being the paraovarian cysts. And sometimes, particularly when lesions are really large, it can be challenging to determine their organ of origin. And so in these scenarios, cross-sectional imaging may help determine that origin. And so ORADS can be deferred in this setting. In general, we're going to base our assessment on transvaginal ultrasound, but this can be augmented by transabdominal or even transrectal. In some women, they may defer transvaginal. But if you can get adequate assessment on transabdominal, that would still be considered technically adequate. And so we can use, obviously, that information. Now, with multiple or bilateral lesions, each should be separately characterized with management driven by the lesion with the highest score. My next advice to you is that after you know the rules, you now need to keep these charts handy because these are essentially your scorecards. And these nice color-coded charts where we have similar color coding now for all of the RADS groups. You will see here that sometimes pre and postmenopausal, the management strategies may differ. For the classic benign lesions, they got a little bit more granular here, particularly for pre and postmenopausal, so they had to go on their own sheet. I recommend that you print them, laminate them, keep them next to your workstation or on the wall next to it. They're going to be really, really helpful. Now, for others of you who may think that this is a little bit cumbersome, we have good news, and that we do have a smartphone app that was recently launched. This is available on both iPhone and Android, and is part of the ACR guidance app. So you can search ACR guidance, ACR ORADS, or different iterations of those words. On iPhone, you will see something like this. If you go ahead and download it, you will see this is the ACR guidance app. There's information on contrast reaction, incidental finding. Hopefully more of the RADS groups will join, but right now we have ORADS. So if you click anywhere on this screen, you will first be asked the menopausal status. If I hit premenopausal, I then determine, do I think it's in the ovary, separate from the ovary? If it's in the ovary, and because I chose premenopausal, I'm going to be given some physiologic options first. If I choose lesion, I'm going to be given some of the classic benign lesions to consider. If I want to see images, I can click on this little icon and it will give me some classic demonstrations. I can use my fingers and spread on an image and make that larger. I can go back at any time. Let's say I think this is a hemorrhagic cyst. I'm next going to be asked what is relevant for risk stratification of hemorrhagic cysts, and that is these buckets of sizes. So if perhaps I clicked this size, I'm going to go straight to the ORADS category and the management recommendation. Okay, so let's do that now with a new finding, a little bit quicker, postmenopausal. Let's say it's extra ovarian and I think it's a hydrocele pain. So boom, I get right to that ORAD score, and it just took less than 5 seconds to get there. At any time, I can view a table of the other lesions in that category. There is this nice triple bar menu at the bottom where I can get some links to some useful information, including instructions on how to use the app. I can go to the risk stratification tables at any time where I can see those color-coded tables. I can even click this link and go straight to the ACR website with even more useful information. So with all of that good news, I do have a consumer warning that this is not AI or CAD. You can't wave your phone over your monitor. It still is going to require you to recognize these relevant features and to know and use the lexicon terminology. All right, lexicon, let's talk lexicon. We published this paper back in 2018, and there were just a few words. Okay, there were a lot. We got a lot of feedback about this. And so when we were looking at what was really relevant for risk stratification, we found that many of them just weren't. After we removed the synonyms, we combined some other terms, we found that we really could come down to an abbreviated lexicon that fell into these nice buckets. And if you follow an algorithmic approach, starting with, is a lesion physiologic? If not, does it have the descriptors that would make it a classic benign lesion? If not, which of the lesion categories does it fit in? And then at some associated findings, you could easily get to the category. So let's start with the physiologic lesions that clearly will only be applicable in the premenopausal woman. We start with the follicle, which is a unilocular anechoic cyst that measures 3 centimeters or less. If it meets this criteria, we caution you against the word cyst. That may portend a more ominous diagnosis. This is physiologic. It is just a follicle. The second finding that is physiologic is the corpus luteum. This may have a cystic appearance with thick walls. Sometimes those walls are so thick that you don't see that central cystic component and it may appear solid. Again, when it measures 3 centimeters or less, we just use the word corpus luteum. They often will have this robust peripheral vascularity, which we used to call the ring of fire. We're now going to use the word peripheral vascularity, particularly for those solid lesions or the solid appearance of a corpus luteum. That can be very, very helpful. Now, when it has that central cystic component, it is not uncommon to have a crenulated inner margin. Those luteinized cells can be very vascular, so it's also not uncommon to see these internal echoes that are blood products. You can even see a little bit of retractile clot that, right as we can see right here, that might have some concave margins. Now, very important, if you see something that does not have concave margins, you want to carefully interrogate with color Doppler, because if it has flow, it is not blood products as seen in this small early borderline serous cyst adenoma. Okay, when the descriptors are met for a follicle and corpus luteum, you can use those terms. You don't have to be more wordy. In terms of the assessment and management, these are ORADS 1, no imaging follow-up is needed. Let's move on to our classic benign lesions. There are 3 in the ovary. We'll start with the hemorrhagic cyst that we're going to use to describe those internal fine lines that are intersecting the reticular pattern. So this is what we used to call lacy, cobweb, fishnet. We're all going to be using the term reticular pattern. That retractile clot is when that blood congeals, moves over to the side. We can diagnose it when we see these concave or straight margins. Very important that there is no internal flow on color Doppler imaging. The dermoid cysts, also no internal flow, but we will see these hyperechoic lines and dots that represent coiled hair. You can see the hyperechoic component with acoustic shadowing. This is our Rokitansky nodule. And occasionally you will see floating hyperechoic spherical structures. Not very common, but very pathognomonic for a dermoid cyst. The endometrioma is the third lesion in classic benign lesions in the ovary, where the hallmark are these homogeneous low-level echoes. You can use the word ground glass. Ground glass was an iota term, but we included it here. They can be unilocular, they can be multilocular. Again, no internal flow. You can see flow in the surrounding ovarian parenchyma or in parenchyma that might separate 2 endometriomas within there, but they should have no flow within them. Now, in terms of the extra-ovarian lesion, we're going to start with the para-ovarian cyst, which is a simple cyst that is separate from the ovary. If it's difficult to tell if it's separate or just an exophytic cyst, you can use some gentle probe pressure to demonstrate that those are indeed separate. Now, para-ovarian cyst, that term is going to include paratubal cysts. They're both Wolffian duct remnants. So instead of having to say para-ovarian / paratubal, we're just going to say para-ovarian. But what's really important is that they be simple. If these cysts are not simple, then we want to assess them as per the ovarian lesion category. Now, hydrosalpinx are our fluid-filled tubes that you might see these incomplete septations that represent the folds. They should have a tubular configuration. Particularly in the axial plane, you may see these thickened endosalpingeal folds, and often cineclips will nicely demonstrate all of these features, confirming it's a hydrosalpinx. The peritoneal inclusion cyst is when you have a fluid collection with a normal ovary that is either at the margin or it can be suspended within this collection. And the reason it's there is because you have these adhesions, which look like septations that don't allow that fluid to be resorbed. And what's most important, though, is that it follows the contour of the adjacent pelvic organs and there is no mass effect. Now, in terms of the assessment and management for the classic benign lesions, for the extra ovarian cyst, size is not relevant when we're going to assess them. For the ovary, when it's less than 10 centimeters, all of these are going to fall into that ORADS 2 almost certainly benign category. And as I mentioned earlier, this is where there's going to be variable imaging follow-up. So you're going to have to look at this chart and see where it falls. Is she premenopausal or post? Because the management is going to differ. It's the same for dermoids and endometriomas. I want to point out that if you're going to be if it's not surgically removed and you're going to be getting annual ultrasound follow-up, that at a minimum would be for 1 year. There's some evidence to suggest that you can consider going up to 5 years with your surveillance. For the simple para-ovarian cysts, you have an option of a 1-year follow-up if they're postmenopausal. But for peritoneal inclusion cysts and hydrosalpinges, they do not need imaging follow-up. They can just be managed by or you can just go ahead and use the app, and that's going to take you right there. Now, when the ovarian lesions get bigger, they get 10 centimeters or greater, there is a slightly higher risk for malignancy, so they're going to bump up into that ORADS 3 low risk category, where you're going to recommend, again, another set of eyes, MRI evaluation, but again, they can be managed by gynecology. But I have to just reinforce that you have to yield to these descriptors, because if you don't, you may unfortunately upgrade a lesion. For instance, here are 4 examples of these classic benign lesions, and with the lesion all the way over to the left, you might want to call this solid appearing, or these unilocular cysts with solid appearing components, or multilocular cystic with solid component. First, you need to always check, does it meet these other descriptors? Because if they do, use them. It will take you to the correct diagnosis, category, and management. All right, let's move on to our lesions. There are 5 categories. The unilocular cyst without solid component, of which the simple cyst is a subcategory. Unilocular cyst with a solid component, multilocular without and with solid, and then the solid appearing, where if it has 80% solid tissue or greater, it's going to fall into this category. I want to start with the solid appearing because this is actually the most straightforward. First, we need to define that solid or the solid component of a cystic lesion will exclude blood, fat, cartilage, bone, or calcifications, because these are common in dermoids. Flow, if it's present, that confirms that it's solid tissue. And so if you are seeing flow, you can go ahead and just call it solid. But if it otherwise looks solid, but you don't see flow, which can sometimes occur, then you may choose to use the word solid appearing. When you have a solid lesion, the first thing that you want to evaluate is the outer contour. You have 2 choices for your descriptors. The first is smooth. When it is smooth all the way around, if it is not smooth, we are going to be using the word irregular, and that would include lobular margins. Now, if it is smooth, then you need to go ahead and assess the vascularity within the lesion itself. And for this, we have a grading system, which we have borrowed from the IOTA classification from 1 to 4, from no to minimal, moderate, and very strong flow, which I have schematic diagrams over here and examples of what this would look like in our solid lesions. Color score is also going to be relevant for the solid component within and the septations within multilocular cystic lesions. So I want to show you some examples right now as well. Now, some people have wondered, yes, color is operator dependent, so there are some technical considerations that we need to keep in mind, and that you want to optimize those settings. You can use some normal surrounding tissues like the uterus, the contralateral ovary to set your baseline. You want to use a low scale, appropriate gain. Important to keep that Doppler box, a small size. For instance, let me show you this example where this was a lesion. And at first, someone might think, oh, is this a hemorrhagic cyst? Is that just clot on the side? Because I don't see flow within there. But note that the size of that color Doppler box is just too large. We're asking too much of our Doppler. If we make that box smaller, and all I did was decrease the size of the box here, look at that robust flow, and that is indeed a solid component. Other things you need to be careful about are streaming artifact, flash artifact. Streaming is when you might, for instance, see a lesion like this and you think it might be flow, but on real time, what's going on is it's just this Brownian motion of these internal echoes. Note that we will see color Doppler when you have movement. And yes, there is movement within vessels, but there can also be movement just from these echoes. So you want to grab these cine clips, you want information from your sonographers that things were actually moving. Flash artifact can be when your scale is too low, or when, for instance, the patient, just with their breathing, you don't know, is that from the motion or is that real flow? And this is where spectral can be really helpful in differentiating between artifact and true flow. But that is really the only role of quantitative Doppler at this time. Now, for assessment and management of solid lesions, if you have an irregular outer contour, that is bad enough to put it into this highest risk category of ORADS 5 high risk. If it has a smooth outer contour is when you want to look at color score. And so your ORAD score may range from 3 to 5, depending on the amount of flow within there. We do not expect anybody to memorize this, so you're going to be looking at the charts for wherever we mention solid lesion. It's going to tell you what that color score needs to be to take you to the category, or again, you can use the app. Let's move on to our cystic lesions. And other than the simple cyst, these are what, whenever it had something going on, right, a septation, a solid component, we would just lump them into the term complex cyst, but we're not going to use that anymore. We're going to be more specific. The first thing you want to evaluate when you have a cystic lesion is for the presence of septations, because if there are no complete septations, it is considered a unilocular cyst. However, the presence of one complete septation or many is all considered a multilocular cyst. If, for example, you've got to be careful though, if you're trying to decide, is this a true septation, that you have to take a look and not to confuse that with this cyst and assist appearance, which is partial volume averaging of a support follicle with an adjacent either follicle or cyst. And so if you find that it is contiguous with that ovarian wall, that is very important. Other times you might see this linear structure here and wonder, are these two adjacent cysts? Is this a septation? And so what's important here is to look at how that ovarian tissue, if it crawls into that area, that is what we call the figure of 8 sign, indicating that that indeed is two adjacent follicles or cysts and not a true septation. True locules, as we see here, are not contiguous with the surrounding wall. Sometimes they even come off of other cysts. We then want to assess for the presence of any solid components. Those can be attached to the wall or mural. They can be attached to septations. A specific category of a solid component that becomes important in the unilocular cysts are the papillary projections. A papillary projection is defined by one that protrudes into the cyst lumen that measures 3 millimeters or greater. And then if it is surrounded by fluid on 3 sides, we have to look at its attachment to the adjacent wall or a septation. Or I like to think that, does it have acute angles with that interface? If you see a papillary projection, then we have to count them, but just in major buckets of, are there less than 4 or are there 4 or more? So in terms of our assessment, our cystic and solid lesions, these are going to be our highest risk lesions, right, in our 4 and our 5 categories. For unilocular cysts, it's all about the number of papillary projections. Either the solid component does not meet criteria for a papillary projection, or there's less than 3, and that's an ORADS 4. 4 or more papillary projections puts it into an ORADS 5 category. With a multilocular cyst that have a solid component, it is all about color score, but into one of 2 buckets: no to minimal flow, or moderate to very strong flow to put it in 4 or 5. But again, you're going to look at the charts wherever we mention cystic with solid, or use the app and it will take you there. So that is all of our cystic lesions with solid. We now have our cystic lesions without solid. And now it becomes important to assess the inside of it. So what is going on with those internal walls and septations? Again, our terms are smooth for the inner wall or the septations. If they are not smooth, we are going to be using the word irregular. What's important regarding the wall is that if you see some focal wall irregularity, you want to measure it because it has to be less than 3 millimeters to be considered focal wall irregularity. If it becomes 3 millimeters or greater, it is then either a solid component or a papillary projection based on its interface again with that adjacent tissue. For the septations, there's really no size criteria for making it irregular. That is a subjective occurrence. Now, if it is smooth, you then need to assess the internal contents for the presence of echoes. If there are no echoes, it is anechoic. We are going to be calling it simple. And if it is unilocular anechoic with smooth inner walls, that is a simple cyst. And you can just use the word simple cyst with without these additional descriptors. Non-simple would be when you are seeing scattered echoes. So these are internal echoes that do not meet criteria for homogeneous low level or the hyperechoic lines and dots. If you see an incomplete septation, that would also be considered a non-simple cyst for ORAD's categorization. So our assessment and management of the cystic lesions without solid. When there's not a solid component, these are never going to get high enough to go into that ORADS 5 category. They're going to be 2, 3, or 4. So unilocular needs to be smooth inner insides, small, and so small we're going to consider less than 10 centimeters. Those are going to go into the ORADS 2 category. But anything opposite of that, irregular or 10 centimeters or greater, is going to bump it up to an ORADS 3. For the multilocular, again, smooth and small, but now we look at color score. Anything less than very strong flow takes it into an ORADS 3 low risk, but anything opposite of that, irregular or 10 centimeters or greater or very strong flow, takes it into ORADS 4. Again, we're going to look at those charts for wherever we mention cystic without solid, and probably much easier to just use the app. Now, I want to pause for a second and talk about this ORADS 2 category, in that there are both simple and non-simple cysts that fall into that unilocular category. These, again, get very granular with size, menopausal status, so you're going to have to look here at these charts, but again, the app is going to take you there. So what we have just done is this algorithm that we're now going to review, that you're first going to decide, is it physiologic, follicle, or corpus luteum? That's all you need to look for. Next, is it a classic benign lesion? If it's extra ovarian, that's all you need to assess. Size and everything else does not matter. If it's ovarian, we're going to consider menopausal status and size. If it is a lesion, is it solid or cystic? If it's solid, we look at the outer contour. Smooth or irregular, irregular is bad enough. If it's smooth, we look at color score and then you stop. If it's cystic, we look for the presence of septations and then solid components. If there's solid components, we're assessing number of papillary projections or color score, but that is it. It's those cystic lesions that have solid components, no solid components, that we look at the inner walls and septations, smooth or irregular. If they're irregular, they're bad enough. The smooth ones, we look at a couple more and then we stop. So as you can see, color score is only relevant in some lesions. Our solid, smooth, multilocular cysts. Size is only relevant in certain lesions, and menopausal status is only relevant in certain lesions, but not for every lesion. So probably looking at it like this, you see this is a very manageable system to apply. Now, a caveat or two to scoring is the presence of ascites or peritoneal nodules. That's going to convert any 3 or 4 lesion into an ORADS 5. But very important that this ascites be unexplained. So she can't have ascites due to another etiology, so like from cirrhosis perhaps. If you are seeing a lesion that you would otherwise characterize as an ORADS 1 or 2 and you're seeing ascites or peritoneal nodules, you should really be considering other malignant or non-malignant etiologies, because we know those exist. For instance, like TB, can present with both ascites and peritoneal nodules. For ORADs, our definition of ascites is going to be fluid extending beyond the pouch of Douglas or the cul-de-sac that's above the uterine fundus when it's antiflex, or anterior superior to the uterus when retroflex. These the peritoneal nodules or thickening can be focal, it can be diffuse of the lining, it can be seen along the bowel serosal surface or along that peritoneal lining. So what do we need to do? Well, and I'm going to say differently because hopefully we've been doing a lot of these things, but some things are going to be new to all of us. Hopefully we've all been getting cine clips through and through in orthogonal planes. So important to take a look what is going on. Is there any little focal wall irregularity? We want to make sure we're turning on lesions to get their largest size, and we want to optimize those Doppler settings. Perhaps something new is we really need to discern focal wall irregularity from a solid component from a papillary projection. To do this, we need to start measuring the height of protrusion into the cyst lumen. This is at least something I was not doing before that now we're definitely starting to do. You then want to assess the attachment to its wall or its septation, and then if there are papillary projections, we need to count them. But again, you don't need to go crazy. Just is it less than 4 or are there 4 or more? We need to apply color Doppler to all smooth solid lesions and all multilocular cystic lesions, even when there's not a solid component. Color is going to matter on the septations in multilocular cystic lesions, and we need to stick to that lexicon, and I cannot underscore that enough. Now, what do we not need to do? Well, we don't need to stress over lesions that don't neatly fit into one category. I find that when that happens for me, I just kind of play with the possibilities to see what's going to happen. So for instance, here is a lesion that I think we can all agree is a multilocular cystic lesion. And I might say, well, I'm not really seeing any solid component, but those septations look a little bit irregular. So that's going to fall into an ORADS 4 category. But perhaps my colleague says, or maybe on a different day, I go, those are just a little too thick for me. Maybe that's a solid component, but there's no color on that. But guess what? That's also an ORADS 4 category. And so when you do this, you're going to find that often the score, the management rarely differs. If they do, we recommend that you use that higher score just to be cautious. So how to report? Well, I have bad news that right now we don't have any prescribed templates. And that is because when we tried to create them, we found that in order to, if we listed all of those options, the reports were just too lengthy and cumbersome. It's not like TIRADS where you are looking and have to report on the same features for every lesion. If you did that, you're going to have a lot of not applicables because, again, color score doesn't always matter for every lesion, outer contour, inner walls. And so what we're really recommending is you just modify your existing pelvic ultrasound reports when you are using ORADS for a lesion. In general, we're recommending less is more. You want to use that lexicon terminology and then report from most to least worrisome. Somewhere in the findings, you need to report the location, the laterality, is it inside the ovary, is it separate from the ovary, only those relevant features, the outer contour, the inner walls, when color score is appropriate. You do have additional descriptors in that from that original lexicon paper that you can use, but those are optional. You want to give it size. The maximum size is required, but some people might say, well, in our institution, our gynecologists want 3 sizes reported. That is fine as well. And then associated findings when they are present or when you believe they are relevant. In terms of the impression, it should be a succinct summary. You want to mention the ORADS category and the management recommendation, but by using the words, the numbers are optional because we don't expect people, our referring clinicians, to remember those numbers. You can use the numbers alone, but then you're going to have to use these reference tables, and you have the option to include the percentages for the risk of malignancy. You also have the option to include a link to the risk stratification paper, which might be a helpful resource for your referring clinicians. I want to refer you to the ACR ORADS website because when you go here and look at this educational resources, there is a section with templates that says sample reports. And so instead of templates, we have this nice 7-page Word document where we have the essential components of a report, and then we give you 10 examples of what that that might look like if you like to dictate in prose or in table format, when there's one lesion, when there's multiple, just to give you an example of how you might want to report. So let's go over some cases now. We're going to start with this first case, which is a 35-year-old woman with pelvic fullness. We see we have a cystic lesion. It appears unilocular, and I've got some solid components that look like papillary projections. I'm going to count how many, but that is all I need to do. I look on my table. I know this is probably going to be bad, but if I scour it, I come across the 5-category unilocular cysts, more than 4 papillary projections. Again, size and color score does not matter. If I were to use my calculator, I'm going to go ahead and click here. She is premenopausal. It looks like it's in the ovary and is a lesion. And then it's unilocular, and I've got solid components. You see, I'm asked about the number of papillary projections, and it takes me to the ORADS category. I want to point out here this nice little bar. We call this our breadcrumbs. If you look here, it's been tracking all of your selections. So when it becomes time to dictate, all you have to do is look at that bar, and it's going to tell you the important features that you need to dictate. It's also really helpful because if you want to go back and play with it or change something, you can click right here on any of these and it will take you back to that page. So in the report, in the findings, I might say something like, in the right adnexa, there's a unilocular cyst with innumerable papillary projections. I'm giving all 3 measurements right here. As no normal right ovary is seen, this is presumed ovarian. No ascites or peritoneal nodules. I think that might be relevant with this lesion. In my impression, I'm going to summarize 10.5 centimeter unilocular cystic lesion, more than 4 papillary projections, high risk ORADS 5, refer to gynecologic oncologist. Here I'm showing what the reference table and the link would look like. All right, case 2, 18-year-old woman, positive beta HCG, palpable right lower quadrant mass. You might be thinking, oh, could this be an ectopic pregnancy? But she was virginal, so we actually could not perform transvaginal assessment. Transabdominally, we see that there is this very large lesion that looks solid. It's measuring 18 centimeters. With color Doppler, we see it is indeed solid. So it's got vascularity. I don't need to use solid appearing. This is solid. It has an irregular outer contour. I look at my scorecard, and right there I see solid lesion with a regular outer contour. Again, any size, any color score is going to give me a 5. I can use the app. I'm going to show you how, again, that works. She's premenopausal. It is in the ovary, a lesion. I go to solid with an irregular contour, and I get to 5. Again, this took me about 5-7 seconds to get there. So ORADS 5, refer to a gynecologic oncologist. In my findings, no normal right ovary is seen. Solid adnexal lesion with an irregular outer contour, measuring up to 18 centimeters. Again, no ascites or peritoneal nodules. You can add more if you want. You can comment on that it's moderate internal vascularity, the color scoring, give 3 measurements, but you don't need to. I just want to show you that there are options here. In the impression, I'm going to summarize. It's high risk, recommend referral to gynecologic oncology. Now, if you are familiar with what this might be in the setting of a positive beta HCG, you can go ahead and dictate concerning for germ cell tumors such as dysgerminoma, which this turned out to be. And this might be how an ultrasound specialist report might look, but it doesn't need to be. Note that even when I am not putting any number here for ORADS 5, this is still an ORADS report because I am using the lexicon terminology and giving the management recommendations. All right, case 3, 40-year-old woman infertility evaluation. I'm going to show you a cine clip here. It looks cystic. I don't see septations or solid components. It has a nice smooth inner wall. It's measuring 7 centimeters. So I look here. This is a simple cyst. It falls into this bucket of greater than 5 but less than 10. I scoot over to my premenopausal. It's giving me a follow-up in 8 to 12 years and weeks. Yes, this is slightly different than SRU, but we felt that it was important that many women might worry about this. Most of these are going to be physiologic and they're going to resolve. And so in order to ease anxiety, and many women may forget to come back in a year, we are recommending follow-up in 8 to 12 weeks. But I want to remind you of our first rule, and that individual case management may be modified by judgment. She is 40. This is for infertility evaluation. Maybe she can't afford 8 to 12 weeks to wait for that follow-up. So in my report, I'm going to comment, it's a simple cyst. I'm going to recommend that short-term follow-up no later than 8 to 12 weeks, but sooner as clinically indicated, because that would be appropriate in this setting. All right, case 4, 34-year-old woman with pelvic pain and bloating. I see this lesion. To me, it has homogeneous low-level echoes. There's no internal flow. You might wonder, is this a solid lesion? Sometimes solid lesions don't have internal flow, but I also see this other important finding in that I see this fluid level. Now, how do I call it a fluid level? It's going up and down. Well, remember, with transvaginal imaging, the interface is always at the top of the screen. So this is where the belly and the buttocks really are. And so really, this is a dependent level. So just to keep that in mind. There's another important feature I'm seeing here, and these are these peripheral punctate echogenic foci that are very common in endometriomas. Now, this lexicon, this was not in the lexicon, peripheral punctate echogenic foci, but it doesn't need to be. All we need is homogeneous low-level echoes without internal flow to tell us this looks like a typical dermoid. It was less than 10 centimeters, so I'm going to be looking here. Let's review our options. If you are not 100% sure, you think maybe this is an acute hemorrhagic cyst, again, you have the option for a short follow-up in 8 to 12 weeks. If you are confident, you can add, if not surgically removed, annual ultrasound follow-up should be considered. If this is your follow-up and you see that it is changing morphology, it's developing a vascular component, this is where we cannot give an ORAD score because this is all of ORAD's is data supported, and we do not have data on this, but you can go ahead and use the descriptors and the recommendations, which is for additional imaging. Okay. In our report, I want to show you what it might look like if in your institution you like using more of these table formats with the side, the descriptors, the maximum size. Again, you can add about the level and the echogenic foci if you choose. Our impression, though, is 7.2 centimeter endometrioma, almost certainly benign, and I'm going to recommend follow-up in 1 year. My last case here is going to be a little bit more difficult because they're not going to be as straightforward as what I showed you. This was a 36-year-old woman with bloating. When we look transabdominally, we see this fluid. Now, no, that is not her bladder. Her bladder is actually decompressed right here. So this fluid in this slightly red fluid is actually ascites. When I look in the right adnexa, I'm seeing what looks like a solid lesion. I know that most solid adnexal lesions turn out to be myoma, so we're going to apply some gentle probe pressure and see that these don't separate. This is truly in the ovary. This is a solid ovarian lesion. So I know next what I need to look at is the outer contour. I look all the way around, it's looking smooth to me. So now I need to look at color score. There was barely any flow that we could see. This is very minimal flow. That would be a color score 2. Now, there is another important feature that I see here, and that is this, right? This is posterior shadowing. Shadowing for solid lesions was actually in the original lexicon paper. It was not in the risk stratification because we didn't want to make it too complicated with this first edition of ORADs. But when I see this, I am thinking about a sex cord stromal tumor, particularly a fibroma. And I know with the presence of ascites and sometimes pleural effusions that this can be Meg syndrome. All right, so what would happen if I used the calculator here? And so let's click on this. She's premenopausal. It's in the ovary. It is a lesion and it is solid. I have a smooth outer contour with minimal to moderate flow. Now this becomes this important question. Whenever it's going to be taking me to a 3 or 4, you're going to be asked this question about unexplained ascites or peritoneal nodules. If you recognize that if you don't recognize this and you say, no, this is unexplained, unfortunately, this is going to take you to an ORADS 5. If you do recognize this condition and you hit no, it will take you to an ORADS 4, where again, if you're a specialist, that's good enough. If not, you can get an opinion from somebody or get MRI for further evaluation. But I want to show you this case because this is where MRI really shines. So just like with ORADS, for ultrasound, For ORAD's MRI, there is a similar color-coded table that we have, and right here for the 2 almost certainly benign category, we have lesions that are solid with these specific features where they're dark T2, dark on diffusion-weighted imaging, and homogeneously hypointense on T2. This is an example of dark on T2 with some fat sat and diffusion-weighted imaging. This is great because it can take an ultrasound ORADS 4 category all the way down to an MRI ORADS 2 with a less than 0.5% likelihood of malignancy. So what might the report look like? And it's going to depend on who's reading this, right? So if I, as the expert, might say, in the right ovary, I've got a solid lesion with a smooth outer contour, posterior shadowing with minimal flow, small ascites is seen. I think this is suggestive of an ovarian fibroma with MEG syndrome. I don't even recommend referral to gynecology. I don't even have to put the ORAD score here. If you think it probably is, so you didn't choose the unexplained ascites, but you don't have someone to ask, or you want to get an MRI, you might place it in the intermediate risk and recommend MRI. But you know what? The MRI is gonna resolve it and put it in the lower category. Let's say you weren't familiar with this at all and didn't know about the shadowing or the ascites, and you might end up in this high-risk group. Again, your gynecologic oncologist, as long as you are using those lexicon terms of solid with smooth outer contour and minimal flow ascites, that's going to ring something for the gynecologic oncologist who's going to recommend the MRI and get there. So again, ORADs might look different to people with different levels of experience, but in the end, the right thing will ultimately happen for the patient. So in summary, ORADs is both a lexicon and a tool for risk stratification. Ultrasound is for our first-line imaging, with MRI reserved for problem solving. The approach should be physiologic, if not classic benign. If not, which of the 5 categories of lesion does it fit into? Learn the lexicon, let it guide you. It will take you there. Use those charts or the app. I'm going to give you an opportunity right now to pull out your phones and just barcode this in. So if you have not downloaded the app, do so. This is going to be life-changing and make life so much easier. In our reports, they should be short and sweet with the relevant features using that abbreviated lexicon, but that's at a minimum. You do have additional terms available to you. But just if you could start using it and start eliminating complex and heterogeneous, that would be a great start. The impression should include the category and the management, but again, the wording is what is important for both category and color score, not just the numbers, because people are not going to remember those. So coming up, we are going to have some more webinars here with some great cases by Dr. Phyllis Glantz, and then some frequently asked questions by the chair of ORADS, Dr. Rochelle Andriotti. It's very important that you send us your ORADS questions to this website so we can answer them, and that this is how we can make ORADS better for future editions. For CME credit for this particular webinar, you can obtain a full credit, but you have to complete the post-evaluation and post-test questions. Participants must receive an 80% or higher score on the post-test, but I know you're not going to have any problem answering those. So I want to thank you very much for your attention. I know this was a little bit long, but I hope you will be excited and enthused to now go ahead and apply ORADS. Thank you.
I'm Dr. Ted Lyons from Winnipeg, Manitoba, Canada. I'm going to be talking today about postpartum bleeding and focus on some of the things that are of concern and may be difficult in the clinical situation, such as retained products or even AV malformations. I have no commercial associations, and most of the photographs have actually been taken myself, so I give myself permission to use these. Late postpartum hemorrhage, either from spontaneous vaginal delivery, therapeutic abortion, or spontaneous abortion.
Is there a normal amount and duration? Yes, there is. There's a gradual decrease in flow and change in color from red to watery pink. And it may last up to 2 to 3 weeks, but it's abnormal if anything lasts more than 2 weeks postpartum. If there's persistent bleeding, or even if there's stop and then start several weeks later, those are all abnormal. So what are the causes of postpartum bleeding? Well, continuous bleeding may be due to a failure of the endometrium from which the placenta came, the failure of the endometrium to regenerate, or subinvolution. You can also obviously have retained products. In a start and stop situation, endometritis, inflammation, or an invasive mole, gestational trophoblast disease, and also AV fistula or AV malformation. But you have to watch out for that, and we'll talk about that later. Well, why is it important to get the exact cause of the bleeding correct? Well, obviously, it's important because there are different treatment options with each one. So delayed endometrial regeneration, you don't do anything. You wouldn't go in and do a D&C on something where there is a normal placental bed, but it just hasn't regenerated quickly enough. Retained products, obviously, with tissue in there, you're going to want to remove it, so a D&C. Endometritis is inflammation, and antibiotics are important. An invasive mole, hydatidiform mole, needs methotrexate. And finally, the AV fistula or malformation, which may be traumatic or post-traumatic, angiography is very good to assist in the diagnosis and also in the treatment with embolization. Or you may just simply want to watch it. Bottom line is you've got to treat the patient, not just the image. In unexplained postpartum vaginal bleeding, it's really important to use color and to use spectral to see where there is flow and to track the velocities. Very high velocities are of concern. Delayed regeneration of the endometrium. Here we have a coronal view of a uterus, and there's a spot that I have identified that was where the placenta implanted, and there's bleeding from it. So it presents with persistent bleeding, probably due to subinvolution. The endometrial bed, the endometrial defect that was the placental bed has not yet re-epithelialized and has not gone back to its normal state. So the endometrium and decidual basalis have not regenerated the placental site. Usually, as you would expect, the ultrasound is negative. You don't see a mass, and there's no increased color velocity. Obviously, conservative therapy. There's nothing to do other than to wait and see. Obviously, a D&C is not only not necessary, but would even be counterproductive. So a typical case might look like this. Nice normal uterus, anteverted, nice endometrial canal, normal endometrium, and the myometrium. Retained products of conception. It usually presents with persistent bleeding, and here I've drawn a retained cotyledon from the placenta. Well, in a complete abortion, clinically, there is no bleeding. Ultrasound, no mass, endometrial fluid, or increased vascularity, and the uterus is non-tender. So here's a nice case of a complete abortion. She did have a gestational sac at 6 weeks. Now it's all gone. Now there's normal vascularity. So there's no retained products. But how would that compare to a situation where there is retained product. So here's a patient who is bleeding at 11 weeks menstrual age. She was passing clots. You look in the endometrial canal, and there's normal vascularity. So it's a thin stripe, no significant increased vascularity. Empty uterus, no increased vessels. Again, another complete abortion from a early pregnancy that we had seen 2 weeks prior, a nice normal 8-week pregnancy that aborted spontaneously. So in retained products, what are the findings? Well, clinically, they almost always have bleeding, and they may well be passing some tissue. The ultrasound examination within the endometrial canal, you can have a wide endometrial stripe, you can have a mass, or you may see nothing at all. Color and spectral is critical. You may see a single or a group of vessels and usually have high velocity flow. It can actually be very striking how high the flow velocity is, and it may generate a lot of concern, but remember, it's usually a normal finding to have high velocity flow in retained products. The uterus is non-tender on pelvic examination. We always look for tender uterus or tender adnexa that might give us a clue to what the actual patient's problem is. Not everybody does this, but I think it's very, very important. In cases with endometritis, pain and a tender uterus is very, very important. So if you have retained products and you also have some infection that can happen, you have vaginal bleeding that may be persistent, you often have an echogenic mass in the canal, remember it can be retained products or it can just simply be a hematoma, and they may be difficult to differentiate, although the hematoma will not have any internal vascularity. You will have focal increased vascularity in retained products, obviously, but not in hematoma. If there is infection as well, pain and tenderness will give you the indication of endometritis. If you don't push on the uterus and ask the question, does this hurt? Then patients will not be able to tell you that it's tender, and you will miss the diagnosis of associated endometritis. So it's very important to ask the question, does this hurt, when you're pushing on the uterus or the adnexa? So here's a case, a patient who has bleeding. You can see there in the central endometrial canal a mass measuring about 17 millimeters in diameter with increased vascularity. The uterus was non-tender, so you have bleeding, you have a mass, you have vascularity in a non-tender uterus. This woman was 3 weeks postpartum, passing clots. She has retained products, and the treatment is a DNC. A woman who had a therapeutic abortion at 5 weeks menstrual age, gushing blood, has this large echogenic mass identified by the arrows. She had retained products at pathology, and you can see on the color Doppler that there's tremendous increased vascularity in that mass. So the mass, the increased vascularity, and the clinical situation of a patient who is bleeding following a therapeutic abortion are all indicative of retained products, and that's what it was. I mention this specifically because many centers use just 2D ultrasound and don't always use endovaginal, and endovaginal is critically important, but also is color and also is identifying focal areas of tenderness. Another patient, 3 weeks after a spontaneous vaginal delivery, had an area of increased echogenicity, tremendous increased vascularity, so obviously we're thinking about retained products. And here on a video, you can see the area of increased vascularity in the fundus, an area that is common to have retained products, and when you do the spectral, you can see high velocity flow over 100 centimeters per second and even up to 160 centimeters per second. So retained products. A woman who had a therapeutic abortion 6 weeks ago, continuous bleeding, does she have retained products? You look at this scan and you say, well, you know, I'm not sure if there's anything going on, but look carefully. There is an area of increased echogenicity in the myometrium anteriorly, and there was increased vascularity and high velocity flow. So whereas the 2D image was perhaps a little bit subtle, the color turns you on to the fact that she has retained products. And in fact, at DNC, they had retained products. So retained products has a variety of appearances. Here's another patient, 30 weeks. She's 4 weeks postpartum, post-cesarean section, with bleeding and a very subtle mass. So here you see this beautiful triangular shaped defect, typical of a previous cesarean section. You may not have really appreciated this echogenic mass up in the fundus. Here it is highlighted, but that echogenic mass was retained products. You turn on color, you have an area of increased echogenicity, and at DNC this was retained products. So she had a mass, pain, a mass, bleeding, and increased vascularity. Sometimes it's very difficult. This 35-year-old woman has been bleeding for 2 weeks after a spontaneous abortion at 19 weeks. Does she have retained products? That's usually the question that they ask. Does she have retained products? You look at that, and the uterus is certainly bulky. The endometrial canal looks empty. But what about this area? It is heterogeneous. Is this an area of retained products? She actually had an area of increased vascularity right in that subtle area. So we suspected that she did have some retained products there. Again, more based on the area of increased vascularity. And this, in fact, at DNC was proven to be retained product. So there's a wide variety of appearances of retained products. Here's a patient who had a therapeutic abortion 6 weeks ago. She had at the time a 5-centimeter corpus luteum cyst, and it was felt to be useful to follow up the cyst. She's on day 5 of a rather heavier than normal period. Other than that, she's had no symptoms. Sonographically, on sagittal view, you see nice endometrial canal. Transverse view, similar, nice endometrial canal, nice myometrium. Nothing really exciting. But you turn on the color, and here you see again an area of increased vascularity extending down to the endometrial canal. And there was some increased vascularity. So this patient actually had a DNC and had a small area of retained products. I suspect this is far more common than we actually see, small areas of retained products. And is treatment always necessary, or will these actually resolve spontaneously? So to treat or not to treat, that's the question. Most gynecologists treat the symptoms. You don't treat the images, you treat the patient, you treat the symptoms. If there are ultrasound findings of retained products but no bleeding, do you watch and wait? Most will. Except if there is a large mass and signs of myometrial invasion, and that should be monitored closely on ultrasound. And obviously, if you have tenderness, signs of infection, uterine tenderness, they're going to want to give antibiotics. You're never going to know if that uterus is tender unless you say the words while you're pushing on the uterus, does this hurt? Is it tender? Here's a wonderful example. 35-year-old girl at 15 weeks, bleeding. Is this an incomplete abortion? Is there retained products after an abortion? She has an area of increased, an area increased in, she has tissue, or she has echogenic material within the endometrial canal that has no vascularity. So is this an incomplete abortion with products of conception in the lower uterine segment, or could this just simply be a blood clot? Again, treat the patient. She was bleeding. They did a DNC. This is a very interesting patient. She was absolutely asymptomatic 3.5 months postpartum. Maybe she had a little bit of spotting, or else she wouldn't have come to ultrasound. We saw this large mass, echogenic mass with no increased vascularity, situated right in the endometrial canal. When I called the doctor and I said, there's something going on in there, she was absolutely amazed. She said, are you sure? Because this woman is absolutely asymptomatic. No, I said, there's definitely tissue there. She said, well, okay. They did a DNC, and there was retained products. Most unusual in a woman with very, very little symptoms for such a large mass lesion. She had, again, the mass, but really very little bleeding, not a lot of increased vascularity, and non-tender, but she did have retained products. Another patient, 9 weeks post-cesarean section with bleeding, passed clots 2 days ago. Well, you do the scan. Endometrial canal is not bad, no real increased vascularity. So it looks pretty normal. And in this patient, you may well want to just simply, again, treat the patient. She's not having a lot of symptoms other than some bleeding. She may well be treated, and was treated, conservatively. A 29-year-old patient, 12 weeks, but no bleeding. She has passed clots, but there's no bleeding right now. She has a wide endometrial stripe and some increased vascularity. She was pregnant. Here is a 5-week pregnancy. She had a therapeutic abortion. And the question is, what do you do? Well, this was her again with a large empty gestational sac. So on the sequence of events, she had an early pregnancy with a large yolk sac. Now she has a failed intrauterine pregnancy, and so you're going to want to monitor it. She actually passed the sac. Here is where the implantation was, where that increased vascularity, and here you see that area of retained products is where the implantation site was originally. So there's good correlation. She had retained products. She doesn't have any bleeding now, so how are you going to actually treat this patient? I think that this, and here you can see the vascularity on the cine. You can see the increased vascularity on the posterior wall, which was the site of the retained products. This particular patient, they watched her. She had no clots in the last 7 days. The endometrial stripe is now thinner. The question is, was there any increased vascularity? And in fact, there was some persistent increased vascularity. And she had some retained products, no mass, just the vessel only. 1 week later, no vessel. So was this really increased? Was this really retained products? Or can you just see a persistent vessel that may in fact resolve on its own? And do you always need treatment? So regardless of what the ultrasound may show, you got to treat the patient. And so she had conservative treatment with resolution 2 weeks later. Another patient, 12 weeks, menstrual age, bleeding, past a fetus. Does she have retained products? So she has a widened endometrial stripe with no increased vascularity. She had a DNC the next day. They had decidual only, but no evidence of retained products. So she had the DNC because she was bleeding, but we didn't see any increased vascularity here. A woman who was 22 years old, had a therapeutic abortion at 9 weeks. Some bleeding that has now decreasing, so does she have any retained products? So she has a widened endometrial stripe, she has some echogenic material, no increased vascularity. How are you actually going to treat this patient? She has no bleeding, she has maybe a little bit of a mass and no vascularity. And so you may well want to treat this patient conservatively. Retained products and endometritis. You have to do an endovaginal exam in order to assess uterine tenderness, and you have to ask the patient, does this hurt? So here's a patient 2 weeks postpartum. She has pain and bleeding. So here on ultrasound, you can see the echogenic mass. You can see all kinds of increased vascularity. And she has a tender uterus. She has little bits of air in the endometrial canal that you may or may not see. But the uterus was tender. So she has retained placenta, retained products, and she has endometritis. And here, and then following a DNC, she had a DNC, and following a DNC, she had that mass removed with only a small amount of fluid in the endometrial canal. Endometritis with retained products or without retained products. 4 days post-therapeutic abortion, fever and increased white count. Obviously, if patients have all of the clinical signs of infection, maybe they're passing some foul-smelling fluid, they have a fever, they have increased white count, there's no question that they have an infection somewhere. And if they've had a recent instrumentation in the uterus, that's the area that you're going to look at. And she has retained products, and she has a tender uterus. Here you can see tender. She has a tender uterus, so she has retained products as well as endometritis. A 20-year-old who had a therapeutic abortion 5 weeks ago. She's bleeding despite antibiotics. Some physicians, if a woman comes in following a therapeutic abortion and has very minimal symptoms, but has some uterine tenderness, and you can see the uterus was tender on ultrasound, they may just give them antibiotics in the office and not, in fact, do an ultrasound examination. So here they did the ultrasound. Is there any abnormality? Well, there may be a small area of increased tissue with some increased vascularity. This could be a small area of retained products, but a tender uterus. So she had a DNC to remove this area of retained products, and she had antibiotics to cover the infection. Endometritis only may appear with spotting or bleeding weeks after delivery. The scan is often done to rule out retained products. They may have minimal discharge or minimal fever. Ultrasound findings may be normal. There may be some endometrial fluid, maybe some air occasionally, and uterine tenderness on endovaginal examination. And obviously, the treatment for endometritis only is antibiotics and not a DNC. Here's a patient who had a therapeutic abortion at 16 weeks. 5 weeks later, she's got some bleeding, fever, foul-smelling discharge, no history of pelvic inflammatory disease. The uterus looks fine. No retained products, but the uterus was tender to palpation. She has endometritis, and she would be treated with antibiotics only. A patient 3 weeks postpartum, recurrent fever, pain, manual removal of the placenta. That's a key. Someone put their hand in there in order to treat the patient at the time for a placenta that was overly adherent, so they may well introduce infection into the uterus. She has some free fluid in the endometrial canal, echogenic areas consistent with air, so she had, and a tender uterus, so she had retained products. Here's a patient 5 days after a cesarean section, has fever, so obviously there's some infection somewhere. This is a view of the lower uterine segment. Here we're looking at the cesarean section scar, but it actually has a hematoma within it. It has a mass, and it has areas of increased echogenicity consistent with air. So she has an infected cesarean section hematoma. Another patient, and this is a real dilemma. This is a patient who has, she had a therapeutic abortion, and now she comes back with some bleeding. You see areas of significant increased vascularity with high velocity flow. And the question is this just simply retained products? So high velocity vascularity, retained products, is very common. Remember, there are AV fistulas within this adherent placental tissue, so they're common in retained products. You can successfully treat it with the DNC and seldom have excess blood loss. But when you're looking at the myometrium, one of the things that you should look at, not always there, but one of the things you should look at is, are there any large myometrial holes that may have high or even low velocity flow? A large AV fistula, and this is different than retained products because there's a tremendous amount of flow, has usually large holes in the myometrium, large vessels, and excess bleeding. And in fact, one of the concerns is that they can exsanguinate. So, causes of bleeding. AV fistula or malformation, remember, it can still be retained products. Gestational trophoblastic disease, what is the difference? With an AV fistula, people will bleed like stink. You're gushing blood. The beta may well be negative. High velocity flow, large holes in the myometrium, and treatment. You may have to do compression with an intrauterine catheter. You may want to embolize, or you then may want to wait, and some of these people may actually require hysterectomy. With gestational trophoblastic disease or a mole, you have moderate bleeding. The beta-HCG is going to be positive. The vascularity that you see has low velocity rather than high velocity. You may actually have large holes in the myometrium and a mass of vessels, but you're going to treat it mostly with methotrexate. You may also require a DNC. So here you have a patient bleeding 6 weeks after a therapeutic abortion. Question was there retained products? Here you can see a mass of tissue. In this particular patient, an article had recently come out about AV fistulas, and so we were keen on looking at the vascularity. And you can see these corkscrew vessels, high velocity flow. We were concerned that this patient actually may have an AV fistula, not just retained products. So we talked the radiologists into doing an angiogram, and they saw areas of rapid filling of venous flow as well as arterial flow. And they said, yes, there are some there is some AV fistulas there. The seasoned angiographer said, no, she's a young girl, I'm not going to do any embolization. I'd have to embolize too much, and I don't want to affect her potential fertility. So he did nothing. I wondered what became of that woman, and 6 months later I called her back for a repeat ultrasound. I said, whatever happened after you had the angiography? She said, well, nobody treated me, the bleeding stopped, and 6 months later, obviously, she had nothing serious, and now she's pregnant again. So it's clear that what the seasoned angiographer did is just give this woman a tincture of time, watch her treated conservatively, and not do any angiography was the right treatment. So now you look at a patient who has huge volume and extent of flow, 26 years old, has had numerous pregnancies, and now you see a uterus that has these big holes in it. It looks abnormal. These big myometrial holes and some fluid in the endometrial canal. Whatever this is, this can't be normal. So this we were really quite concerned about. We brought her, we turned on the color, and here she has flow, extensive flow throughout this myometrium. This is definitely abnormal. And she did have increased flow. So the flow was not that high, but it was definitely abnormal for sure. So now what are we going to do? Here in power Doppler, again, shows the massive amount of flow in the uterus. So she needs an angiogram, and they did an angiogram on her. And you can see that as soon as they put contrast into the left uterine artery, she's almost immediately getting huge amount of venous flow. So she's got a large AV fistula in that uterus, and that's what's causing all of the ultrasound findings. They also had increased flow in the ovarian artery as well. So what they then did was, here you can see the right ovarian artery. That also has significant increased flow. So this patient needs surgery. Post angiography, they embolize the uterine and right ovarian arteries in order to control the flow prior to surgery. And here you can see some of the coils that were put in. They then took her to surgery. So here you can see the uterus and the right ovary, the enlarged right ovary. Here you can see the uterus and the left ovary and the large right ovary, normal left ovary and enlarged right ovary. They removed the uterus uneventfully, and the uterus looks not too bad. When you open it up, you can see these large vessels that obviously, because the pressure from the arterial system has been removed, the vessels are much less dramatic. But this patient had AV fistulas that could have been disastrous for her. Another patient, she delivered at 21 weeks, manual removal of the placenta, and she has, again, tremendous area of increased vascularity and sort of small holes in the myometrium. Is this an AV fistula? Is this something that we have to be really concerned about? She had tremendous amount of vascularity seen associated with this, with these holes and with the mass in the endometrial canal. So she had large vessels, increased velocity. What are you going to do? Does she also need a hysterectomy? She's only 22 years old, and she's just delivered a baby. Well, the patient went to the ward after ultrasound. She had uncontrollable bleeding, so So now you're wondering about AV fistula. The interventional radiologist would not embolize, and so the obstetrician put in an intrauterine balloon, really just a Foley catheter. The balloon stopped the bleeding, compression. It stopped the bleeding, and 24 hours later it was removed. She had no bleeding, and she was sent home. 2 weeks after what looked like a disastrous situation, the uterus looks normal. So they had compressed and stopped the massive amount of flow in this woman, and so just with conservative management and balloon compression, she actually retained her uterus and everything was fine. So AV fistulas versus retained products. Don't overcall AV fistulas because the results can be disastrous. AV fistulas should have large myometrial holes, but not always. And there's a large overlap between AV fistulas and retained products of conception. Here is a patient 5 weeks postpartum, had heavy bleeding and clots. Again, is this retained product or AV fistula? She decided just simply to leave home, to leave the hospital. She did have some increased vascularity, but we're seeing a lot of things that it's not absolutely always clear. She had an area of increased vascularity, she left, and she came back fine. So was this retained product, or was this just simply, could this have been an AV fistula? Now here's an area that's much more concerned. Enlarged uterus, thickened myometrium, a bunch of holes in a woman who has a high beta HCG. High beta HCG. So now we're not thinking of retained products, but what we should be thinking of, hydatidiform mole. And here, when you look at the vascularity, it's low vascularity. So high beta HCG, low vascularity, we're thinking now hydatidiform mole, and that's in fact what it was. You look at this and it looks, well, there's a mass and increased vascularity in a woman who had a therapeutic abortion 6 weeks ago, has been bleeding for 6 weeks, has a positive beta. I might just simply have called this retained products had it not been for the positive beta. But remember, the beta can continue to be positive after delivery and gradually dropping. Hers was not dropping. The mass, the low velocity flow, she actually also had an invasive mole. It looks different than the previous case. So again, there's a wide variety of these. Trophoblastic invasion of the myometrium. What's the significance? May need surgery, but can resolve spontaneously. A woman with bleeding 6 weeks post spontaneous vaginal delivery, manual removal of the placenta. You look and you see a big mass there. You have to look closely because the mass seems to extend into the myometrium. And when you look closely, there it is going almost to the serosal surface. So the question is this retained products? But more importantly, is there an area of placenta increta? When you look back at the 7-week scan, you can see that the placenta was extending right into the myometrium. She has an area of placenta increta. She had had enough pregnancies. They were quite concerned about her, and they decided to do a hysterectomy. Here's the unbisected uterus, and here you can see the bisected uterus with that trophoblast extending right out to the serosal surface. So this was a mass of invasive trophoblastic tissue. Obviously, a hysterectomy was the correct case, was the correct treatment in this case. Another patient, early pregnancy failure, 29 weeks, untreated, myometrial invasion. So here we look at this case and we see the non-gravid uterus. Here then she gets pregnant. It looks not too bad. You can see the gestational sac. She's had some bleeding at 8 weeks. She doesn't want a D&C, so we're managing it expectantly. Normal placental implantation site anteriorly. We keep following her now a week later, and she has a prominent vessel extending right into the myometrium, and you can see it on 3D. Prominent vascularity in the anterior myometrium. So what is this? Is this retained products? And she has, again, high velocity flow. And is there anything we need to do about it? Well, if you look again at the 2D, you can see this heterogeneous trophoblast extending into the myometrium. Does this patient need a hysterectomy? This was 1 week apart. She has persistent trophoblast with increased vascularity, but she's clinically well. So what to do next? Do you monitor her beta? We should monitor her beta. Do you do a D&C? Or do you give methotrexate? Well, they decided to give methotrexate, and a week later, everything is cleared up. So sometimes, and here it looks quite normal, so sometimes just simply watching, we're seeing a lot of things that we weren't seeing before because of the improved equipment, but do you always have to treat the things that you're seeing? Patient who has 10 weeks, early pregnancy failure, an empty gestational sac, and you look at the endometrial canal, and extending into the myometrium is an area of increased echogenicity. It looks like myometrial invasion. There's some increased vascularity in that region. What should you do? Is this molar invasion? Is this trophoblastic invasion? There was some high velocity flow. She's only spotting, so what do you do? Well, this patient, they just simply, again, they treated conservatively, and she resolved. At 16 weeks pregnant, this woman has had bleeding for 2 months and finally just came to see a doctor. She has these big holes in the endometrium or myometrium, very, very confusing, and has some high velocity flow. We brought her back a day later because or 2 days later, I wasn't exactly sure what was going on. Sorry, 3 days later. And she had passed whatever it was. And I said, well, it must have been a mole. Did you pass a bunch of grapes? She said, no. She said, I passed a collapsed fetus. So this whole area that is quite distorted, maybe that was the head and the body, I don't know, but this was actually a collapsed fetus. Finally, here you have a patient, again, a similar situation. She had some interventional procedure. Now she's got this big mass in the endometrial canal, but it's avascular. Remember, an avascular mass can simply be a hematoma. She was pregnant earlier. She had a small embryo. She had a therapeutic abortion, and now she has a hematometra. No mass, and in fact, depending on her clinical situation, you may do a D&C. Another patient with a clot, avascular clot in the endometrial canal, mixed echogenicity, hematometra, or a blood clot, rather than retained products. And the only way you're going to know is by looking at vascularity. So late postpartum bleeding, first of all, it requires a good history. Is this continuous versus stop and start bleeding? Is the uterus tender? The only way you're going to know about uterine tenderness is talk to the patient. When you're scanning with an endovaginal probe, when you're touching the uterus, you've got to ask the question, does that hurt? Is the uterus tender? Endovaginal ultrasound is absolutely critical, and remember, use color and use spectral. So examine the uterus, push on it, ask if it's tender, use color always to see if there's increased vascularity, and use spectral to see whether or not this is high velocity flow. Thank you very much. I hope that this talk has been useful for you.
Hello, my name is Dr. Leslie Scout, and I'm Chief of Ultrasound at Yale New Haven Hospital and Professor of Diagnostic Radiology at Yale University School of Medicine. And I'm here today to talk to you about ultrasound evaluation of ovarian torsion, as well as some of the common clinical mimics of ovarian torsion. Today we are going to be talking about the sonographic evaluation of ovarian torsion. And the objectives of this lecture are to describe the clinical presentation of ovarian torsion, to discuss the most common grayscale ultrasound appearances of ovarian torsion, and to describe the role of Doppler ultrasound in the evaluation of patients presenting with clinically suspected ovarian torsion. In addition, at the end of the presentation, I am going to describe the ultrasound findings of common gynecologic clinical mimics of ovarian torsion, in particular hemorrhagic and ruptured ovarian cysts, as well as pelvic inflammatory disease. Ovarian torsion accounts for only approximately 3% of all gynecologic emergencies. It can involve the ovary alone, or the fallopian tube alone, or most commonly involves both. And if it is not surgically relieved, ovarian torsion will ultimately result in ovarian necrosis. Patients are therefore go to surgery when the diagnosis is made, and if the ovary is necrotic, oophorectomy is performed. If clinically, when they're in the operating room, they determine that the ovary is likely to be viable, they can attempt to do detorsion as well as cystectomy if there is an underlying mass present. Unfortunately, however, the ovarian salvage rate is low because it is extremely hard to predict as you're looking at the ovary whether or not it is going to be viable if a detorsion procedure is performed. Patients with ovarian torsion are typically women of reproductive age who present with acute onset of severe pelvic pain, which is more common actually on the right. Patients tend to be afebrile and they have a normal white blood cell count, although occasionally one can see mild leukocytosis. And when patients present with this classical presentation, workup proceeds with immediate Doppler ultrasound evaluation and the diagnosis is quickly made. However, there are very common atypical presentations which you should be aware of. And first of all, although ovarian torsion most commonly occurs in women of reproductive age, it can actually occur in postmenopausal women and children as well as neonates. And in children, ovarian torsion often presents as an abdominal or pelvic mass rather than acute onset of pelvic pain. In addition, another common atypical presentation is that the pain, rather than being sudden, severe, and acute, may actually be relatively mild or intermittent. And in some series, in fact, this intermittent or mild presentation of very minimal pelvic pain has been reported in as many as 50% of cases. And in these patients, these symptoms may mimic GI, renal, or other GYN pathology. And because of this clinical overlap, often a CT scan is the first imaging modality that is obtained rather than an ultrasound. What are the risk factors for ovarian torsion? Well, the most common risk factor is the presence of an ipsilateral adnexal mass. About 20% of cases occur in women who are pregnant, particularly women who have ovarian hyperstimulation syndrome. Pelvic surgery can predispose to torsion, particularly in patients who've undergone tubal ligation. In addition, in children, occasionally lax supporting ovarian ligaments are believed to be the predisposing factor that can result in ovarian torsion. As I mentioned, it is an underlying ovarian mass that is the most common risk factor, and it's estimated that patients have such a mass in about 50 to 80% of all cases. The most common is a dermoid cyst or cystic teratoma of the ovary, but of all adnexal masses, it is the paratubal cyst itself which is most prone to torsion, although a paratubal cyst is is less common than dermoids in the general population. Simple cysts and hemorrhagic cysts can also predispose to torsion, and very, very rarely ovarian cancer can predispose to torsion. Any mass, though, once it causes the adnexa to be greater than 5 centimeters in dimension, predisposes the ovary to torsion. Interestingly, though, this is not true in children, presumably because their pelvis is small, and if a mass is very large, greater than 5 centimeters, it is more likely fixed in place and therefore less likely to rotate along its pedicle. And similarly, in adults, ovarian masses that are extremely large, greater than 12 or 15 centimeters in diameter, again, are less likely to torse because they are fixed within the pelvis and unable to rotate. In terms of children who have normal ovaries and end up with ovarian torsion, this is believed to be due to some type of laxity in the pelvis, either lax supporting ligaments, sometimes due to redundant mesosalpinx, sometimes possibly tubal spasm, and in addition, ovarian torsion in children has been described when there is abrupt change in intra-abdominal pressure because of coughing, vomiting, and sometimes even strenuous exercise. Well, if a patient is suspected of ovarian torsion, Doppler ultrasound should be the first imaging modality that is performed. And it is the grayscale features on ultrasound examination that really are the most important for making this diagnosis. That being said, the appearance of ovarian torsion on grayscale imaging is still quite variable and likely depends on the time since torsion occurred as well as the degree of torsion. The findings that you want to look for, though, on grayscale imaging are first and foremost the presence of an enlarged ovary. As yet, I have never seen an ovary that is normal in size which has undergone torsion, and maybe someday I will, but so far every case of ovarian torsion I've seen, the ovary has been enlarged. The central ovarian stroma tends to be very heterogeneous, with hypoechoic areas due to edema and echogenic areas due to hemorrhagic infarction. And this infiltration of the central stroma tends to displace the follicles in the ovary peripherally, and so one sees a characteristic pattern of peripheral location of small follicular cysts. However, if torsion has been present for a relatively long time, the ovary can be quite amorphous in appearance. Another thing you can look for is an atypical midline position of the ovary. Always check to see if there is an underlying ovarian or adnexal mass. As I mentioned, you will see this in up to 50 to 80% of all cases. If a cyst is present, look for asymmetric thickening of the cyst wall. And also be very careful to try and identify the tube, which is usually between the ovary and the uterus, because often you can see the tube or the pedicle is dilated or edematous, and if you look at it in cross-section, you can see a target sign that looks like a archery target. In addition, it is very common to see a small amount of adjacent free fluid. When the ovary undergoes torsion, the initial thing that happens as the pedicle twists is that the lymphatics are obstructed, and during this early time, blood flow may be normal, but lymphatic obstruction actually is what causes the ovary initially to enlarge and to become edematous. As the obstruction persists, one sees decreased flow through the pedicle. Then one will see reversed diastolic flow. This is followed by decreasing or absence of venous flow, and only after the pedicle has been torqued for a fairly substantial period of time will you see complete absence of arterial flow. So given this progression of pathologic findings over time, it is not surprising that the Doppler characteristics or Doppler findings of ovarian torsion are quite variable. And again, this is mostly due to differences or variability in the length of time from torsion to imaging and also to the degree of torsion. But in addition, there are two arteries that supply blood flow to the ovary, one from the uterus as well as one from the aorta or iliac vessels. And since one of these can torus and not the other, this can sometimes preserve flow to the ovary. Another thing that can affect the Doppler findings is that ovarian torsion in women is very frequently intermittent. And so you can be seeing the torsion during a time of detorsion when blood flow has been restored to the ovary. So what then, though, are the diagnostic ultrasound findings of ovarian torsion? Well, certainly if there is complete absence of arterial flow, this is consistent with the diagnosis of torsion. And another thing that you can look for is the Doppler equivalent of the target sign in the twisted pedicle, which has been termed the whirlpool sign, and I will show you some cases of this in a few minutes. But it is very important to recognize that while those two features, absence of arterial flow and the presence of the color Doppler whirlpool sign, are diagnostic of ovarian torsion, a normal Doppler ultrasound examination does not exclude this diagnosis. As I said, you can have, if you consider absence of arterial flow as being the most important diagnostic criteria for ovarian torsion, you will have a considerable number of false negative exams because flow may be present early on, but you can also have false positive exams, and this can be due to sampling error, the fact that you may not see flow in a normal ovary, particularly in a postmenopausal woman or in a woman where the ovary is deep within the pelvis, and also if through inexperience your machine settings are faulty or not very sensitive. Well, let's go through some examples of ovarian torsion that point out these findings that I've just described. Well, as I said, the sine qua non of ovarian torsion on grayscale imaging is the presence of an enlarged ovary. And so here you see an example of an ovary which is quite enlarged, almost 6 centimeters in diameter. You can see that the central stroma is heterogeneous with hypoechoic areas representing edema and more echogenic areas representing hemorrhagic infarction. You see the peripheral displacement of small follicles, some adjacent free fluid, as well as a simple cyst and a hemorrhagic cyst, which are underlying masses, possibly the lead points causing this ovarian torsion. Here is another example. You see a very, very enlarged ovary. Sometimes there are very few number of peripherally displaced cysts, this very amorphous heterogeneous central stroma, and a very large simple cyst, which was the lead point for this torsion. Here is another example where you can see an abnormal position of the ovary. Notice that it is on the transabdominal image, it is midline in the pelvis, anterior to the uterus here. Note the intrauterine device, which is abnormal in location and within the cervix rather than in the fundus where it belongs. Note again the lead point, this large simple cyst with some reverberation artifact anteriorly. And when you do the endovaginal exam, you can see that the right and left ovary are adjacent to each other. You can see marked asymmetry in the size with the ovary that has undergone torsion quite a bit larger than the normal ovary. Here again the lead point, this central amorphous heterogeneous stroma with peripheral displacement of small follicles. And another example, again, an enlarged ovary over 6 centimeters in diameter, peripheral displacement of follicles, adjacent free fluid, and in this particular case you can see a hemorrhagic cyst, which was the lead point for the ovarian torsion. As I said, it's really critical to try and identify the pedicle, and usually you can find the pedicle between the ovary and the uterus, and if it is torused, it will become extremely edematous, as you can see in this case, nicely outlined by some adjacent free fluid. And if you look carefully in cross-section, it has a bullseye or target appearance, just like an archery target, with alternating rings of decreased echogenicity and more echogenic circular structures. And this has been termed the target sign, and again often seen between the torsed ovary and the uterus. Here is the adjacent normal ovary. Here is the very large torsed ovary and the target sign. If you see a cyst and the patient is presenting with acute pain, look at the wall of the cyst, and if you see asymmetric thickening, again, consider the diagnosis of ovarian torsion. And those are the grayscale features which, in my personal experience, you tend to see in the vast majority of patients with ovarian torsion. Well, how about the Doppler examination? Well, let me show you some classic examples in which Doppler is very helpful, and the sine qua non again is complete absence of arterial and venous flow. So here you have a classic appearance on grayscale of a torsed ovary, enlarged, peripheral displacement of follicles, adjacent free fluid, heterogeneous stroma, and with color Doppler, no evidence of blood flow. Remember that your spectral Doppler is, of course, more sensitive to blood flow than color Doppler, as is power Doppler. So use both of those modalities to look for flow. And again, they confirm that there's absolutely no evidence of flow within this ovary. And this, again, confirms the diagnosis of ovarian torsion. But I caution you, when the ovary is this classic in appearance for ovarian torsion, I don't really care what the Doppler findings show, because the grayscale findings are enough to make the diagnosis. Here's another example, though, where the Doppler confirmed the grayscale finding. Again, classic appearance of ovarian torsion on grayscale, but on color and spectral Doppler, no evidence of blood flow, just a little bit of noise within the ovarian parenchyma. This is a child who presented with a palpable palpable abdominal mass. You can see the bladder here and the uterus and this extremely large mass with no evidence of blood flow on Doppler examination. And they were concerned about ovarian torsion because they figured any kind of malignancy that was this large would be likely to have flow. And so because they considered the diagnosis of torsion, they did a very interesting thing. They changed transducers and used a high-resolution linear array transducer. They understood that they would not be able to see the entire mass, but they could see to better advantage the more superficial anterior portion, and note that they can, again, with this high-resolution technique, see the peripherally displaced tiny follicles, and this helped confirm their diagnosis that this mass indeed represented ovarian torsion rather than some kind of malignancy. This is the same case that I showed you earlier, where you could see that target sign on the grayscale imaging, and if you put color flow on that area, you'll see the vessels swirling around, and this has been described the whirlpool sign. And if you see this finding, this is a very specific finding for ovarian torsion, but unfortunately it is a very uncommon thing to see. And I've only seen it once or twice in my practice, which is why I've gone to the literature to show you some other examples. And here is from the paper that initially reported this from India, where you can see the target sign, the hypoechoic echogenic alternating rims on the grayscale, and the swirling vessels on the color Doppler, indicative of both the target and the whirlpool sign. And this is a third example lent to me by a colleague from Johns Hopkins University, again on grayscale, classic appearance of an enlarged torsed ovary, the target sign on the grayscale, and the swirling vessels creating the whirlpool sign on the color Doppler image. But as I mentioned, the Doppler findings can be somewhat variable, again, mostly due to the fact that torsion can be intermittent and variability in the length of time and degree of torsion from onset until imaging with ultrasound. And so here's an example of a patient who's got the classic grayscale features of ovarian torsion. This simple cyst is the lead point. Note the peripherally displaced follicles. But when we put colored and pulse Doppler on, notice that there is some arterial flow, though it is abnormal, as there is a high resistance waveform pattern with absence of diastolic flow. And again, although there is blood flow, it is abnormal, but it is the grayscale findings alone that cause you to make with confidence the diagnosis of ovarian torsion. If you have a question about it, you can consider doing an MRI, as was done in this case. This was early in our experience, and you can see again the ovary is enlarged, the follicles are displaced peripherally. Here is the simple cyst as a lead point, and notice this high signal intensity central ovarian stroma consistent with edema. Again, all the findings that you see on the ultrasound, you see on the MR. Here is another example of a patient who presented with intermittent pelvic pain. Note this left ovary is huge, 8 centimeters in diameter. Again, the classic findings of ovarian torsion. But when we look with color and spectral Doppler, there is both arterial as well as venous flow. However, I want to caution you that the presence of this blood flow should not make you, should not dissuade you from considering the diagnosis of ovarian torsion. All this may mean is that the ovary is in fact viable. So again, when the grayscale findings are classic in appearance, I really don't care what the Doppler looks like. I'm going to make the diagnosis whether I see blood flow or not. And this is the case I showed you at the outset. Again, the classic grayscale findings of ovarian torsion. But on the Doppler exam on color, there's arterial and venous flow confirmed on the spectral examination. Again, this should not dissuade you from making the diagnosis. In fact, this patient should go to the operating room quickly because there is a good chance that the ovary will be viable when they detorse it and therefore will be salvageable. Another example demonstrating blood flow, arterial and venous, in a patient with the classic grayscale features of ovarian torsion. Well, what are some of the pitfalls in the diagnosis of ovarian torsion? Well, it can be difficult when you have a cyst that's possibly hemorrhagic or ruptured to determine if the pain is due to symptoms from the cyst itself or due to torsion, since you know that these cysts also can predispose to ovarian torsion. So this is an example, again, early in our experience, where a patient came into the emergency room with acute onset of pain. This ultrasound was done, a cyst was seen, some adjacent free fluid, arterial and venous flow was identified, and because blood flow was seen, they thought that they should exclude the diagnosis of ovarian torsion, and they thought that the pain was likely to due to leakage from the cyst. But notice that if you look carefully at the rest of the normal ovary, you don't see any normal ovarian architecture. There's some tiny peripherally displaced cysts. There's a very heterogeneous central ovarian stroma. So unfortunately in this case, there are the classic grayscale features of ovarian torsion, but the inexperienced resident was dissuaded from making this diagnosis because of the presence of blood flow. This patient came back to the emergency room 3 days later. Notice that now the ovary is even larger, that cyst is smaller. There is much more echogenic heterogeneity within that ovarian stroma consistent with hemorrhagic infarction. And unfortunately, when they went to the operating room at this time, the ovary was infarcted and this woman did lose her ovary. So again, don't let the presence of blood flow dissuade you from making the diagnosis if the grayscale features are classic. This is a patient who had ovarian hyperstimulation syndrome and had just become pregnant. And notice that her right ovary and her left ovary are extremely large. There are numerous cysts throughout both ovaries, consistent with the diagnosis ovarian hyperstimulation syndrome. And when we did the Doppler, you can see that there was arterial flow to both ovaries. However, on this particular patient, the left ovary was much more tender than the right, even though it looked very similar, and it was tender on examination, so that when the probe was on the left side of the pelvis, the patient was much more uncomfortable than the right. So because of these changes in physical examination and because we know of the risk of ovarian torsion in women with hyperstimulation syndrome, this patient did go to the operating room, and indeed the left ovary had been torsed and they were able to salvage it. The only clue, perhaps retrospectively, on evaluating or analyzing the Doppler waveform spectrum is that there's a little less diastolic flow on the left than on the right, possibly indicating increased peripheral vascular resistance due to swelling from the ovarian torsion. Another pitfall in the ultrasound of diagnosis of ovarian torsion is the patient who has chronic torsion. And when the ovary has been infarcted for a while, it becomes extremely amorphous, and sometimes all you see is just a big sac of blood. Notice the low-level echoes within the cystic mass in the left adnexa, or in this case where you see again a big cystic mass just with some clot within it. And so it can have a very, very variable appearance when the torsion has been long-standing. It is most common that either the ovary itself or the ovary and the tube torse, but occasionally, particularly in children, it is possible to torse just the fallopian tube, and this can be very, very difficult to make this diagnosis. But here's a patient who presented with acute pain. The ovary looked normal, and you have no trouble making the diagnosis of hydrosalpinx on the right adnexa. But notice that the hydrosalpinx forms sort of a beak point here, just as if you were to take a balloon and twist it, making a balloon animal at a children's birthday party. This beak sign is not a typical feature of a dilated fallopian tube, which tends to be more dilated actually at the fimbriated end rather than narrowed and pointed as you see here. And so when you see the beak sign in a patient who presents with acute pain, consider the diagnosis of torsion that is isolated to the fallopian tube. And here is another example of a patient showing that beak sign in whom just the fallopian tube alone had undergone torsion and the ovary was normal. As I mentioned, it is a dermoid cyst that is the most common lead point in a patient with ovarian torsion, and it can be very difficult to make the diagnosis of a torse dermoid, particularly when it is large. You may not see any of the classic ultrasound features of ovarian torsion because you don't see the normal ovary, so you can't recognize those changes in the ovarian stroma or the displacement of the peripheral follicles. So in my recommendation in terms of dealing with this clinical situation, if you see a patient with a large dermoid, you can't see the ovary to assess the parenchyma, and if that dermoid hurts, you have to assume that it is either torsed or it is leaking. In either case, it is a surgical situation, and you should advise the clinicians that you can't exclude torsion or rupture of the dermoid. You can try using color, but it doesn't really help because often you don't see any blood flow in a dermoid cyst. And as I mentioned, even if you do see blood flow, this does not exclude the diagnosis. So in general, if the dermoid is symptomatic and large and you can't see the ovary, you have to be concerned about the possibility of torsion. Well, what about the patient in whom you have some clinical suspicion and you have some suspicion on the ultrasound findings, but they're not totally classic, they're somewhat equivocal? This is the time when I think MR is very helpful as a problem solver. So this is a patient who had very, very mild pain, had been intermittent over several months. When we did the endovaginal exam, we can see that there is some asymmetry in the size of the ovaries. The right ovary was just over 5 centimeters, the left 3.5. The right ovary therefore clearly bigger. Again, some peripheral displacement of follicles, but you can see that on the normal left ovary as well, and the central stroma a little bit more prominent. This patient did have arterial flow and venous flow, which I haven't shown you, but there was asymmetry in the size of the ovaries, but because it wasn't that dramatic and the patient's symptoms weren't that dramatic, we weren't really sure if this was torsion or not, and in this case we ended up recommending that they do an MR. And MR is very useful as a problem solver. That being said, it actually shows you very similar things to what I've described on the ultrasound examination. The ovary that is torsed on MR is going to be enlarged. It's going to be abnormal in location. Note this midline position. There is going to be a high signal intensity central stroma due to edema, and you will see peripheral displacement of follicles. One thing that you can do with MR that you can't do with ultrasound easily in the United States, since intravenous ultrasound contrast is not yet FDA approved, is you can give intravenous contrast, and with intravenous contrast you'll see that there is lack of contrast enhancement, and sometimes that can help you identify also the thickened fallopian tube, which in this case was a little bit hard to differentiate from the ovary until we gave the contrast. Here is another example. This is a pediatric patient in which the ultrasound wasn't diagnostic and they didn't have a good explanation for the patient's pain. And on the MR, you can see the findings of ovarian torsion. Here is the hemorrhagic cyst and a serous cyst, either one of which could have been the lead point. You can see increased signal consistent with edema in the residual ovarian parenchyma, peripheral displacement of little follicles, and you see this round swirling mass between the ovary and the uterus representing the twisted, thickened pedicle. And following contrast enhancement, no enhancement in the ovary and just a little bit of enhancement in that pedicle in this patient with ovarian torsion. I want to spend just a few minutes talking about the appearance of ovarian torsion on CT scan, even though this is an ultrasound lecture. And the reason for that is that in these patients with atypical presentation who present with mild or intermittent symptoms that mimic GI or renal or even other gynecologic pathology, sometimes a CT scan may be the first imaging test that's obtained, and so it's important that one be able to recognize the appearance of ovarian torsion on CT. And just like on MR, the appearances of ovarian torsion on CT mimic exactly what I've described on ultrasound. So you see an enlarged midline ovary, peripheral cyst, and a thickened adjacent pedicle, as well as a heterogeneous central ovarian stroma, sometimes increased in attenuation due to hematoma, areas of decreased attenuation due to edema. Another example lent to me by Dr. Lefthoff, now at the University of Pennsylvania, where you can see again these peripheral follicles, this thickened adjacent fallopian tube, and stranding in the pelvic fat, which is a nonspecific finding on CT of inflammation or infection. Another example from Dr. Lefthoff showing the lead point, this simple cyst here with a star, the underlying mass, as well as this thickened fallopian tube between the ovary and the uterine cornua. And on CT, just like with MR, you can give intravenous contrast. Notice there is no enhancement of this torsed and infarcted ovary. Notice, just like on ultrasound, you can see some adjacent free fluid, sometimes of high attenuation, indicating pelvic hematoma. Well, those are is a brief summary of the ultrasound, CT, and MR appearances of ovarian torsion. But as you evaluate these symptomatic patients, it's also important to differentiate ovarian torsion from other common causes of acute pelvic pain in the woman of reproductive age. And the three things that I want to talk about at the end of this lecture are hemorrhagic cysts, ruptured ovarian cysts, as well as pelvic inflammatory disease. And if you take women of reproductive age, all women who come to the emergency room or who present with acute pelvic pain, actually hemorrhagic cysts are the most common cause of acute pelvic pain in these women. And so it's very important to recognize the ultrasound findings to make this diagnosis with confidence. Patients with hemorrhagic cysts, these hemorrhagic cysts may have a variable pattern of internal echogenicity, but one of the key features is this pattern will change and evolve over time. These are cysts, so the wall should be thin and regular, although it may be vascular. Because they are cysts, they will demonstrate increased through transmission, and no matter what the pattern of internal echogenicity, there should be no evidence of internal vascularity. When a patient presents to the emergency room acutely within the first several hours of hemorrhage into an ovarian cyst, the typical pattern that you see is, as I've presented here, one of diffuse, homogeneous, low-level echoes. So here is a cyst, thin wall, some increased through transmission, and diffuse low-level echoes in a homogeneous pattern throughout the hemorrhagic cyst. As time moves on, what happens is that the red blood cells lyse and they release their contents into the cystic fluid, and fibrin strands form. And these can form a lace-like or spider web, sometimes people call it as a fishnet pattern of internal echoes and septations. And they can be sort of minimal, as you see on the example on your left, or they can be more echogenic and more confluent, as on the example on your right. And over time, they tend to coalesce to form the clot, so they tend to point towards a particular focus, often associated with the wall, because the clot is often adherent to the wall. And the next thing that happens is that these septations, as I said, evolve into acute clot, and this clot acutely tends to be echogenic, Most often it's adherent to the wall. It can be kind of polypoid in configuration as you see here, but sometimes that echogenic clot can actually be suspended within the cyst, and this really does look like a spider web with maybe some kind of a fly or bug caught in the fibrin strands within this hemorrhagic cyst. Over time, that clot is going to change, and the fluid within it is going to be absorbed, and it's going to become retractile. And this can be diagnosed on ultrasound by the identification of the sharp or concave margins, and this is very typical for retractile clot and is very uncommon to see with any kind of soft tissue mass. Here are two other examples showing these concaved, scalloped margins, very straight margins. This would be very atypical for any kind of soft tissue component or neoplasm, and here again a very, very straight margin. Very unlikely that any neoplasm would have that kind of a configuration. Well, what do you do though if you see a patient who's got a little echogenic focus within a cyst in the ovary, and you have to differentiate between clot and a mural nodule? Because if you see a mural nodule or a soft tissue component, you of course are going to be concerned that there's an underlying cystic epithelial neoplasm. Well, one of the first things you can do actually is to roll the patient, and if that clot moves or layers just like sludge within the gallbladder, and here you can see a very flat interface between that hemorrhage and the rest of the fluid within the cyst, you know this is not going to be a mural nodule and this is just going to be hemorrhage. And the other thing, of course, that you're going to do is to check your vascularity with your color, power, as well as spectral Doppler. And if you see any blood flow, you have an answer. You know this has to be a neoplasm or some sort of a tumor nodule. If you don't see blood flow, it's most likely to be clot, but you need to remember that sometimes when mural nodules from tumors are small, they may have so little blood flow that it's below the resolution of your ultrasound machine. And so for that reason, we tend to get follow-up, because again, clot or internal echoes, no matter the appearance, should have no evidence of vascularity. But because you can't necessarily differentiate a small tumor nodule from clot if you don't see blood flow, we do recommend getting follow-up. And the typical time frame that we get this follow-up is within about 6 weeks. And again, this is very important, particularly if the clinical presentation is somewhat atypical. In other words, the patient didn't have pain and you see a hemorrhagic cyst but there are no symptoms, or if it doesn't really look typical for the clot that I've shown you, you don't see those straight concave margins. In 6 weeks, clot should change in appearance, and if the echogenic focus does not change in 6 weeks or doesn't resolve, or if you see blood flow, in either case you have to consider that there is a tumor nodule there, and it then becomes a surgical lesion. Well, what about rupture of a cyst? This again is a very common cause of pain, and often the pain is not only acute but extremely severe. These patients may have rebound tenderness. If they lose a lot of blood, they may even be hypotensive. Typically, they have a normal white blood cell count and they are afebrile. Well, how do you make the diagnosis of ovarian cyst rupture in ultrasound examination? Well, first of all, it sometimes is a diagnosis of exclusion. In other words, the ultrasound examination is completely normal. Why is that? Well, the cyst rupture, the fluid dissipates within the pelvis and is absorbed, so with the cyst being ruptured, you don't see it anymore, and you don't even see the adjacent fluid. But sometimes the cyst doesn't rupture completely, and it will look crenated with a pointy, abnormal configuration with straight margins. It may contain some internal debris, and you may see some fluid adjacent to the ovary or within the cul-de-sac, sometimes even in Morrison's pouch if there's been a lot of bleeding, and sometimes you can actually see a clot within the fluid. Look carefully for these low-level echoes indicating that this is hemorrhagic fluid. Here is an example of a patient who has a ruptured cyst. You can see the ovary here, and the cyst is a very crenated configuration with angular margins. And note that this ovary is surrounded by a lot of amorphous material, and this is clot that actually seems to almost be engulfing this ovary. When you see this much clot, very important to look in the cul-de-sac Notice that there is a lot of clot in the cul-de-sac posterior to the uterus and in the anterior cul-de-sac anteriorly as well. And when you see this much clot, look throughout the rest of the abdomen and in the upper quadrants in order to quantify the amount of hemoperitoneum. And here in this patient in the pelvis and in the flanks, you can see a huge amount of fluid surrounding these loops of bowel with a lot of low-level echoes within them, indicative that this is hemorrhagic fluid. Here's another example where you can see the ovary surrounded by a huge amount of clot. There's blood flow to the ovary, so you know there's no, so you can identify that this is ovary, but the clot has no blood flow, of course, within it. And in this particular case, you can't see the cyst anymore because it's ruptured. All you see is the hemoperitoneum around it. But again, always look elsewhere in the pelvis. And this patient had a huge clot in the cul-de-sac behind the uterus. Here you can see it on sagittal. A lot of free fluid in the anterior cul-de-sac, and note that there's even fluid in the upper quadrants here surrounding the spleen. And this patient was very unstable and actually ended up getting a CT scan. I'm actually not sure why they didn't just go to the operating room, but the CT scan shows just what we saw in the ultrasound. So fluid around the liver and around the spleen, and a huge amount of fluid within the pelvis, some of it showing high attenuation consistent with active bleeding. And this patient had to go to the operating room because she was unstable just from bleeding from her hemorrhagic cyst. And the last thing I want to mention as a relatively common cause of acute pelvic pain in women of reproductive age is pelvic inflammatory disease. This is an ascending infection. It begins at the cervix, and these bacteria move up through the endometrial cavity, out through the fallopian tube and into the pelvis to surround the ovaries. And currently in the United States, chlamydia is the most common cause of pelvic inflammatory disease. In past years, gonorrhea, of course, was the most typical cause of PID in women in the United States, but this has been supplanted now by chlamydia infection. The clinical presentation of patients with PID can be quite variable, and the symptoms can be very minor or vague, and then can be as extreme as an acute onset of severe pain. Unlike the patients with ovarian torsion or hemorrhagic cysts, these patients tend to be febrile. They have an elevated white blood cell count. They may have a purulent vaginal discharge and will have cervical motion tenderness on exam. Well, in ultrasound, you don't ever see the cervicitis, so this is not a diagnosis you can make with ultrasound, but you can start to see findings once those bacteria extend into the endometrial cavity. And the first thing that you might see is endometritis. So what are the findings of endometritis on ultrasound? Well, the first thing is that the endometrial stripe becomes indistinct and sometimes thickened. So here is a sagittal view of the uterus of a woman with pelvic inflammatory disease. I can see a little bit of fluid within the endometrial canal, but I cannot see the endometrial stripe. I would have no idea how to measure it, and so for me this is a very, very indistinct endometrial stripe. Now, depending upon the organism that has caused the infection, if it's a gas-forming organism, you can actually see echogenic foci within the distended endometrial cavity with shadowing because of the gas. And sometimes you can see fluid and a lot of debris distending the endometrial canal. Endometritis is often associated with marked increase in vascularity, and this will have an abnormal arterial waveform pattern characterized by a lot of diastolic flow, different from the normal high resistance waveform pattern in the normal uterine artery. Now, those bugs continue on their path up through the endometrial canal and out into the fallopian tubes, and so the next thing that develops is salpingitis, or inflammation of the fallopian tubes. And what you see on ultrasound is a very thick, inflamed fallopian tube. It's not normal on most patients to actually even be able to identify the fallopian tube unless there's ascites in the pelvis. So when you see the fallopian tube and it looks thick like this, you have to be concerned about inflammation, and often it will be very vascular if the infection is acute. The fallopian tube will become obstructed, and then it becomes filled with pus and debris, so you can see a lot of fluid in this markedly distended tubular serpiginous fallopian tube. Again, the debris, the low-level echoes representing pus. and also the wall, again, often very vascular if this is acute. Sometimes that pus and debris will layer, as you see in this very distended serpiginous fallopian tube. And it's in patients with chronic PID, sometimes you don't see as much pus in the tube, and so it's important that you know how to identify a fallopian tube and differentiate that from other cystic structures in the adnexa. And three things to think about. One is the waist sign, and this is a little pinching off, if you will, indentation of part of that tube, and that occurs because that fimbriated end is typically more dilated than the rest of the fallopian tube. Another thing that you can look for is the cogwheel sign, and this is the presence of these little nodules, seen often best in cross-section. These are just the thickened mucosal ridges or striations, which are commonly seen in the fallopian tube. But I should caution you that you can see mural nodules like this with malignancy, so this shouldn't be the only sign that you use to make the diagnosis of a hydro or a pyosalpinx. And the last thing that you should look for, which is considered really the most specific thing, again, if you go back to that analogy that I mentioned earlier of the balloon animal, if you think of the fallopian tube as a big long balloon and you fold it on itself, you see these incomplete septation sign, which is just the two walls of part of the tube as it folds on itself. So anytime you see a septation that doesn't extend from one side of a cystic area to the other, think of a fallopian tube that is just folded upon itself. As the pus exits from the fimbriated end of the fallopian tube, it spills into the peritoneal cavity, and it may coat the surface of the uterus, causing this hypoechoic rim around the uterus, and this is what you see in patients who have uterine serositis. And this can form adhesions, and so sometimes you can see that the rectum, or in this case the ovary, is attached to the uterus, and instead of the normal acute angles that you see between the ovary and the uterine fundus, you can see these straight margins due to this hypoechoic pussy substance, again causing adhesions between the serosal surface of the uterus and the ovary. And the last thing that will happen is that all of this infection and inflammation will engulf the ovaries, and the patient will develop tubo-ovarian abscesses. And these are typically complex, multilocular, thick-walled masses containing variable patterns of internal echoes. Again, often bilateral ovaries, often seen together in the cul-de-sac or anterior to the uterus. Another example showing very complex vascular bilateral adnexal masses. Here you can see the distended fallopian tube and these low-level echoes within the cystic components. These masses tend to be tender and tend to demonstrate a lot of increased vascularity, and as I said, tend to be bilateral. And again, it's very important to talk to the patient, and they'll let you know if their mass is painful, and if the mass is painful, again, think strongly of a tubo-ovarian abscess. Now, when you see a complex mass in the pelvis, and it is tender, but you can actually see the ovary separately surrounded by inflammation, this is best termed not a tubo-ovarian abscess, but as best described as a tubo-ovarian complex. And it's important to recognize this, because if the ovary is preserved, and it often is preserved a while from involvement of infection by the ovarian capsule, which is a barrier to the spread of infection, this will respond better to antibiotics. And so often these patients deserve a trial of antibiotics before they have any kind of a drainage procedure or surgery. And another thing that has been described recently is that the pelvic fat in patients who have inflammation or infection tends to become echogenic. This is not a specific finding for pelvic inflammatory disease and can be seen in patients with diverticulitis or inflammatory bowel disease. But in patients with PID, you'll see this increased echogenicity of the pelvic fat around the adnexa and around the uterus, as you see here. And if you see this, this increases your sensitivity for making this diagnosis. So in conclusion, in a patient with ovarian torsion, or with clinical suspicion, I should say, of ovarian torsion, don't be dissuaded by the history. Not all patients with ovarian torsion present with acute severe pain. In many patients, the pain is relatively mild or intermittent. Focus on the grayscale imaging features to make this diagnosis. Look for an enlarged ovary with a heterogeneous central stroma with areas of increased and decreased echogenicity, peripheral displacement of small follicular cysts, an abnormal midline location, and look between the enlarged ovary and the uterus to find that thickened adjacent pedicle, which on cross-section might show that target sign. When you do the Doppler examination, and we do this in all patients, do look for absence of flow, abnormal flow, and the whirlpool sign, because the absence of flow and that whirlpool sign are diagnostic findings for ovarian torsion. But don't be dissuaded by the presence of blood flow. Don't let this keep you from making the diagnosis of ovarian torsion if the grayscale features are classic. In fact, the presence of blood flow in a patient with ovarian torsion may be a good thing and may indicate that the ovary is salvageable. Look for similar findings on CT and use MRI as a problem solver. So again, on CT, you'll see an enlarged midline, non-enhancing ovary with thickened adjacent tube. And again, MR, you'll see the same thing, though often it's a little bit easier to see the pedicle and the increased signal intensity of that central ovarian stroma. In terms of hemorrhagic cysts, remember the key feature here is that there will be no Doppler flow except in the cyst wall, no matter what the pattern of internal echogenicity. Remember to get follow-up because clot will resolve or get smaller after 6 weeks. And remember that in patients who've ruptured or hemorrhaged, occasionally they can develop massive hemoperitoneum that requires surgery in order to stabilize them. In terms of patients with pelvic inflammatory disease, the most common finding, of course, is the presence of a complex, tender, vascular, and bilateral adnexal masses. But look carefully for some of these more subtle findings that I've described of PID, such as uterine serositis, echogenic pelvic fat, and that dilated adjacent tube, because this will increase your sensitivity for making this diagnosis. Thank you for your attention.
My name is Mary Frades. I'm from Brigham and Women's Hospital in Boston. My topic today is update on ectopic pregnancy. Let's talk about some background for ectopic pregnancy. Ectopic pregnancy essentially means that the products of conception have implanted outside of the endometrial cavity. This occurs in about 1.5% to 2% of all pregnancies. We care about ectopic pregnancy because complications of ectopics are the leading cause of pregnancy-related deaths during the first trimester in the United States. The majority of ectopic pregnancies occur in the fallopian tube. The ampullary portion of the tube is the most common site, with the isthmic section the second most common. Ectopics in the interstitial portion of the fallopian tube, the so-called cornual ectopics, cervical ectopics, ovarian ectopics, pretty rare. Who's at high risk for ectopic pregnancy? Well, the known risk factors are anyone with tubal scarring. So that's a patient who's had pelvic inflammatory disease or a prior ectopic pregnancy. Any patient with an IUD present in the endometrial cavity. And also the huge number of patients who are undergoing assisted fertilization for whatever reason. For the uterus or the tubes or the ovaries are not working completely normally, and those patients will be at increased risk for ectopic pregnancy. Now, it's interesting to remember that 25% of pregnancies that occur in patients with an indwelling IUD or a history of tubal ligation are ectopic pregnancies. So when you have a positive pregnancy test in that population, you want to be aware that they are high risk for ectopics. However, even knowing that, 50% of the patients with ectopic pregnancy comes in with no known risk factor. Here's what we're talking about when I say that patients with PID or scarring are at increased risk. So here's the hydrosalpinx. You can see the dilated fallopian tube. Here's the sausage shape or the curved fluid-filled dilated fallopian tube, and the cogwheel appearance coronal image, a transverse image of the fallopian tube, all abnormal tubes. The classic presentation of a patient with ectopic pregnancy is pain, vaginal bleeding, and an adnexal mass. In a patient who presents with those findings, if there's a positive pregnancy test as well, ultrasound should be the first test done. And here we see a tubal ring sitting right next to the left ovary. Let's talk about HCG. So trophoblastic tissue makes HCG 8 days after conception. Normally, an intrauterine gestational sac will typically be seen with transvaginal sonography once that HCG gets to 1,000 milli-international units. However, you should be aware that in a study done in 1997, 1/3 of the patients with HCGs of over 2,000 ended up with intrauterine pregnancies at follow-up. So from some data from our hospital at Brigham and Women's, we looked at 225 patients with ectopic pregnancies, all of whom had their HCG drawn within 24 hours of the transvaginal ultrasound. The HCG in this patient series ranged from a low of 7 to a high of 107,000, the average being around 3,000. It was significantly higher in patients with a live ectopic pregnancy, 20,980, as opposed to patients whose ectopics did not have cardiac activity, where the average was 1,900. The majority of the patients in our series did have an HCG of under 3,000, but 7% had an HCG of over 10,000. I'd like to just mention a cautionary case that we did see recently at the Brigham, where a patient came in with an HCG of over 4,000, and at transvaginal sonography, nothing was found in the uterus. In addition, nothing was found in the adnexa. We followed that patient up, and she ended up with a normal intrauterine pregnancy. So it is incredibly important to realize that patients should not be treated for an ectopic pregnancy unless you are absolutely certain that there is nothing in the uterus that could potentially be a normal intrauterine pregnancy. When you have a patient with a positive pregnancy test and no pregnancy is found in the uterus on transvaginal sonography, we term that a pregnancy of unknown location. And in this situation, there really are only 3 options. Either the pregnancy is in the uterus and it's too early or too small for us to identify with transvaginal sonography. The patient could potentially have just undergone a spontaneous loss or have a chemical pregnancy, or there may be an ectopic pregnancy. So how do you know whether there's an intrauterine pregnancy or not? Well, an intrauterine pregnancy, an intrauterine gestational sac, is round, has a very clear echogenic rim, and often will have a yolk sac, a fetal pole, or a fetal heartbeat. It should be located within the decidua of the endometrium. Don't be misled by fluid in the endometrial cavity. Here's a few examples of small gestational sacs. On the top left, you see a well-defined echogenic ring with a little bit of free fluid in the endometrial cavity, and you can appreciate, I think, the intradecidual location of this gestational sac. Bottom left image, again, a little tiny fluid collection within the decidualized endometrium, maybe too small to know for sure whether that's a gestational sac or not. And on the clip, you can see a little bit of a bigger fluid collection with a white ring in the decidualized endometrium. These can either be dictated as a small early gestational sac or as a probable gestational sac. Another case, clearly defined echogenic rim, round sac in the decidualized endometrium, and some fluid in the endometrial cavity, or likely blood. In comparison to these 3 cases, we can see that there's fluid in the endometrial cavity, very irregular, poorly defined, a little bit of debris in this one, but not a discrete, well-defined circular structure with an echogenic rim. In these cases, no gestational sac is seen. Some complex endometrial fluid is present. When we look at the endometrium in a patient that we're concerned about the presence of an ectopic or an intrauterine pregnancy, well, one of the things we can look at is how thick the endometrium is. Is this a reasonable thing to do? Well, in 2008, one author showed that if the endometrium was less than 8 millimeters in thickness, none of those patients had an intrauterine pregnancy. At the opposite end, in the patients with an endometrium over 25 millimeters, 4 patients with ectopics did have that very thick endometrium. Can we look at a trilaminar pattern, the multi-layered endometrium? Will that help? When we use a multi-layered endometrium with an attempt to predict whether there's an ectopic pregnancy or not, it has a very low sensitivity and a positive predictive value of only 50%, so flipping a coin. So trilaminar pattern, not that useful. Here's a patient who was seen recently on Clomid. By her last menstrual period, she should be 7.5 weeks. And when we look transvaginally, this was no intrauterine pregnancy is seen. Here's the image that was submitted to us as a normal right ovary. This was done at one of our remote sites. But at 7.5 weeks, we were concerned that there had to be a pregnancy in there somewhere. So she had the exam repeated that afternoon at the hospital, and here's the right ovary image that was then obtained. You can see that the right ovary with its corpus luteal cyst is here, and that there's a complex mass seen on the lateral edge of the ovary. And with a video clip, we can appreciate that there is an embryo with cardiac activity seen in this ectopic sitting right next to the ovary. So you do have to be careful. Just one picture of an ovary does not rule out the presence of an associated mass. Again, it's more important to identify a mass in the adnexa, and that's the best way to diagnose an ectopic pregnancy, rather than relying on the fact that there's nothing in the uterus. The earlier we can find a mass, the earlier we can take care of the patient. So unlike the traditional non-pregnant patient where you scan the uterus and you take a coronal and a sag clip of one ovary and a coronal and a sag look at the other ovary, that's when the study starts for ectopic pregnancy. You can do your standard exam, and then you have to start looking around for anything out of the ordinary that could be the ectopic. It's not going to be one of the traditional pictures that you're taking for your pelvic ultrasound. Here's a patient who had a history of ectopic pregnancy who came in with her dating at 4.7 weeks with some pain and highly concerned because of her prior history. And we could see, here's an image of the ovary, but just next to the ovary, we could see a soft tissue structure with blood flow just lateral to the ovary. And on the video clip, you can see the ovary is here, and there's this structure, which was a tubular, solid appearing structure just lateral to the ovary. This turned out to be normal fallopian tube in this particular patient, and on follow-up, there was a normal intrauterine pregnancy. So if the patient is stable and the findings are not convincing, the best thing to do is follow the patient, follow the HCG, and get a repeat ultrasound. What are we looking for in the adnexa? Well, the most convincing finding for an ectopic pregnancy is the presence of a tubal ring. A tubal ring is a round hypoechoic or anechoic structure with an echogenic ring around it, which is basically the gestational sac. You can think about the sac that we looked at, or early sacs that we looked at in the uterus, picking up that sac and moving it out into the adnexa and throwing it over there next to an ovary or next to the outside of the uterus. It's the same look. You're looking for a pregnancy sac. 25% of patients with ectopic pregnancy in our recent series did have a tubal ring. 8% had a tubal ring with a yolk sac, and 7% had a tubal ring with a yolk sac and cardiac activity. What does the tubal ring look like? Well, here's another patient with ectopic pregnancy. We can see the ovary here with a corpus luteal cyst on it and the bright echogenic ring with an anechoic center. Here's the yolk sac. And when we look closely, we can see an embryo and cardiac activity in this live ectopic. Here's another patient. This is a coronal image of the uterus, and you can see a beautiful intrauterine gestational sac, pretty much anechoic center, echogenic ring around the outside, and a yolk sac in the middle. But look at this, out in the left adnexa is the identical picture. Here's the echogenic ring, the anechoic center, and the yolk sac. And this patient has a heterotopic pregnancy with an IUP and a left-sided ectopic pregnancy. But it's amazing how similar the two pregnancies look. Sometimes the findings are pretty subtle. In this patient, here's the left ovary, and you can see there's a little tiny echogenic structure. Well, it got an anechoic center and an echogenic ring around the outside. Here it is measured, and here it is in the sagittal plane. It looks a little bit bigger. The ovaries up here. A very bright echogenic ring helps us know that this is a tiny early ectopic. Sometimes we don't see the echogenic ring and we just find a complex mass with poorly defined borders, very ill-defined. Over half of ectopic pregnancies in our series presented with this finding. When you see these ill-defined complex masses, take a really close look in the center of the mass because you may be able to find the tubal ring or a yolk sac or something that tells you that this indeed is an ectopic pregnancy with a large amount of clot around it. And if this complex mass is tubular, remember that you're likely looking at a hematosalpinx or a fallopian tube that has filled up with blood due to the central ectopic pregnancy within the tube. Here's what I mean by a heterogeneous mass. This is a patient who's at 5.7 weeks based on IVF. Here's the ovary, here's the edge of the uterus, and we can see this solid, nondescript, hypoechoic mass separate from the ovary, separate from the uterus, 2 centimeter mass. This is the ectopic pregnancy. In a different patient, we can see the ovary here and this tubular, somewhat echogenic structure in the adnexa. And if you look closely at this tubular hematosalpinx, you might appreciate that there's a little echogenic ring, almost like a donut, right in the middle of the structure. And when we zoom up on that adnexal ring, we can actually see that there are 2 gestational sacs, and this is a twin ectopic pregnancy out in that fallopian tube. This is an old case, but really illustrates what we're looking at very well. On the sagittal image in the adnexa, we can see the echogenic ring of our adnexal ring within this larger heterogeneous mass. And on that coronal image, you can see that this is actually the wall of the fallopian tube. Here's the gestational sac that's grown into the wall or attached to the wall of the tube. There's a little bit of bleeding inside the tube, giving you the hematosalpinx, and also blood that has gone out the end of the tube is now in the peritoneal cavity, outlining the outside of the hematosalpinx. So what really are we looking at? What are we looking for in the adnexa? Well, there's a well-known paper in Journal of Ultrasound and Medicine in 1994, which is a meta-analysis of 10 studies. And in that meta-analysis, the authors found that the most appropriate criteria for diagnosing an ectopic pregnancy is any non-cystic extra-ovarian adnexal mass. So think about that. The mass cannot be on the ovary, so anything not on the ovary, but it also can't be a cyst. So it cannot be the typical simple para-ovarian cysts that we see all the time. Crossing off the cystic structures, crossing off anything in the ovary. If there's anything else left in the adnexa, that's the ectopic pregnancy. And when you look at these non-cystic adnexal masses, there's a sensitivity reported of almost 99% and a positive predictive value of 96%. This study was re-looked at in 2005, and the numbers, if anything, are better. Almost 100% sensitivity, positive predictive value, again, well over 93%, and a negative predictive value of almost 100%. So here's another example of an ectopic pregnancy. The ovary is here, and there's a big mass here which is very echogenic, ill-defined, doesn't really look like a gestational sac, but it certainly is a mass in the adnexa. It's not a simple cyst. It's not on the ovary. You can see we're pushing on it here. It's very ill-defined. It doesn't have a lot of information. Pretty close to the ovary, a little bit of free fluid, and a video clip through the mass showing the ovary here. But look closely at this mass. Look very closely. Watch the whole clip. Right at the end of the clip, is this. Here's the tubal pregnancy right here. And if you look at it, I'll put my arrow right on it. It's right there, right at the end. There's a little tiny sac in the middle of this enormous clot. So look carefully when you see these big masses. Sometimes your answer is right in the center. In comparison, in this other patient with ectopic pregnancy, we do again see an echogenic lesion in the left adnexa. And on this clip, you can see that there really is nothing within it. And this is just a collection of trophoblastic tissue, that bright echogenic trophoblastic tissue in the hematosalpinx, and free fluid with echoes around the lesion. So less specific, but just as suspicious for the ectopic pregnancy. So things to think about when you're looking at the adnexa and you find a mass. One question is this mass part of the ovary or not? And that's a useful thing to help you decide whether you are concerned about an ectopic. But also look at the mass and determine what the echotexture of the mass is. So what do I mean by movement of the mass? Well, if you, during a transvaginal scan, place some pressure on the patient's anterior abdominal wall as the vaginal probe is on your lesion and push, you can see here that the ovary stays lateral and the ectopic pregnancy slides away and slides medially. So this shows us that this lesion is not part of the ovary. It moves separately from the ovary. In comparison, this patient who has a complex lesion on the medial edge of the ovary, when we push, the lesion sticks with the ovary. It all stays together. We cannot separate this off the ovary, and that's because this is the corpus luteum, not an ectopic. When you look at movement of an adnexal mass, the majority of patients with ectopic pregnancy did show movement of a mass with palpation. A few patients without ectopics also showed movement of the mass with palpation. Potentially that was some hematoma or some normal fallopian tube that can slide away from the mass. So that is a reasonable thing to do to help you determine whether the lesion is part of the ovary or not. Here's a patient with an empty uterus, no intrauterine gestational sac. Here's the ovary, so we do see a mass next to the ovary. And again, when we use pressure, you can see that the ovary slides, but this adnexal mass rolls. It would be impossible for a cyst, a corpus luteal cyst on the ovary to turn or roll. So that motion, even though we're not really separating them, we can see the mass move whereas the ovary slides away. So that confirms our suspicion of an adnexal mass and an ectopic pregnancy. Here's a patient who came in a few years back with persistent abdominal pain, having undergone IVF. And she was told at an outside hospital that she had an intrauterine pregnancy, and indeed we do see an intrauterine pregnancy with at least one yolk sac, potentially 2 yolk sacs, but she's still having pain, and notice there's quite a bit of free fluid over on the right side of her pelvis. So out in the right adnexa, she had an enormous heterogeneous, complex mass. This is where all her pain was. And looking at the mass, I was able to appreciate, I thought, well, let me see if I can find the ovary inside this mass. Is this just the ovary that has a hemorrhagic corpus luteal cyst, or is this a problem? And inside the mass, I could see this hypoechoic ring and an echogenic ring, both. Turning on the color, you can see color flow here around the patient's corpus luteum. This is the right ovary, and right next to the ovary, an echogenic ring, also with a little bit of blood flow, and this is her heterotopic pregnancy, creating a lot of clot around the right ovary. Well, when we are trying to figure out whether we're looking at a tubal ring or a corpus luteum, we did do a study a few years ago looking at the echogenicity of the tubal ring in comparison to the echogenicity of a corpus luteum. We had 26 patients in that series who had a tubal ring with a yolk sac or with a heartbeat. And of those 26 patients, 88% of the rings were brighter or more echogenic than the ovary. We also had 13 patients with empty rings, no yolk sac, no heartbeat, no way of knowing whether this was truly an ectopic, and yet 77% of those patients, the ring was more echogenic than the ovary. We had a control group of 45 patients with a normal intrauterine pregnancy and no ectopic. And in those patients, the corpus luteum was more echogenic than the ovary in only 3%. So the vast majority of corpus luteums are isoechoic or hypoechoic. The vast majority of ectopics are echogenic. This is what I mean. These are patients from our series. Here's the ovary here, and here's the echogenic tubal ring. And you can see that the wall or this ring is clearly much brighter than the parenchyma of the ovary. In comparison, here's the thick-walled corpus luteum, hypoechoic in relationship to the echogenic ovarian parenchyma. So the relative echogenicity of an adnexa ring can be a very useful characteristic if you can't figure out based on location whether you're looking at a tubal ring or a corpus luteum. Another paper looked at this where they compared the echogenicity of the ectopic and the corpus luteum to the endometrial stripe. And in this study, they found that the wall of the tubal ring or of the ectopic was brighter than the endometrium in 30% of the ectopics, but none of the corpus luteal cysts. The wall of the lesion was less echogenic than the endometrium in a third of ectopics, but in the majority of the corpus luteal cysts. Here's a patient that was seen overnight a few years back, and one of our residents took this transvaginal image showing an intrauterine pregnancy. There's a yolk sac and there's a heartbeat of 106. And out in the adnexa, here's the right ovary, and they found this lesion out in the right adnexa with an echogenic ring around it, brighter than the ovarian parenchyma. The resident was very concerned that this was an ectopic pregnancy, and the patient was taken to the OR. Well, there's a couple problems with that scenario. One is if we look closely at this echogenic lesion, we can see that the ovary itself goes all the way around the echogenic lesion, and this is clearly an intra-ovarian cyst, not a non-ovarian lesion. So that's one reason why we shouldn't be concerned about an ectopic. Number two, the patient has an IUP, so they're less likely to have an ectopic pregnancy. Number three, or the third problem with this case, is that the patient went to the operating room even with a completely stable clinical picture, no free fluid, normal blood pressure. This patient probably should have been watched rather than taken to the OR emergently in the middle of the night. And this is what happened when they got to the OR. Here's the lesion. You can see that this is the ovary here, and this lesion is clearly intra-ovarian, and it was simply the corpus luteum, and here's the uterus here. Now, this patient did fine, and the intrauterine pregnancy continued normally, and the gynecologists were clearly did not remove the corpus luteum, and that just closed up and the patient went home. But it's important to remember to use the echogenicity and the location of the lesion, not one over the other. Now, when we're looking at a tubal ring versus a corpus luteum, what about Doppler? Can we do Doppler of the lesion and help us distinguish between an ectopic pregnancy or a corpus luteum? Well, the resistive index around an ectopic pregnancy is widely variable and can go from 0.1 to 1.6. That's a huge span, as opposed to the corpus luteal resistive index, which is much lower, somewhere between 0.39 and 0.7. So it did show us that an RI of greater than 0.7 was 100% specific and had a positive predictive value of 100%. But that's not that useful because only 1/3 of the ectopics in this study did have an RI that was that high. Well, here's another finding we can look for in the adnexa. What about the presence of free fluid? What's important when we look at fluid in the cul-de-sac in a patient at risk for ectopic pregnancy to determine whether there are echoes in the fluid or whether the fluid is anechoic. The reason is that when there are echoes in the intraperitoneal fluid, there's a very high correlation with hemoperitoneum. And that suggests to us that this patient is at very high risk for an ectopic pregnancy. And this is an old paper from 1991, but has stood the test of time. In 1998, an article in JUM looked at 185 patients who were taken to the operating room for ectopic pregnancy. In those patients, 125 of the patients had echogenic fluid at the time of the ultrasound, and over 98% of the patients blood was found at surgery. In the 30 patients with anechoic fluid, 0 had blood. And in the 30 patients with no fluid at transvaginal sonography, 0 had blood. So this confirms that echogenic fluid in the cul-de-sac does correlate with hemoperitoneum in patients with ectopic pregnancy with high sensitivity, specificity, and positive predictive value. In another study done in the Annals of the American Journal of Emergency Medicine, 38% of patients with pregnancy of unknown location had isolated free fluid. Of these 38 patients, 42% ended up with ectopic pregnancy. About a quarter of those had a moderate amount of fluid, and 3/4 of the patients who presented with a large amount of fluid. So it does tell us that patients with isolated cul-de-sac fluid are at a moderate risk for ectopic pregnancy. And if the fluid has echoes in it, or if there's a large amount of fluid, we're going to be more worried about those patients. Here's a patient who presented at 5.4 weeks, and out in the left adnexa we see complex fluid, ill-defined, maybe sort of clumping up here, suggesting a clot. And on the right side, a large amount of fluid with low-level internal echoes. And in this patient, this was the only finding of an ectopic pregnancy. We could not find a mass. We could not find an intrauterine pregnancy, just echogenic hemoperitoneum. What about the patients with a completely negative exam? Well, why do we miss ectopic pregnancies? It could be because the pregnancy is extremely early. If the pregnancy is under 5 weeks, these are very, very small, and it could be too early for us to see in the uterus. It could be too early for us to see in the adnexa. Patients with a high BMI, patients with a lot of fibroids, inexperience of the sonographer, or patients who have pathology in the ovaries make it difficult for us to find the ectopic pregnancy. 5% of the patients in our series had 0 findings at their pelvic ultrasound. If the patient is stable in this instance, the most important thing to remember is you haven't found an ectopic, just get follow-up ultrasounds and HCGs, because we need to make sure that that patient does not have an intrauterine pregnancy. If the patient is unstable, she has to go to the operating room, whether we found the problem or not. Here's a patient in whom the presence of pathology in the ovary made it very difficult for us to make the correct diagnosis. This is a patient who had undergone IVF, and following the IVF had hyperstimulation. And you can see on this clip that there are very large cysts on the ovary sitting down in the cul-de-sac, and we have free fluid, again, all related to the hyperstimulation. On this video clip, I don't know if anybody has noticed anything going by, but when we look a little bit closer, you may or may not see it now. Here's the big cyst on the ovary, and here's a little complex lesion with maybe a little flicker. And here's the zoomed up image, and now it's easier to see the echogenic ring, the yolk sac, the embryo, and the heartbeat. But I will say, in view of the large cysts on this ovaries and the known hyperstimulation, we did not immediately see this, and the patient went to the OR for persistent pain. This turned out to be a primary ovarian ectopic, and we were completely thrown by all of the other pathology in the ovary and missed this little tiny ectopic sitting on the edge. What about tubal rupture? You hear a lot of conversation about tubal rupture with ectopic pregnancies or ruptured ectopics. And remember, when you talk about a ruptured ectopic, you're not talking about the gestational sac itself that has popped for some reason and the yolk sac fell out. We're talking about the fallopian tube that ruptures and with the gestational sac inside. Well, we care about it because there is an increasing trend across the world toward medical management of ectopic pregnancy. And if the patient is going to be managed non-surgically, it's very important that we know that the fallopian tube is intact. So can we help? Can transvaginal sonography tell the referring gynecologist whether the fallopian tube is intact? In our retrospective study, we had patients who had ultrasounds within 24 hours of their surgery, and all of the patients had ectopic pregnancy proven at surgery. This study was composed of 143 patients, And at the time of surgery, 75% were unruptured and 25% were found to be ruptured at pathology. When we looked at those 143 patients and we divide the ultrasound findings to whether there was a cardiac activity, a yolk sac, just a tubal ring, a generic looking mass, or no mass at all, the rupture rate in these categories was not significantly different between any of the categories. There is no statistical significance based on what the adnexal mass looked like or even whether there was a mass at all. It turned out that the rate of rupture in our series was significantly higher if the fluid was moderate to large. A third of those patients were ruptured, as compared to the patients with small or no free fluid. Only 17% of those were ruptured. However, moderate to large fluid had very poor sensitivity for tubal rupture and a very poor positive predictive value. What about HCG levels? Can we look at the HCG level and determine whether that patient has a ruptured tube? Well, we had 139 patients who had an HCG within 24 hours of their surgical confirmation of ectopic pregnancy. And it turns out that there is no cutoff level that predicts tubal rupture. And interestingly, approximately 10% of our patients with very low HCGs did have rupture of the tube at surgery. Here's two patients with very similar ectopic pregnancies. Here's the ectopic here. You see the bright echogenic ring and the central yolk sac. In this patient, the bright echogenic ring. Here's the yolk sac. These look very, very similar to me sonographically. One is ruptured and one is not. The answer is this is the ruptured ectopic. Clearly, we cannot tell the difference based on the sonographic appearance. So remember that tubal rupture is possible when we don't see a mass at all or when there's little or no free fluid. There's no single appearance that we can see at sonography to guarantee no tubal rupture. And there is no single HCG level that we can use to completely exclude a tubal rupture. So last but not least, finishing up, what about the role of 3D imaging? Well, 3D imaging can be very helpful when we're looking at the more unusual types of ectopics. In other words, cornual ectopics, tubal ectopics, or normal implantation. It's useful with cervical pregnancies and particularly useful with C-section implantations as well. So here's a patient with a retroverted uterus, and we can see this big echogenic lesion in the lower uterine segment. And because the patient is retroverted, we know that this is the site here. This is the anterior surface of the uterus. This is the site of the prior cesarean section. This is where the C-section scar is. And this pregnancy is almost certainly a cesarean section implantation. And on the video clip, we can see the pregnancy. We can see the bulge of the anterior myometrium. And with color Doppler, we can see blood flow going out, around, and extending to the surface of the uterus, that the whole placental or trophoblastic tissue has penetrated the myometrium. And on this 3D coronal reconstruction, here's the fundus of the uterus up here. The pregnancy is clearly not at the fundus. And this picture has been rotated, so this is the back of the uterus, and this is the front of the uterus. And we can see that the myometrium is completely disrupted here in the lower uterine segment, and the pregnancy sac is bulging out of the cesarean section scar. Here's a patient who came in at 5.5 weeks with a question of a C-section scar implantation. So the uterus is here, the fundus is up here, down in the cervix, and this is the region of the C-section scar, and indeed this gestational sac is quite low in the lower uterine segment. And the question is it possibly going up into this C-section scar or not? So what do? The patient's asymptomatic. We're going to follow this patient up, and here she is at 6.5 weeks, so a week later, and here's the 3D reconstruction, anterior view. You can see the pregnancy sac still in the lower uterine segment. But to really know whether the cesarean section scar is involved, we have to rotate the image so that we can look at the anterior surface of the uterus. And here's the cesarean section scar right here. And you can see that the gestational sac is seated well away from the scar. I will point out, however, that on 2D imaging, we can see the cesarean section scar right here, and the gestational sac well above the level of the scar with 2D imaging quite clear as well. What about cornual implantations or the true interstitial pregnancies? Here's the uterus, the endometrial cavity, no gestational sac seen there. Up at the right cornua or the right fundus, we can see the pregnancy with the echogenic rim and embryo, cardiac activity, and here's the myometrium heading out and around at least one part of this pregnancy sac. Lots of color flow seen around the implantation, and when we push, we can't really separate this pregnancy from the bulk of the uterus. You can see it's certainly separate from the endometrial cavity. And on the 3D coronal reconstruction, you can see that the pregnancy is disrupting the myometrial surface at the right fundus, so it's a true interstitial or so-called cornual ectopic. Another patient with a cornual implantation, this one is a little tougher because if you notice on the video clip, the endometrial stripe is diverging. So we're looking at possibly a subseptate uterus. And in that instance, you want to be careful because you're going to have some asymmetry and the sac can be located well off to one side or another. The issue becomes whether there's myometrium all the way around the pregnancy, whether the pregnancy is still in the endometrial cavity or not. And here 3D became was very useful to us. So you can see on the reconstruction that the patient does have a subseptate uterus with a big piece of this fundal myometrium diving down into the endometrial cavity. But we can also see that at the right horn, out at the right cornua, that the endometrial cavity ends here, and the gestational sac is separate from the endometrial cavity and partially covered by a very thin myometrium. And this was a very useful time for 3D imaging when you have an anomaly of the uterus and a pregnancy not smack in the center of the endometrial cavity. In comparison to this patient, where we can see the endometrial cavity and we can see the pregnancy that is not in the endometrial cavity. And on the 3D reconstruction, here's the gestational sac sticking onto the left corner, quite a bit of myometrium here, quite a bit of myometrium here. The question is this myometrium coming out and around? And this 3D image was actually a little bit misleading because when we pushed on this pregnancy, we could actually see that the pregnancy moved separately from the uterus. And this is an intramural ectopic pregnancy, or a pregnancy in the part of the fallopian tube very close to the uterus, but not the interstitial component of the tube, just really close by to the uterus, and just a tubal pregnancy mimicked, which mimics a cornual ectopic on the 3D imaging. So make sure that you use all of the tools at your disposal. In conclusion, transvaginal sonography continues to be the optimal method for evaluation of ectopic pregnancy. Early diagnosis of ectopics allows less invasive treatment options for our patients. It's important to do a close evaluation of the endometrium, a close evaluation of the adnexa using palpation and 3D imaging when necessary, and critically important, the stable patient with a pregnancy of unknown location, follow-up is best in that patient. Thank you very much.
I'm Dr. Ted Lyons from Winnipeg, Manitoba, Canada. I'm going to be talking today about postpartum bleeding and focus on some of the things that are of concern and may be difficult in the clinical situation, such as retained products or even AV malformations. I have no commercial associations, and most of the photographs have actually been taken myself, so I give myself permission to use these. Late postpartum hemorrhage, either from spontaneous vaginal delivery, therapeutic abortion, or spontaneous abortion. Is there a normal amount and duration? Yes, there is. There's a gradual decrease in flow and change in color from red to watery pink, and it may last up to 2 to 3 weeks, but it's abnormal if anything lasts more than 2 weeks postpartum. If there's persistent bleeding, or even if there's stop and then start several weeks later, those are all abnormal. So what are the causes of postpartum bleeding? Well, continuous bleeding may be due to a failure of the endometrium from which the placenta came, the failure of the endometrium to regenerate, or subinvolution. You can also obviously have retained products. In a start and stop situation, endometritis, inflammation, or an invasive mole, gestational trophoblast disease, and also AV fistula or AV malformation. But you have to watch out for that, and we'll talk about that later. Well, why is it important to get the exact cause of the bleeding correct? Well, obviously, it's important because there are different treatment options with each one. So delayed endometrial regeneration, you don't do anything. You wouldn't go in and do a D&C on something where there is a normal placental bed, but it just hasn't regenerated quickly enough. Retained products, obviously, with tissue in there, you're going to want to remove it, so a D&C. Endometritis is inflammation, and antibiotics are important. An invasive mole, hydatidiform mole, needs methotrexate. And finally, the AV fistula or malformation, which may be traumatic or post-traumatic, angiography is very good to assist in the diagnosis and also in the treatment with embolization. Or you may just simply want to watch it. Bottom line is you've got to treat the patient, not just the image. In unexplained postpartum vaginal bleeding, it's really important to use color and to use spectral to see where there is flow and to track the velocities. Very high velocities are of concern. Delayed regeneration of the endometrium. Here we have a coronal view of a uterus, and there's a spot that I have identified that was where the placenta implanted, and there's bleeding from of it. So it presents with persistent bleeding, probably due to subinvolution, the endometrial bed, the endometrial defect that was the placental bed has not yet re-epithelialized and has not gone back to its normal state. So the endometrium and decidual basalis have not regenerated the placental site. Usually, as you would expect, the ultrasound is negative. You don't see a mass, and there's no increased color velocity. Obviously, conservative therapy. There's nothing to do other than to wait and see. Obviously, a D&C is not only not necessary, but would even be counterproductive. So a typical case might look like this. Nice normal uterus, anteverted, nice endometrial canal, normal endometrium, and the myometrium. Retained products of conception. It usually presents with persistent bleeding, and here I've drawn a retained cotyledon from the placenta. Well, in a complete abortion, clinically, there is no bleeding. Ultrasound, no mass, endometrial fluid, or increased vascularity, and the uterus is non-tender. So here's a nice case of a complete abortion. She did have a gestational sac at 6 weeks. Now it's all gone. Now there's normal vascularity. So there's no retained products. But how would that compare to a situation where there is retained product? So here's a patient who is bleeding at 11 weeks menstrual age. She was passing clots. You look in the endometrial canal and there's normal vascularity. So it's a thin stripe, no significant increased vascularity. Empty uterus, no increased vessels. Again, another complete abortion from a early pregnancy that we had seen 2 weeks prior, a nice normal 8-week pregnancy that aborted spontaneously. So in retained products, what are the findings? Well, clinically, they almost always have bleeding, and they may well be passing some tissue. The ultrasound examination within the endometrial canal, you can have a wide endometrial stripe, you can have a mass, or you may see nothing at all. Color and spectral is critical. You may see a single or a group of vessels and usually have high velocity flow. It can actually be very striking how high the flow velocity is, and it may generate a lot of concern, but remember, it's usually a normal finding to have high velocity flow in retained products. The uterus is non-tender on pelvic examination. We always look for tender uterus or tender adnexa that might give us a clue to what the actual patient's problem is. Not everybody does this, but I think it's very, very important. In cases with endometritis, pain and a tender uterus is very, very important. So if you have retained products and you also have some infection that can happen, you have vaginal bleeding that may be persistent, you often have an echogenic mass in the canal, remember it can be retained products or it can just simply be a hematoma, and they may be difficult to differentiate, although the hematoma will not have any internal vascularity. You will have focal increased vascularity in retained products, obviously, but not in hematoma. If there is infection as well, pain and tenderness will give you the indication of endometritis. If you don't push on the uterus and ask the question, does this hurt? Then patients will not be able to tell you that it's tender, and you will miss the diagnosis of associated endometritis. So it's very important to ask the question, does this hurt, when you're pushing on the uterus or the adnexa? So here's a case, a patient who has bleeding. You can see there in the central endometrial canal a mass measuring about 17 millimeters in diameter with increased vascularity. The uterus was non-tender, so you have bleeding, you have a mass, you have vascularity in a non-tender uterus. This woman was 3 weeks postpartum, passing clots. She has retained products, and the treatment is a DNC. A woman who had a therapeutic abortion at 5 weeks menstrual age, gushing blood, has this large echogenic mass identified by the arrows. She had retained products at pathology, and you can see on the color Doppler that there's tremendous increased vascularity in that mass. So the mass, the increased vascularity, and the clinical situation of a patient who is bleeding following a therapeutic abortion are all indicative of retained products, and that's what it was. I mention this specifically because many centers use just 2D ultrasound and don't always use endovaginal, and endovaginal is critically important, but also is color and also is identifying focal areas of tenderness. Another patient, 3 weeks after a spontaneous vaginal delivery, had an area of increased echogenicity, tremendous increased vascularity. So obviously we're thinking about retained products. And here on a video, you can see the area of increased vascularity in the fundus, an area that is common to have retained products. And when you do the spectral, you can see high velocity flow over 100 centimeters per second and even up to 160 centimeters per second. So retained products. A woman who had a therapeutic abortion 6 weeks ago, continuous bleeding, does she have retained products? You look at this scan and you say, well, I'm not sure if there's anything going on, but look carefully. There is an area of increased echogenicity in the myometrium anteriorly, and there was increased vascularity and high velocity flow. So whereas the 2D image was perhaps a little bit subtle, the color turns you on to the fact that she has retained products. And in fact, at DNC, they had retained products. So retained products has a variety of appearances. Here's another patient, 30 weeks. She had, she's 4 weeks postpartum, post-cesarean section, with bleeding and a very subtle mass. So here you see this beautiful triangular shaped defect, typical of a previous cesarean section. You may not have really appreciated this echogenic mass up in the fundus. Here it is highlighted, but that echogenic mass was retained products. You turn on color, you have an area of increased echogenicity, and at DNC this was retained products. So she had a mass, pain, a mass, bleeding, and increased vascularity. Sometimes it's very difficult. This 35-year-old woman has been bleeding for 2 weeks after a spontaneous abortion at 19 weeks. Does she have retained products? That's usually the question that they ask. Does she have retained products? You look at that, and the uterus is certainly bulky. The endometrial canal looks empty. But what about this area? It is heterogeneous. Is this an area of retained products? She actually had an area of increased vascularity right in that subtle area. So we suspected that she did have some retained products there. Again, more based on the area of increased vascularity. And this, in fact, at DNC was proven to be retained product. So there's a wide variety of appearances of retained products. Here's a patient who had a therapeutic abortion 6 weeks ago. She had at the time a 5-centimeter corpus luteum cyst, and it was felt to be useful to follow up the cyst. She's on day 5 of a rather heavier than normal period. Other than that, she's had no symptoms. Sonographically, on sagittal view, you see nice endometrial canal. Transverse view, similar. Nice endometrial canal, nice myometrium. Nothing really exciting. But you turn on the color. And here you see, again, an area of increased vascularity extending down to the endometrial canal. And there was some increased vascularity. So this patient actually had a DNC and had a small area of retained products. I suspect this is far more common than we actually see, small areas of retained products. And is treatment always necessary, or will these actually resolve spontaneously? So to treat or not to treat, that's the question. Most gynecologists treat the symptoms. You don't treat the images, you treat the patient, you treat the symptoms. If there are ultrasound findings of retained products but no bleeding, do you watch and wait? Most will. Except if there is a large mass and signs of myometrial invasion, and that should be monitored closely on ultrasound. And obviously, if you have tenderness, signs of infection, uterine tenderness, they're going to want to give antibiotics. You're never going to know if that uterus is tender unless you say the words while you're pushing on the uterus, does this hurt? Is it tender? Here's a wonderful example. 35-year-old girl at 15 weeks, bleeding. Is this an incomplete abortion? Is there retained products after an abortion? She has an area of increased, an area increased in, she has tissue, or she has echogenic material within the endometrial canal that has no vascularity. So is this an incomplete abortion with products of conception in the lower uterine segment, or could this just simply be a blood clot? Again, treat the patient. She was bleeding. They did a D&C. This is a very interesting patient. She was absolutely asymptomatic 3.5 months postpartum. Maybe she had a little bit of spotting, or else she wouldn't have come to ultrasound. We saw this large mass, echogenic mass with no increased vascularity, situated right in the endometrial canal. When I called the doctor and I said, there's something going on in there, she was absolutely amazed. She said, are you sure? Because this woman is absolutely asymptomatic. No, I said, there's definitely tissue there. She said, well, okay. They did a D&C, and there was retained products. Most unusual in a woman with very, very little symptoms for such a large mass lesion. She had, again, the mass, but really very little bleeding, not a lot of increased vascularity, and non-tender, but she did have retained products. Another patient, 9 weeks post-cesarean section with bleeding, passed clots 2 days ago. Well, you do the scan. Endometrial canal is not bad, no real increased vascularity. So it looks pretty normal. And in this patient, you may well want to just simply, again, treat the patient. She's not having a lot of symptoms other than some bleeding. She may well be treated, and was treated, conservatively. A 29-year-old patient, 12 weeks, but no bleeding. She has passed clots, but there's no bleeding right now. She has a wide endometrial stripe and some increased vascularity. She was pregnant. Here is a 5-week pregnancy. She had a therapeutic abortion. And the question is, what do you do? Well, this was her again with a large empty gestational sac. So on the sequence of events, she had an early pregnancy with a large yolk sac. Now she has a failed intrauterine pregnancy, and so you're going to want to monitor it. She actually passed the sac. Here is where the implantation was, where that increased vascularity, and here you see that area of retained products is where the implantation site was originally. So there's good correlation. She had retained products. She doesn't have any bleeding now, so how are you going to actually treat this patient? I think that this, and here you can see the vascularity on the cine. You can see the increased vascularity on the posterior wall, which was the site of the retained products. This particular patient, they watched her. She had no clots in the last 7 days. The endometrial stripe is now thinner. The question is, was there any increased vascularity? And in fact, there was some persistent increased vascularity. And she had some retained products, no mass, just the vessel only. 1 week later, no vessel. So was this really increased? Was this really retained products? Or can you just see a persistent vessel that may in fact resolve on its own? And do you always need treatment? So regardless of what the ultrasound may show, you got to treat the patient. And so she had conservative treatment with resolution 2 weeks later. Another patient, 12 weeks, menstrual age, bleeding, past a fetus. Does she have retained products? So she has a widened endometrial stripe with no increased vascularity. She had a DNC the next day. They had decidual only, but no evidence of retained products. So she had the DNC because she was bleeding, but we didn't see any increased vascularity here. A woman who was 22 years old, had a therapeutic abortion at 9 weeks. Some bleeding that has now decreasing, so does she have any retained products? So she has a widened endometrial stripe, she has some echogenic material, no increased vascularity. How are you actually going to treat this patient? She has no bleeding, she has maybe a little bit of a mass, and no vascularity. And so you may well want to treat this patient conservatively. Retained products and endometritis. You have to do an endovaginal exam in order to assess uterine tenderness, and you have to ask the patient, does this hurt? So here's a patient 2 weeks postpartum. She has pain and bleeding. So here on ultrasound, you can see the echogenic mass, you can see all kinds of increased vascularity, and she has a tender uterus. She has little bits of air in the endometrial canal that you may or may not see. But the uterus was tender, so she has retained placenta, retained products, and she has endometritis. And here, and then following a DNC, she had a DNC, and following a DNC, she had that mass removed with only a small amount of fluid in the endometrial canal. Endometritis with retained products or without retained products. 4 days post-therapeutic abortion, fever and increased white count. Obviously, if patients have all of the clinical signs of infection, maybe they're passing some foul-smelling fluid, they have a fever, they have increased white count, there's no question that they have an infection somewhere. And if they've had a recent instrumentation in the uterus, that's the area that you're going to look at. And she has retained products, and she has a tender uterus. Here you can see tender. She has a tender uterus, so she has retained products as well as endometritis. A 20-year-old who had a therapeutic abortion 5 weeks ago, she's bleeding despite antibiotics. Some physicians, if a woman comes in following a therapeutic abortion and has very minimal symptoms, but has some uterine tenderness, and you can see the uterus was tender on ultrasound, they may just give them antibiotics in the office and not, in fact, do an ultrasound examination. So here they did the ultrasound. Is there any abnormality? Well, there may be a small area of increased tissue with some increased vascularity. This could be a small area of retained products, but a tender uterus. So she had a DNC to remove this area of retained products, and she had antibiotics to cover the infection. Endometritis only may appear with spotting or bleeding weeks after delivery. The scan is often done to rule out retained products. They may have minimal discharge or minimal fever. Ultrasound findings may be normal. There may be some endometrial fluid, maybe some air occasionally, and uterine tenderness on endovaginal examination. And obviously, the treatment for endometritis only is antibiotics and not a DNC. Here's a patient who had a therapeutic abortion at 16 weeks. 5 weeks later, she's got some bleeding, fever, foul-smelling discharge, no history of pelvic inflammatory disease. The uterus looks fine, no retained products, but the uterus was tender to palpation. She has endometritis, and she would be treated with antibiotics only. A patient 3 weeks postpartum, recurrent fever, pain, manual removal of the placenta. That's a key. Someone put their hand in there in order to treat the patient at the time for a placenta that was overly adherent, so they may well introduce infection into the uterus. She has some free fluid in the endometrial canal, echogenic areas consistent with air, so she had, and a tender uterus, so she had retained products. Here's a patient 5 days after a cesarean section, has fever, so obviously there's some infection somewhere. This is a view of the lower uterine segment. Here we're looking at the cesarean section scar, but it actually has a hematoma within it. It has a mass, and it has areas of increased echogenicity consistent with air. So she has an infected cesarean section hematoma. Another patient, and this is a real dilemma. This is a patient who has, she had a therapeutic abortion, and now she comes back with some bleeding. You see areas of significant increased vascularity with high velocity flow. And the question is this just simply retained products? So high velocity vascularity, retained products, is very common. Remember, there are AV fistulas within this adherent placental tissue, so they're common in retained products. You can successfully treat it with a DNC and seldom have excess blood loss. But when you're looking at the myometrium, one of the things that you should look at, not always there, but one of the things you should look at is, are there any large myometrial holes that may have high or even low velocity flow? A large AV fistula, and this is different than retained products because there's a tremendous amount of flow, has usually large holes in the myometrium, large vessels, and excess bleeding. And in fact, one of the concerns is that they can exsanguinate. So, causes of bleeding. AV fistula or malformation, remember, it can still be retained products. Gestational trophoblastic disease, what is the difference? With an AV fistula, people will bleed like stink. You're gushing blood. The beta may well be negative. High velocity flow, large holes in the myometrium, and treatment. You may have to do compression with an intrauterine catheter. You may want to embolize, or you then may want to wait, and some of these people may actually require hysterectomy. With gestational trophoblastic disease or a mole, you have moderate bleeding. The beta-HCG is going to be positive. The vascularity that you see has low velocity rather than high velocity. You may actually have large holes in the myometrium and a mass of vessels, but you're going to treat it mostly with methotrexate. You may also require a DNC. So here you have a patient bleeding 6 weeks after a therapeutic abortion. Question was there retained products? Here you can see a mass of tissue. In this particular patient, an article had recently come out about AV fistulas, and so we were keen on looking at the vascularity. And you can see these corkscrew vessels, high velocity flow. We were concerned that this patient actually may have an AV fistula. not just retained products. So we talked the radiologists into doing an angiogram, and they saw areas of rapid filling of venous flow as well as arterial flow. And they said, yes, there is some AV fistulas there. The seasoned angiographer said, no, she's a young girl, I'm not going to do any embolization. I'd have to embolize too much, and I don't want to affect her potential fertility. So he did nothing. I wondered what became of that woman, and 6 months later I called her back for a repeat ultrasound. I said, whatever happened after you had the angiography? She said, well, nobody treated me, the bleeding stopped, and 6 months later, obviously, she had nothing serious, and now she's pregnant again. So it's clear that what the seasoned angiographer did is just give this woman a tincture of time, watch her treated conservatively, and not do any angiography was the right treatment. So now you look at a patient who has huge volume and extent of flow, 26 years old, has had numerous pregnancies, and now you see a uterus that has these big holes in it. It looks abnormal. These big myometrial holes and some fluid in the endometrial canal. Whatever this is, this can't be normal. So this we were really quite concerned about. We brought her, we turned on the color, and here she has flow, extensive flow throughout this myometrium. This is definitely abnormal, and she did have increased flow. So the flow was not that high, but it was definitely abnormal for sure. So now what are we going to do? Here in power Doppler, again, shows the massive amount of flow in the uterus. So she needs an angiogram, and they did an angiogram on her. Then you can see that as soon as they put contrast into the left uterine artery, she's almost immediately getting huge amount of venous flow. So she's got a large AV fistula in that uterus, and that's what's causing all of the ultrasound findings. They also had increased flow in the ovarian artery as well. So what they then did was, here you can see the right ovarian artery. That also has significant increased flow. So this patient needs surgery. Post angiography, they embolize the uterine and right ovarian arteries in order to control the flow prior to surgery. And here you can see some of the coils that were put in. They then took her to surgery. So here you can see the uterus and the right ovary, the enlarged right ovary. Here you can see the uterus and the left ovary and the large right ovary, normal left ovary and enlarged right ovary. They removed the uterus uneventfully, and the uterus looks not too bad. When you open it up, you can see these large vessels that obviously, because the pressure from the arterial system has been removed, the vessels are much less dramatic. But this patient had AV fistulas that could have been disastrous for her. Another patient, she delivered at 21 weeks, manual removal of the placenta, and she has, again, tremendous area of increased vascularity and sort of small holes in the myometrium. Is this an AV fistula? Is this something that we have to be really concerned about? She had tremendous amount of vascularity seen associated with this, with these holes and with the mass in the endometrial canal. So she had large vessels, increased velocity, what are you going to do? Does she also need a hysterectomy? She's only 22 years old, and she's just delivered a baby. Well, the patient went to the ward after ultrasound. She had uncontrollable bleeding, so now you're wondering about AV fistula. The interventional radiologist would not embolize, and so the obstetrician put in an intrauterine balloon, really just a Foley catheter. The balloon stopped the bleeding, compression. It stopped the bleeding, and 24 hours later it was removed. She had no bleeding, and she was sent home. 2 weeks after what looked like a disastrous situation, the uterus looks normal. So they had compressed and stopped the massive amount of flow in this woman, and so just with conservative management and balloon compression, she actually retained her uterus and everything was fine. So AV fistulas versus retained products. Don't overcall AV fistulas because the results can be disastrous. AV fistulas should have large myometrial holes, but not always. And there's a large overlap between AV fistulas and retained products of conception. Here is a patient 5 weeks postpartum, had heavy bleeding and clots. Again, is this retained product or AV fistula? She decided just simply to leave home, to leave the hospital. She did have some increased vascularity, but we're seeing a lot of things that it's not absolutely always clear. She had an area of increased vascularity, she left, and she came back fine. So was this retained product, or was this just simply, could this have been an AV fistula? Now here's an area that's much more concerned. In large uterus, thickened myometrium, a bunch of holes in a woman who has a high beta HCG. High beta HCG. So now we're not thinking of retained products, but what we should be thinking of, hydatidiform mole. And here, when you look at the vascularity, it's low vascularity. So high beta HCG, low vascularity, we're thinking now hydatidiform mole, and that's in fact what it was. You look at this and it looks, well, there's a mass and increased vascularity in a woman who had a therapeutic abortion 6 weeks ago, has been bleeding for 6 weeks, has a positive beta. I might just simply have called this retained products had it not been for the positive beta. But remember, the beta can continue to be positive after delivery and gradually dropping. Hers was not dropping. The mass, the low velocity flow, she actually also had an invasive mole. It looks different than the previous case. So again, there's a wide variety of these. Trophoblastic invasion of the myometrium. What's the significance? May need surgery, but can resolve spontaneously. A woman with bleeding 6 weeks post-spontaneous vaginal delivery, manual removal of the placenta. You look and you see a big mass there. You have to look closely because the mass seems to extend into the myometrium. And when you look closely, there it is going almost to the serosal surface. So the question is this retained products? But more importantly, is there an area of placenta increta? When you look back at the 7-week scan, you can see that the placenta was extending right into the myometrium. She has an area of placenta increta. She had had enough pregnancies. They were quite concerned about her, and they decided to do a hysterectomy. Here's the unbisected uterus, and here you can see the bisected uterus with that trophoblast extending right out to the serosal surface. So this was a mass of invasive trophoblastic tissue. Obviously, a hysterectomy was the correct case, was the correct treatment in this case. Another patient, early pregnancy failure, 29 weeks, untreated, myometrial invasion. So here we look at this case and we see the non-gravid uterus. Here then she gets pregnant. It looks not too bad. You can see the gestational sac. She's had some bleeding at 8 weeks. She doesn't want a D&C, so we're managing it expectantly. Normal placental implantation site anteriorly. We keep following her now a week later, and she has a prominent vessel extending right into the myometrium, and you can see it on 3D. Prominent vascularity in the anterior myometrium. So what is this? Is this retained products? And she has, again, high velocity flow. And is there anything we need to do about it? Well, if you look again at the 2D, you can see this heterogeneous trophoblasts extending into the myometrium. Does this patient need a hysterectomy? This was 1 week apart. She has persistent trophoblasts with increased vascularity, but she's clinically well. So what to do next? Do you monitor her beta? We should monitor her beta. Do you do a D&C? Or do you give methotrexate? Well, they decided to give methotrexate, and a week later, everything is cleared up. So sometimes, and here it looks quite normal, so sometimes just simply watching, we're seeing a lot of things that we weren't seeing before because of the improved equipment, but do you always have to treat the things that you're seeing? A patient who has 10 weeks, early pregnancy failure, an empty gestational sac, and you look at the endometrial canal, and extending into the myometrium is an area of increased echogenicity. It looks like myometrial invasion. There's some increased vascularity in that region. What should you do? Is this molar invasion? Is this trophoblastic invasion? There was some high velocity flow. She's only spotting, so what do you do? Well, this patient, they just simply, again, they treated conservatively and she resolved. At 16 weeks pregnant, this woman has had bleeding for 2 months and finally just came to see a doctor. She has these big holes in the endometrium or myometrium, very, very confusing, and has some high velocity flow. We brought her back a day later because or 2 days later, I wasn't exactly sure what was going on. Sorry, 3 days later. And she had passed whatever it was. And I said, well, it must have been a mole. Did you pass a bunch of grapes? She said, no. She said, I passed a collapsed fetus. So this whole area that is quite distorted, maybe that was the head and the body, I don't know, but this was actually a collapsed fetus. Finally, here you have a patient, again, a similar situation. She had some interventional procedure. Now she's got this big mass in the endometrial canal, but it's avascular. Remember, an avascular mass can simply be a hematoma. She was pregnant earlier, she had a small embryo, she had a therapeutic abortion, and now she has a hematometra. No mass, and in fact, depending on her clinical situation, you may do a D&C. Another patient with a clot, avascular clot in the endometrial canal, mixed echogenicity, hematometra, or a blood clot, rather than retained products. And the only way you're going to know is by looking at vascularity. So late postpartum bleeding, first of all, it requires a good history. Is this continuous versus stop and start bleeding? Is the uterus tender? The only way you're going to know about uterine tenderness is talk to the patient. When you're scanning with an endovaginal probe and you're touching the uterus, You've got to ask the question, does that hurt? Is the uterus tender? Endovaginal ultrasound is absolutely critical. And remember, use color and use spectral. So examine the uterus, push on it, ask if it's tender, use color always to see if there's increased vascularity, and use spectral to see whether or not this is high velocity flow. Thank you very much. I hope that this talk has been useful for you.
My name is Dr. Mindy Haro. I'm a radiologist actually in charge of ultrasound in the vascular lab at the Albert Einstein Medical Center in Philadelphia, Pennsylvania. This lecture is entitled Pitfalls in Gynecologic Ultrasound. I have no disclosures. Before I actually get into a discussion of pitfalls and problems, I'd like to talk a little bit about how we do our pelvic ultrasound at Albert Einstein Medical Center. For several years now, we no longer require women to arrive at the department with a distended urinary bladder. If they have never had any prior pelvic imaging, either ultrasound or otherwise, we always take a brief transabdominal look. Then we make a decision about whether this patient will be better to do transabdominally or transvaginally, and occasionally a combination of both is required. The vast majority of women only have a transvaginal imaging study. Occasionally we have to wait for the bladder to fill. This, of course, makes the patients more comfortable, it helps the throughput in the department, and there are fewer people running back and forth to the bathroom. The outline of my talk is as follows. First, I'm going to talk about the uterus and particularly unusual manifestations of some of the more common entities. Then there will be some miscellaneous topics, and then I will talk about post-surgical issues, not acute post-surgical, but more chronic issues, particularly those related to cesarean section. I will also then go on to a discussion of the adnexa of a variety of tubes, and those tubes may be fallopian tubes as well as other tubular structures, vessels, bowel, and otherwise. And the last topic will be ovaries. In this group, I will discuss ovaries that do not have any particular focal mass or unusual cystic structure, but either are too large or too small and therefore are abnormal for the patient. I will also show you some atypical appearances, again, of common abnormalities, and then I'll include some of our actual M&M cases. So as far as the uterus goes, there are fibroids, there's adenomyosis, and then we'll discuss some miscellaneous topics. Most of the vast majority of fibroids are obvious and easy to deal with and easy to diagnose, but every now and then some unusual cases come across. And many of these are taken from our recorded problem cases, either problems for the technologists, a resident at night, or one of the staff. These are the initial transabdominal measurements of the uterus. And the question I would pose to you is, do you think these are correct? That this is a nice sagittal view of an enlarged uterus and a transverse view? Actually, upon further transvaginal imaging, we found a fairly normal-looking body of the uterus and then could see the edge of what appeared to be a very large myoma that was not easily imaged completely on ultrasound, on transvaginal imaging. So we went back to the transabdominal and were able to find that normal piece of uterus with the endometrium, and actually this uterus just has one very large exophytic myoma rather than a diffusely myomatous uterus. And that's a particularly important thing in terms of therapy for this patient. So sometimes a single exophytic myoma may make one think that the entire uterus is enlarged when actually there's a normal body of the uterus there. Every now and then this issue arises. Is this solid adnexal appearing mass actually part of the uterus, or is it adnexal? And one of the things that we found very useful is to use color Doppler and look for bridging vessels. These type of bridging vessels would indicate that this is a subserosal myoma. Here's another one. Is this an enlarged diffusely myomatous or adenomatous uterus? This is transabdominal with bladder and uterus, and these were the measurements that were given to us on the transabdominal study. Actually, this was a large patient and difficult to image, but upon pressing a bit more on the transabdominally, we could find that this little structure here was the main body of the uterus. This was a sagittal view towards the left, and we could see the endometrium. And once again, there was one large single myoma. Here's an unusual manifestation of a common disease. There's a lobulated cystic structure along the right side of the uterus. And most of the time, cystic structures are adnexal and solid masses are uterine. However, we were able to find the right ovary in this patient, and this structure, therefore, might be related to the uterus. This is transabdominal and transvaginal. In this case, it was opted to obtain an MR, which confirmed our suspicion on ultrasound that this was actually a cystic myoma. This is the claw sign. In other words, this cyst arises from the uterus because of the little claw sign around it, which you can actually appreciate on sonography. Here's an unusual case. These are the initial images presented, and the question was, is this the endometrium in this uterus, and is it extremely thick, even for a premenopausal patient? So in this case, we definitely went transvaginally in this patient, and lo and behold, the endometrial cavity was slightly expanded with some complex fluid and possibly a small myoma, but this large echogenic area was not the endometrium. This patient also went on to an MR for problem solving, and here is a high intensity lesion as well on T2, and with fat saturation it decreased in enhancement, and this is a lipoleiomyoma. So I've now showed you some atypical appearances of fibroids, and fibroids are common, but every now and then there will be an atypical appearance. The cystic ones are usually due to degeneration of a myoma outgrowing its blood supply, and when it degenerates it can liquefy and become cystic. Obviously calcification can occur, and that's much more common. Lipoleiomyomas are very rare smooth muscle tumor myomas that have fatty change inside. Here's a not uncommon, but sometimes underdiagnosed or potentially overdiagnosed issue. This is a 64-year-old woman, and as you notice, there are some chunky calcifications in this uterus, and one might be quick to make the diagnosis of calcified myoma. However, if you look a little bit more carefully, these calcifications line up around the periphery of the uterus, and what this represents is something called Monkeyberg sclerosis, or just generally atherosclerosis, which clearly is a diffuse problem in the body, but can occur in the peripheral vessels in the uterus. On this CT scan, you can see the same effect here of calcifications peripherally. It's more common and accelerated in diabetics and those with chronic kidney disease, and should not be mistaken for a myoma. So moving along to other issues in the uterus, here is the initial sagittal view transabdominally of the uterus, and the question was, is this a myoma? The person doing the scan, the technologist, measured it as a myoma. But a little bit more careful scanning and using color Doppler obtained a different diagnosis. You notice with the color Doppler, there are linear areas of vascularity that penetrate this area rather than the ring-like vascularity so typical of a myoma. And further imaging shows that in the sagittal view, the endometrium is here in the uterus. The posterior myometrium is much thicker than the anterior myometrium, and there are some tiny little cystic areas. Mostly this is increased in echogenicity. It doesn't cause significant attenuation of the sound beam, and this represents focal adenomyosis, which every now and then can be misinterpreted for a fibroid, but certainly has different issues for the patient. Here's a patient, sagittal and transverse views transvaginally of the uterus, and this study was interpreted for the patient as having a small polyp in the endometrial cavity. But if you look a little bit more carefully, you notice that there really are no borders of this structure. There are these pencil-thin shadows coming out. It is echogenic, and then there are some tiny cystic spaces. The problem solver here, again, was MR, which showed a markedly thickened junctional zone and diffuse adenomyosis, which in this case simulated a possible polyp, but there was no polyp. Here's another cause of an enlarged, so-called enlarged uterus. This is the sagittal view of the uterus. It looks fairly normal. On transverse, it's up to almost 6 centimeters, and it sort of looks like a wide area of endometrium. There was no focal abnormality, but overall the measurements were enlarged. And we did a reconstruction in this patient, and you can see that this is actually an anomaly, a septate uterus, and often these types of anomalies can result in a larger uterus. Here's a problem that arises every now and then, and here's a tip for how to get around it. This patient was a 90-year-old with postmenopausal bleeding, and I would say in really elderly patients, this is often the most common reason we're asked to scan. As happens sometimes, she was incontinent and had had a hip fracture that she was recovering from. And those factors made it very difficult to image her. We looked initially transabdominally as she came to us. She only had a small amount of urine in the bladder, and the question was whether she actually even had a uterus, and she was unable to tell us that. So we couldn't fill her bladder. We could not scan her transvaginally because of her other issues, and we have found that in these patients, the best thing to do is a transrectal study. It may seem counterintuitive, or it may seem odd to do this, but actually for imaging the uterus, particularly the endometrium, this is an excellent way to scan. These images are flipped, and here's the probe in the rectum, and you can very nicely see the cervix and the body of the uterus in sagittal, and this is more or less of a coronal view. You don't have quite as much leeway by imaging in the rectum, and it's unlikely that you'll be able to image the adnexa. But for the specific purpose of evaluating the endometrium, this is a very good way to image. You can see that there is a little bit of fluid in her endocervical and endometrial canal, but the actual endometrium was normal in thickness, and the problem was solved. And I should also add, this is actually quite easily tolerated and not difficult to do. Now we'll turn to post-surgical imaging and how this affects the uterus in terms of diagnoses, as well as particular problems that may arise in this patient population that you need to be aware of. This patient gave us a history of having had a hysterectomy. We were initially imaging transabdominally. She had a fairly well-filled bladder, and we noticed a solid-looking structure behind the bladder. This is it in transverse with a little bit of a cyst in it. We went on to image transvaginally, and this clearly is the appearance of a perfectly normal cervix with Nabothian cysts. And so this patient had a supracervical hysterectomy. Every now and then you'll find the cervix that's left behind, and the patient may not realize it. This patient gave us a history also of a hysterectomy, and here's the initial transvaginal imaging, and the interpretation of the sonographer who came out was that she thought that there was some piece of uterus left behind, or that there was some sort of complex solid mass with cystic components. Upon further imaging, it turned out that these were actually the ovaries, the left ovary and the right ovary, and that they had fallen down together near each other in the cul-de-sac and were touching each other here and making it seem as if there was one mass. So they were perfectly normal ovaries, no uterus. Now we'll turn to the patient who's had a cesarean section. As you may know, or depends on where you work and live, but in our country, there's been an amazing rise in the number of cesarean sections over the last 10 to 20 years. And so many patients come to us having had one or more cesarean sections. And the kinds of problems that arise from this for us have made it so that this is one of the specific questions that we ask patients before we begin imaging them. If you just ask if the patient's ever had any pelvic surgery, she may not feel that this is pelvic surgery and might not mention it. But knowing that there has been a cesarean section may lead one to image in a variety of different ways and expect certain things. So here's a typical patient who's had a cesarean section. We initially look transabdominally, and there's a very odd shape and contour to the uterus. So in the sagittal view, head here, feet here, this is the urinary bladder, vagina. You notice the cervix, and it appears relatively elongated. And then if you follow the uterus up to here, it's tethered and pulled right over here. This is the transverse view through the same level. And this is actually where the cesarean section scar is, and it pulls the uterus up, and it's stuck there. And the problem is that if you continue to fill the bladder, it will just push this up further and further. The bladder will never serve as a good sonographic window for the uterus. The other problem is that transvaginal imaging is often limited in these patients. I've taken a sagittal reconstruction of the pelvis from a CT scan in a patient who's had a prior cesarean section and placed next to it a drawing of what it would be like if we tried to do a transvaginal study on this patient. So here's the urinary bladder. This is the fundus of the uterus, and the tethering and scarring is right about at this level. This is the main body of the uterus, and you can see that the cervix is pulled and elongated because the uterus is tethered here. So if you put the probe in the vagina, which would be about here, and you image, you'll get an absolutely wonderful view of the cervix. And it will be so elongated that some people think that's just the uterus. And you may never really be able to image the body of the uterus, which is up here. Here's another patient, and I'm going to show you the ultrasound views and the CT views so that you can appreciate this. Here's transabdominal. This is the bladder. Here's the elongated cervix with the tethering right here. And here's the body of the uterus. In transverse on a CT scan, this is the uterus, and here's that pulled up tethered portion. Oftentimes the ovaries are also pulled up out of the pelvis as well in this situation, also making it difficult to image. This is the sagittal reconstruction, and this scar is so prominent you can actually see the adhesion to the anterior abdominal wall. If I flip this image vertically, essentially you will obtain what we have when we image transvaginally. So here's the patient transvaginally, a lovely view of the cervix. Here's the cervix. And the body and fundus of the uterus are far from the transducer. Here they are here. And oftentimes we just cannot penetrate far enough with a transvaginal probe. So what to do? Well, it's a problem. The scarring can cause significant distortion of the normal position. The cervix is elongated. There's poor visualization of the body of the uterus. And additionally, transabdominal imaging can be very limited, and there's a poor sonographic window. So our recommendation is, if the patient body habitus permits, to actually try a higher frequency curved transabdominal transducer directly over the uterus without using the bladder as a window, and you may actually be able to image the uterus. Every now and then, sonography will fail in some of these patients, and other imaging will be needed. Here's a patient on transvaginal imaging, also a history of a cesarean section, and the person imaging was questioning this region as a myoma. And you can see it here and here. Does this patient have a myoma? This is actually a cesarean section scar simulating a myoma. The scar is right here, and there will be some fibrous tissue, and sometimes you get this sense that there is actually a myoma there, when if you look carefully, this is isoechoic with the normal myometrium. Is there focal endometrial thickening in this patient with a cesarean section history? You can see right here, there's sort of a bump up of the endometrium. And what this represents, this is it in transverse, is the scar with pulling and tethering of the endometrium in towards the scar. These two patients give a history of intermenstrual spotting. This is an important history to obtain from the patient, as well as knowing that both of these patients had prior cesarean sections. In this patient here, you can see a little bit of fluid in the endocervical canal, some complex fluid, and the fluid tracks into the place where the cesarean section scar is. This second patient had an even larger collection of complex fluid in the cesarean section scar, and you can understand why a patient like this might have spotting in between menses. This place is called in the literature by people who have written upon it a niche or reservoir for blood. This patient came to us with a history of heavy menses and also some intermenstrual bleeding. When we did her imaging, we were pretty confident that there was a large myoma centrally, which we thought was submucosal or even intracavitary, and her physician asked that we do a sonohysterogram. Upon installation of the fluid, we outlined the myoma and confirmed its location. In addition, the fluid outlined the little niche or the scar from the cesarean section and filled it. And you can actually see how thin the myometrium is at this point. So you can see these little niches or reservoirs on sonohysterography. Other complications can obtain in such patients. This patient, who had one prior cesarean section, came to us with an early pregnancy and bleeding. These images were interpreted by the physician doing the study with the sonographer as an abortion in progress. Here's the gestational sac low in the uterus. The patient passed the sac and the bleeding stopped. Unfortunately, she returned 1 month later with recurrent bleeding. These are the images we obtained transabdominally at this point. The sac was gone, but there was some echogenic material at the same location. And when we turned on the color Doppler, it was exuberantly vascular, and it had low resistance flow, typical of trophoblast. So what this patient actually had was a pregnancy that had implanted at the cesarean section scar site, an ectopic pregnancy. She had actually passed it, but had retained products of conception at the site of the cesarean section scar. So in summary, this cesarean scar, pouch, or niche can be filled with fluid during regular scanning or fill with sonohysterography. It can be visualized on hysteroscopy and can fill during hysterosalpingography. It can serve as a reservoir for blood and be a cause of abnormal bleeding. What percentage of women who have had a prior cesarean section will actually demonstrate such a niche is really unknown. Here's another issue that can happen related to the cesarean section. This patient came with a request to check for the location of her IUD. On the transvaginal image, most of the IUD is actually in the endocervical canal, and a portion of it is right here. Further transabdominal scanning, again, shows a portion of the IUD right here, and there was no IUD further along in the endometrial cavity. This was the most distal aspect of it right here, and you can actually see that that's where the cesarean section scar was. We went back and looked through this patient's records and found that she had actually, interestingly enough, had a CT scan right after her cesarean section related to bleeding or a fever, and it allows you to see where the scar was in the myometrium right here. A year later, she had a CT scan for other reasons, and she had the IUD, and what wasn't noted was that the IUD was actually malpositioned. Here you can see one of the arms of the IUD exactly at the location of the cesarean section scar, and a reconstruction shows that the IUD was not really sitting well seated in the endometrial cavity, but had gotten stuck, we believe, in the scar and had to be removed. Next, we'll move on to the issue of tubular structures in the pelvis, or as I call it, beyond the uterus and ovaries. So the first pitfall here is that some people are very somewhat short-sighted and figure that if they see the uterus and they see the ovaries, they're done. Unfortunately, or fortunately, it's not so simple as that. And so we'll turn our attention to the fallopian tubes. The most common teaching is that unless the fallopian tubes are abnormal, we do not see them. But I would argue that actually you can see portions of the fallopian tubes, not infrequently. To review the anatomy of the fallopian tube, the fimbriated end and the ampulla are the thickest portions of the normal tube, and that's the part that you may be able to see. It's often more easily seen when the patients have some free fluid in the pelvis for whatever reason. This patient has a fair amount of fluid. It's a little bit complex, but you can see it outlines nicely the fallopian tube, and you can just match it up on the diagram. This is the thicker fimbriated end, and this is the normal fallopian tube. Notice the approximate thickness and appearance of it, and Then I direct your attention to this patient who has no fluid in the pelvis, but you can still find the fallopian tube. This is more easily done when you're scanning transvaginally to stop pushing too much on the ovary and just lighten up the touch a little bit and go right near it, and you should find it. This is the uterus in transverse, this is the left ovary, and between the two is this little echogenic structure, which I would argue is a portion of the fallopian tube, probably the ampullary portion, and this is what a normal tube, if you see any of it, would look like. The problem with seeing it, as you can tell, is that it's fairly isoechoic with myometrium and often with the adjacent fat. These are two patients with the same diagnosis, and it's related to the fallopian tube. Both of them happen to have some free fluid, and that is allowing us to see this diagnosis. Here's the fallopian tube in this patient. This is it in transverse, and there's a little cyst right at the end of the fallopian tube. This is the fimbriated end, and it's sitting in there, hugged by the fimbria. Here's another patient, a similar situation. Here is the tube with a tiny little cyst at the end of it. These are paratubal cysts, also known by their fancier name, hydatids of Morgagni, and these are normal fallopian tubes. Not infrequently, we only see the cyst and we don't really appreciate the fallopian tube, but I would argue that if you find one of these, you should look, and you might actually be able to appreciate that it's coming out of and related to the fallopian tube. These are innocuous findings. On the other hand, the fallopian tubes clearly can become abnormal and should be appreciated as such when that happens. These are two patients with pelvic inflammatory disease, and in these situations, the tubes are very thick-walled, there are fluid debris levels. These little things, in a transverse view of the tube, you see these characteristic little echogenic prongs or little projections into the tube. You can see them here as well. And these are the thick endosalpingeal folds. These are fallopian tubes in acute pelvic inflammatory disease. This patient also has an abnormal tube. She has a history of endometriosis, and here's the tube filled with some low-level echoes, which were blood. And notice, if you will, the sort of indentations on either side diametrically opposed. This is the so-called incomplete waist sign, which has been described as a quite specific finding for a dilated fallopian tube. You can see the tube sitting on top of the ovary. This patient was sent to us for evaluation of a cystic tumor discovered on an outside ultrasound study. And this is one of the images that she brought with her. It looks like a cystic lesion, presumably in the ovary, they thought, with some septations. Further imaging, however, shows that this actually is a structure that's curled back on itself. It has an incomplete septum, and we actually were able to find the ovary next to it. This represents a chronic hydrosalpinx and shows the incomplete septum sign. This is not a cystic tumor. It doesn't need follow-up. It can be left alone, and the patient can be reassured. So, as far as dilated fallopian tubes go, the best markers for dilatation is the waist sign, or the small round projections into the tube. The incomplete septum sign can be useful, but is felt to be less discriminating. If the tube is thick-walled and shows a cogwheel sign, that is typically acute disease, whereas a thin wall and tiny little beads on a string are from chronic disease. And these are some diagrams from an article by Timur Trish illustrating the cogwheel sign, the thick wall with the projections. Here's a thinner wall with tiny little projections. And this is the dilated tube curled back on itself with the waist sign or incomplete septum. Now, there are foolers of fallopian tubes, and these are some of the pitfalls that you need to be careful about. This patient came to us with a history of pelvic pain, and the diagnosis was made on this study of PID with a dilated infected fallopian tube. This is the measurement of the structure they were calling the fallopian tube. You can see low-level echoes. They turned on the color and saw some flow in the wall, which is not uncommon in an acute pelvic inflammatory disease. However, the clinical findings did not seem to coincide with this diagnosis, but nonetheless, she was treated with a course of antibiotics and returned for further imaging. Here's further imaging of what the tubular structure looked like at this point. Again, it looked lobulated and tubular. It had a fluid, low-level echoes, But this time we looked with color Doppler and made the imaging more sensitive. You can see from the numbers here. And lo and behold, we could see flow coming in and out of plane through this entire structure. And what this actually represents are dilated veins or varices in the pelvis, and they have often very slow flow, and as a result can have internal echoes. Demonstrating flow in color Doppler will require very sensitive settings, and occasionally the flow is so slow it won't show up in color Doppler, but you'll actually see the little low-level echoes floating by. Now, distinguishing these from fallopian tubes is clearly important, but also they can have significance in and of themselves. This patient came to us with a history of chronic pelvic pain. She actually, when we reviewed her folder, had multiple sonographic exams and multiple CT exams, all of which had been read as negative. When you look, however, this is not so negative. In her left adnexal region, she had numerous dilated veins. These are all varices. And if you look carefully in the grayscale of these images, these veins in the adnexa connect into the veins in the uterus. You can see she has fairly dilated veins all in the periphery of the uterus connecting out. This is one of the many CT scans that she had. You can see that at the level of the aorta and inferior vena cava at the renal level, she had a dilated right ovarian vein, and you can track it down to the pelvis. These are all the dilated varices on this side, predominantly on the left side, some on the right side. And this patient went on, because of her symptoms, to have an IR study. This is an image of the veins in the pelvis with the catheter in place. And this patient, we confirmed the diagnosis of something called pelvic congestion syndrome, which we treated by embolization of the varices. Pelvic congestion syndrome is a frequently or often underdiagnosed study. Many gynecologists don't really even know that much about it. These are pelvic varices that develop because of incompetent valves and are typically related to multiparity or prior surgery. The symptoms are those of a dull, heavy, aching pain that may exacerbate with standing and can be unilateral or bilateral. Upon clinical examination, the uterus tends to be bulky and tender because of all of those dilated veins in the periphery. There may actually be visible varicose veins in the vulvar region and buttocks and legs, and the ovaries may be slightly large and cystic appearing as well. Imaging will show dilated veins and dilated arcuate veins in the uterus. This can be thought of as analogous to a scrotal varicocele and is typically more on the left than the right side. There are other causes of abnormal tubes in the pelvis, and this is one in this patient. She had right-sided pelvic pain and initially, again, was called as having a pyosalpinx. This is the dilated tube that she has in the pelvis. However, if you look a little more carefully, you can see that this is the ovary with a dominant follicle, and right next to it is, as I showed you in those other ones, a portion of her normal fallopian tube. The structure that was called a pyosalpinx actually has a gut signature. There's fluid, and here you can see the layers of hypoechoic, and a very thick submucosal layer in this patient. So not surprisingly, this is a loop of abnormal bowel in the right lower quadrant. This is the ovary, and this is the normal fallopian tube. The patient also had a CT scan, and you can see the very abnormal loop of bowel here. And so this patient had a diagnosis of Crohn's disease. This patient came with right pelvic pain, and this is the normal right ovary. The clinicians wanted us to look for the possibility of torsion, and there was no torsion. The ovary was completely normal in size and appearance and had flow. Next to it is this little round structure, which is tubular, and you might wonder if this is a normal fallopian tube. However, a little bit more careful view, if you see, there are alternating bright, dark layers typical of bowel. This is color Doppler, and you can see prominent flow in this structure, which actually represents the appendix, and this patient had acute appendicitis, which can in some cases be diagnosed transvaginally. This 16-year-old came with left pelvic pain, and this is the kind of patient that we would have arrive with a full bladder. This is the lower uterus behind the bladder, and the uterus and ovaries were fine. We noticed this little bright echo here with a small shadow. And we did color Doppler. This patient had several cups of water to drink, and she had frequent jets of urine from the right ureteral orifice and none from the left ureteral orifice, which is where this small echogenic calcification was located. So we went up and looked at her left kidney. This is the lower pole, and you can see the dilated ureter coming out of it. So another tubular structure in the pelvis to think about is dilated ureter. The last topic to turn to are abnormalities of the ovaries, and we're going to look at two major categories: ovaries that do not have any particular abnormality but are either too large or too small for this type of patient, and then we'll look at some cases of masses. This is a newborn girl who was sent for ultrasound because of a palpable right lower quadrant mass, and this mass actually corresponded to the right ovary. This is the appearance of the left ovary, and both of them have multiple small cysts in them and are slightly larger than usual. This is the typical newborn uterus. This is actually not an unusual finding to have large ovaries with multiple cysts, and these are secondary to maternal stimulation. They can be found not infrequently in newborn girls, and the best thing is to have conservative management if the ovaries are less than 4 to 5 centimeters. Occasionally, cysts can be aspirated if they're bigger, but these are, again, don't touch kinds of things. This 16-year-old came with a history of amenorrhea, of primary amenorrhea for evaluation. In this young woman, we saw the uterus, which had an unusual configuration for someone 16 years old. It was a much more juvenile appearing uterus. This is a transvaginal view, which we were able to do. And we did find ovaries. This was the right ovary. This is the left ovary, and they were quite small. None of the measurements were greater than a few millimeters, and there were absolutely no follicles. So these represent ovaries that are too small. There's nothing abnormal in them focally, but considerably too small. And this patient turned out to have a mosaic form of Turner syndrome, which is not an infrequent karyotype that can have the presentation of primary amenorrhea. And many of these patients, you can't see any ovaries, but about a certain percentage of them, particularly those with a variety of mosaicism, will have small ovaries. Here's another patient coming as part of an infertility workup. She, however, is 35 years old. The uterus looked fine, and this is the appearance of the ovaries. This is the right ovary, and this is the left ovary. And one might be inclined to say the ovaries look fine. The problem is that they're rather small for a 35-year-old, and there are really no follicles in them at all. These would be fine if the patient was 65, but they're not fine if she's 35. So again, small ovaries, no real follicles, and this patient turned out to have premature ovarian failure, which can be a cause of either primary or secondary amenorrhea. About half the cases are idiopathic, and there are two sonographic groups, those with small ovaries without follicles and those with fairly normal-sized ovaries with inappropriate maturation of the follicles. The mean volume of these ovaries are similar to postmenopausal patients. This 75-year-old patient came for evaluation in the pelvis because of a malignant pleural effusion. She presented, and the thing that was found initially was this effusion. She had no other particular complaints in the abdomen or pelvis. This is her normal left ovary. There was one tiny little cyst in it, but it was normal sized. And this is her right ovary, measured 2.1 by 3.5 by 1.6. Not huge, but too large for a 75-year-old and out of proportion to the left ovary. We were able to find a little bit of flow, but that didn't particularly help one way or the other. We did notice that there was some adjacent complex free fluid. And it turned out, so therefore, this is a larger than normal right ovary without any focal mass that we were able to appreciate. And not surprisingly, this patient had primary ovarian carcinoma, which had presented already with metastases to the pleura. As you know, pelvic sonography is not really a screening tool for the larger population for ovarian carcinoma, but probably is more important for those who are at increased risk. And I show you this example because you would otherwise think it was just a slightly large ovary, but actually there was a tumor. This 60-year-old came to us with a history of breast carcinoma. This is a transabdominal view of her uterus, and you notice that the ovaries are large. They're about the same size as the uterus. Again, there's nothing focal in them that we could see, but they were just too large. We imaged a little bit further, and we found multiple small lesions in the liver, a mass in the right adrenal gland, multiple lesions in her spleen. So these are large ovaries in the setting of metastases elsewhere, and these are metastases to the ovaries. Metastatic disease to the ovaries is not that uncommon. It can be difficult to distinguish from primary ovarian malignancy, but often studies suggest that the metastases are relatively more solid than primary ovarian neoplasms. They can be bilateral or unilateral. The most common tumors are colorectal or breast, though endometrium, stomach, and lymphoma are also possibilities. This 25-year-old had irregular menses and came for infertility evaluation, and this is another example of very large ovaries. The volumes of these ovaries are significantly large, 42.6 ml, 36.3 ml, and you would be tempted to say they otherwise look all right. There are no cysts in them, and so you might not want to consider the diagnosis of polycystic ovarian disease. But if you look very carefully, the cysts in this case are just quite tiny, but here they are lined up around the periphery of the ovaries. So these are very large ovaries. There are tiny peripheral follicles, and this is polycystic ovarian syndrome, which I won't go into all of that much, but sometimes they can be relatively solid with few obvious cysts. This patient came with acute left pelvic pain, and this is what her left ovary looks like. It was absolutely huge. And though there's no focal abnormality, you would certainly argue that there are areas of abnormal echogenicity, increased echogenicity here and here. And so not surprisingly, and most people would think, as did the person scanning, the sonographer, that this patient likely had ovarian torsion. There were few foci of flow, and we were able to get a little bit of low-level flow. These are the images that were initially presented. And you notice the time, this was at 1:43. Upon re-imaging, however, a little more than a quarter of an hour later, there was significant exuberant flow, much more flow in the ovary, relatively high velocities, and very low resistance. So this is a large ovary. Ovarian torsion is the diagnosis, but it's a torsion and detorsion that was going on here. So not that you should be led into a pitfall of thinking everything was actually all right, because there was flow. So for ovarian torsion, the most important finding is the enlarged ovary, which might be in an unusual location. The echogenic areas are probably secondary to hemorrhage, and there can be an underlying mass. Flow is not necessarily the key finding. You may find flow. Do not be dissuaded by finding flow. And the last group of cases are some M&M cases, and several of these are actually very large masses which can be easily missed or mistaken. These are the initial images brought by the sonographer on this patient, and who was thought to have a very large uterus. And it was unclear to the sonographer if this was a fibroid uterus or this was adenomyosis. And you can see the measurements sagittally and transversely with the labels that they were presented. Further imaging, the bladder actually filled a little bit, revealed that this is probably the main body of the uterus, and there was a very large hypoechoic mass. We tried transvaginal imaging, saw the uterus, and it was hard to tell if this mass was arising from the uterus or was separate from it. MR is the best study for problem solving, and this was what we had suggested. This turned out to be a very large, solid mass, quite separate from the uterus right here. And this was a large ovarian fibroma. And these are the ones that may sometimes be difficult to distinguish from an exophytic myoma. This study was also came into our M&M pile. It was initially interpreted as a normal transabdominal study. Here's the uterus in transverse, here's the uterus in sagittal, and this is the urinary bladder. However, this urinary bladder seemed awfully round, and if you look carefully, you can see a little echogenic line that you might think was some odd septation or debris. Further imaging showed that actually this is the bladder, and this is a very large ovarian cyst which was compressing an almost empty bladder. So once in a while, a large cyst, empty bladder, and the two can be mistaken. This was a novice sonographer, somebody who was very new, and she brought these images, and they are labeled as they were submitted to us. This was thought to be a transverse view of the uterus, though it was unclear where the border of the uterus was. This image was labeled left ovary, which it was, with a follicle, and this was labeled right ovary. If you look a little more carefully here, you'll notice that this is the aorta and this is the inferior vena cava, and this structure doesn't really look like an ovary and doesn't have any follicles. In addition, we were looking at this area here where we couldn't see the border of the uterus, and was there something on the right side that was kind of echogenic? MR imaging was done in this patient, and you can see the echogenic mass in the right adnexa is actually a classic dermoid. And here is some further transvaginal imaging of it. This is a blown-up image of what was labeled initially as the right ovary. And what it actually represents is the intervertebral disc. This was a thin patient, and sometimes as you scan through, you can get vertebral body with the shadowing from the bone. And then if you happen to image right where the disc space is, you can see it as a round hypoechoic structure. And so she couldn't find the right ovary in the pelvis and just went up higher and higher until there was something that seemed to be the right size and shape, and labeled that the right ovary. So the masses that are actually the most common, amongst the most common to miss, are large dermoids that do not have any classic cystic component. Here's another one. This was initially thought to be a fairly normal pelvic ultrasound, bladder, uterus, and this was interpreted as bowel gas above the uterus. And the clinicians felt something, and actually there's a huge dermoid sitting here above the uterus. This is not bowel gas. Here's another one. Is this an adnexal mass? And what actually does it even measure? The borders are so indistinct in this situation. And again, this was another very fatty dermoid. So sometimes they can blend in to the fat everywhere around them. And just to remind you that the fat components, that the CT and the ultrasound can somewhat be a little seemingly discrepant. This looks more fluidy to us, and this is shadowing. On CT, this is fat in a liquid state in the body, which is warm, and this is also a little ball of fat, but with an echogenic rind around it and shadowing, and we can't not appreciate the fat inside. The last case that I'll show you is this one, interpreted initially as a cystic adnexal mass on the right with solid components and cystic septated components. And actually, upon further imaging, you can see that these are both ovaries. This is an ovary with follicles. These are both ovaries sort of tethered together in the cul-de-sac with cystic areas and septi around them, connecting them. There happened to be a corpus luteum in the right ovary, and this is a classic peritoneal inclusion cyst. These are not actually true cysts, but there's fluid trapped in adhesions around the ovary. Usually these patients have a history of prior abdominal or pelvic surgery or trauma or endometriosis, and these should not be diagnosed as a tumor. So, in summary, this is our advice based on a varieties of mistakes and problems that we've encountered. Be familiar with uncommon variations of common entities, because those will be the things you'll see more frequently, such as cystic or fat-containing myomata. Consider ovarian size either too small or too large as a diagnosis, even if there is no focal abnormality. Always ask the patient if she's had a cesarean section, and be prepared to understand the appearance of the scar and its associated abnormalities. Remember, there is more to the pelvis than the uterus and ovaries, and you may often make very significant diagnoses related to bowel, fallopian tubes, ureters, and even the bladder. Recognize the issues related to large abnormalities such as cysts and dermoids that may extend out of the pelvis, and always appreciate the limitations of pelvic ultrasound. And if things just do not make sense or cannot be completely evaluated, suggest another study, which in our situation it is usually MR. Thank you.
I'm Dr. Peter Duboulay. I'm professor of radiology at the Brigham and Women's Hospital and Harvard Medical School, and I'll be speaking today on mistakes to avoid in first trimester ultrasound. In this lecture, I'll be talking about a variety of mistakes to avoid in first trimester ultrasound. The kinds of mistakes that I'll be talking about are ones that if you do make them, they could have potentially very serious consequences either to the pregnancy or to the mother. The first mistake that I'll talk about is misdiagnosis of a gestational sac as a pseudogestational sac. The kind of mistake that I'll be talking about is the following statement, incorrect statement that might be made in a particular case. The patient has a beta HCG of 1,200 milli-international units per ml, and ultrasound shows a non-specific intrauterine fluid collection, one that has no visible embryo yolk sac, no double sac sign, no intradecidual sign. Since there are no sonographic features of a gestational sac, the fluid collection is likely to be a pseudogestational sac, and the patient should be treated for ectopic pregnancy. This would be a mistake, as I'll discuss over the next several slides. Here are some examples of that mistake before I talk about how to avoid it. And this is these next couple of slides are real-life cases where this mistake was made. The two images on the left demonstrate an ultrasound. This is a sagittal view of the uterus. This is a view through the left adnexa. This was done as a 5-week scan for pelvic pain, and it was read as a 4 by 3 millimeter fluid space in the uterus. That's this one. A small amount of free fluid. That's here. And a 1.3 centimeter cyst adjacent to the left ovary. And the impression was left ectopic pregnancy with a pseudogestational sac in the uterus. So they considered this little intrauterine fluid collection to be a pseudogestational sac. The patient was treated with systemic methotrexate for the presumed ectopic pregnancy. She had a repeat scan done 4 days later, and on the repeat scan, an intrauterine pregnancy with a yolk sac was seen. So this little fluid collection that they thought was a pseudogestational sac was actually a gestational sac. They only learned that 4 days later, but unfortunately it had been treated with methotrexate. The woman had been treated with methotrexate, which damaged the intrauterine pregnancy, and the outcome, therefore, was a failed pregnancy, leading to a malpractice lawsuit because this early pregnancy, mistaken for a pseudogestational sac, was treated with methotrexate. This was another example of a similar kind of mistake. The image that you see on the left side of the slide was from a 5-week scan done for pelvic pain, and the reading on this was thickened irregular endometrium with cystic spaces, no gestational sac identified, consistent with molar pregnancy. So they saw these two fluid collections. They thought they weren't pregnancies, but they thought the fluid collections indicated a molar pregnancy. Because of that, a D&C was performed to treat the presumed molar pregnancy. Despite the D&C, the HCG continued to rise, so methotrexate was given once a week for 3 months. On a follow-up scan 3 or 4 months later, the woman had a 19-week singleton intrauterine pregnancy. So one of these two fluid collections, presumably these were twins. They thought it was a molar pregnancy. These are twins. The D&C removed one of them, but unfortunately the methotrexate damaged the other one of them. On that follow-up scan, the 19-week singleton pregnancy had already been damaged by methotrexate given early in pregnancy. The outcome was a baby born with microcephaly, and the baby died at 19 months of age. And in the lawsuit, the physician who interpreted this as a molar pregnancy said, I didn't diagnose an intrauterine pregnancy because there was no double sac sign. Well, double sac signs don't have to be present with intrauterine pregnancies. Because of problems such as the ones that I showed you on the 2 prior slides, I, together with Dr. Carol Benson, wrote an editorial called First Do No Harm to Early Pregnancies. Early pregnancies such as the one that you see right here, that are little fluid spaces in the uterus that have no yolk sac or embryo. They're too early for that. No double sac sign, no intradecidual sign. They're just a non-specific fluid collection. That's what a lot of early pregnancies look like. You can't mistake those for pseudogestational sacs, or you'll cause damage and get into trouble. So the sonographic signs of early pregnancy are shown on this schematic diagram. Here is the pregnancy. This is the gestational sac. You can see there's a rim of decidua. There's another layer of decidua. There's at least a couple of layers of decidua separated by the flattened potential space of the uterine cavity. That appearance leads to, on ultrasound, to, in some cases, a double sac sign. This is the gestational sac, and there's a rim of decidua and another rim of decidua. These are these 2 rims that give you the double sac sign. Or sometimes, if the cavity is completely flattened and straight, you will see a gestational sac sitting adjacent to a thin white line, which is the intradecidual sign. So those are 2 sonographic signs of early pregnancy. But there's a third appearance that intrauterine pregnancies can have, and that's no sign, or a so-called non-specific fluid collection. Not all pregnancies, in fact, about half of pregnancies early on, at about 5 weeks, scanned transvaginally, will have no double sac sign, no intradecidual sign, they'll have no sign at all. But don't think that it's not a pregnancy because there's no sign. So here, for example, you see a double sac sign shown on the left. There's fluid collection, a rim of decidua, another rim of decidua. This is a intradecidual sign where you see the gestational sac and the thin, collapsed uterine cavity. When they're there, fine, it's a pregnancy, but when they're not there, it still is likely to be a pregnancy. So when you see a nonspecific intrauterine fluid collection in a woman with a positive beta-HCG, a positive pregnancy test, and by a nonspecific intrauterine fluid collection, I mean one that has oval-shaped with curved edges, there's no double sac sign, no intradecidual sign, no yolk sac, no embryo. Is it a gestational sac or is it a pseudogestational sac? Here are 2 non-specific, 2 different patients. They have a positive pregnancy test, and we see a little fluid collection in the uterus here. We see another one here. There's no double sac sign, no intradecidual sign, no yolk sac, no embryo. Are these gestational sacs or pseudogestational sacs? Well, on follow-up, each of them had an embryo with a heartbeat, as seen here or here. So both of these turned out to be gestational sacs. We know that 11 days or 7 days later. How are we supposed to know whether this was a gestational sac or a pseudogestational sac on the initial scan? Well, let's do a little math. When you see a non-specific fluid collection in a woman with a positive pregnancy test, let's look at how likely it is to be a gestational sac versus a pseudogestational sac. If we assume that the incidence of ectopic pregnancies in all pregnancies is about 2%, and that's the current percentage in the United States, if you also assume that a double sac sign or intradecidual sign occurs in half of intrauterine pregnancies, but the other half are nonspecific, and if you assume that a pseudogestational sac occurs in 10% of ectopic pregnancies, which I think is actually overly high, but some articles in the literature suggest that it may be that high. If you take those 3 numbers and do a little bit of calculation on them, you put them into a calculator, you come out with the conclusion that a nonspecific fluid collection in a woman with a positive pregnancy test has a 99.5% likelihood of being a gestational sac. 199 chances out of 200 of being a gestational sac, only 1 chance in 200, or a 0.5% chance of being a pseudogestational sac. So those nonspecific fluid collections, like I showed you on the prior slide, are over 99% likely to be a gestational sac. Well, there's an expression that says when you hear hoofbeats, think horses, not zebras. Think of the common things, not the rare things. The gestational sac is the common thing when you see a nonspecific fluid collection. The pseudogestational sac, depicted on the right, little fluid in the uterine cavity, is the rare thing, the zebra. So when you see a nonspecific fluid collection, think gestational sac, not pseudogestational sac. So the takeaway message here is that in any patient with a positive pregnancy test who has a fluid collection with rounded edges in the central portion of the uterus, you have to consider it to be a probable or almost certain gestational sac, 99% plus chance of being a gestational sac. And your report should state that there's an intrauterine fluid collection that most likely represents a gestational sac, or some equivalent language. Most importantly, whenever you see those nonspecific fluid collections, treatments that damage an intrauterine pregnancy, such as methotrexate or DNC, should be avoided until intrauterine pregnancy is definitively excluded. If you don't follow these rules, then you can cause damage and get into legal trouble, like this poor fellow on the left side of the screen. Okay, let's move on to another mistake to avoid in the first trimester: over-reliance on the HCG so-called discriminatory level. So here the mistake would be to say the following. The patient has a beta HCG of 2,500 milli-international units per ml, and ultrasound shows normal adnexa and no intrauterine fluid collection. Since the beta HCG is above the discriminatory level of 2,000, a normal IUP can be excluded, and therefore the patient can be treated with methotrexate for possible ectopic pregnancy without concern for harming an intrauterine pregnancy. This mistake is made quite commonly to think that if the beta HCG is above 2,000 and you don't see anything inside the uterus, then it can't be a normal intrauterine pregnancy. If you gave methotrexate because there can't be an intrauterine pregnancy, you would be causing problems, causing damage, as we'll see on the next several slides. So here's an example of a woman who came in to the emergency room at my hospital. She had an ultrasound done. She was having a little bit of pelvic pain. She had a beta HCG that was over 4,336 milli-international units per ml. And as you can see on these two views, sagittal and coronal or transverse views, nothing is seen, no fluid collection is seen in the uterus. The beta HCG is 4,300. Does this mean that she has an ectopic pregnancy or an abnormal intrauterine pregnancy that isn't growing? She can be given methotrexate for her possible ectopic because she can't have a normal intrauterine pregnancy? Well, fortunately, we didn't. It isn't the practice in our emergency room to give methotrexate based on the HCG, on a single HCG level above the 2,000 discriminatory level. Fortunately, we don't give methotrexate in those cases because, look, a month later she had a normal 9.5-week intrauterine pregnancy and ended up giving birth to a normal term baby. So the beta HCG discriminatory level or zone doesn't exclude a normal intrauterine pregnancy. This is one example. Here's another one. This woman came in, she had an ultrasound done for pelvic pain, or she came into the emergency room for pelvic pain. Her beta HCG was a little over 2200. She had an ultrasound, no visible gestational sac. If we followed the protocol that's used in some emergency rooms, which fortunately we didn't, and we don't, this woman would have been given methotrexate because her beta HCG of 2200 was above the discriminatory zone of 2200, and there's nothing seen in the uterus. But look, 6 days later, there's a normal 5.5-week twin intrauterine pregnancy seen, and she gave birth to normal twins. Another example of why the beta HCG discriminatory zone does not exclude a normal intrauterine pregnancy. In fact, we looked, and this will be in press. This is an article being published in the December 2011 edition of the Journal of Ultrasound in Medicine. We looked at our own hospital, the experience between January 2000 and December of 2010. We looked at all cases where the beta HCG was above 2000 and no intrauterine fluid collection was seen on that ultrasound, and then a positive heartbeat was seen on a follow-up ultrasound. We found 9 such cases listed on the right. The ones in white, there are 6 cases where the beta HCG was above 2000 on initial scan where nothing was seen, and then heartbeat, 1 or more heartbeats were seen on follow-up on all of these. The ones in white were the ones that gave birth to, that led to normal liveborn. 6 of the 9 women with beta HCGs of 2000 and no heartbeat and no gestational sac on the initial scan came back with a pregnancy seen on a follow-up scan. 6 of them had babies. The highest one is the one that I showed you with the HCG of 4,300, who ended up with a normal liveborn. So our conclusions are that a beta HCG, even above 4,000, which is double the discriminatory level, beta HCG above 4,000 and an empty uterus does not exclude a normal pregnancy outcome. If a woman is hemodynamically stable and ultrasound doesn't demonstrate an ectopic pregnancy, the discriminatory level should not be used to guide management. And 7 normal babies at our hospital alone might not have been born if the discriminatory level had been used to guide patient management. So 1 HCG level above the discriminatory level of 2000 with nothing in the uterus does not exclude a normal intrauterine pregnancy, and that's why it shouldn't be used to guide management that might damage an intrauterine pregnancy. Another mistake to avoid in the first trimester is confusion between an intraovarian mass and an extraovarian mass in a patient with a positive beta HCG. So the 2 errors that can be made here are that a mass within an ovary, which is likely to be a corpus luteum. If there's a patient with a positive pregnancy test and a mass in the ovary, it's almost certain to be a corpus luteum, but it could be mistaken for an extraovarian mass, which would lead to the false positive diagnosis of ectopic pregnancy. The flip side, the other error that could be made is the mass adjacent to an ovary may be mistaken for an intraovarian mass, or a corpus luteum, which would lead to failure to diagnose intrauterine ectopic pregnancy. This kind of dilemma is shown here in 3 different women who had ultrasounds done with a positive pregnancy test and pain, and in each case we see the ovary and a mass. We see the ovary and a mass. We see the ovary and a mass. But it's unclear whether this mass is, for example, in this case, does the ovary end here, in which case this is an extraovarian mass and it's an ectopic pregnancy, or does the ovary, is the outline of the ovary as shown here, in which case This is an intraovarian mass, and it's just a corpus luteum. Similarly, if the ovary ends here, that's extraovarian. If the ovary ends here, it's intraovarian, and the same with this one. On follow-up, 2 of these were ectopics, and 1 was an intrauterine pregnancy. But how do you tell at the time of scanning when you see a mass that is right either adjacent to or on the edge of an ovary, whether it's just inside or just outside, because it makes all the difference in the world. Just inside, it's corpus luteum. Just outside, it's an ectopic. And this is an example. Woman had an ultrasound for pelvic pain and a positive pregnancy test. An ultrasound was done. Nothing was seen in the uterus. Here's the ovary. There's the ovary, and there's a mass. Does the ovary go out to here, in which case this is intraovarian? Does the ovary end here, in which case it's extraovarian and it's an ectopic? Makes all the difference in the world whether it's intra or extraovarian. How do you tell the difference? Well, you tell the difference in many cases by taking advantage of the fact that ultrasound is a real-time specialty. Your transducer is sitting right up against the ovary. Push it and see if these two, this and this, move together or separately. And here's what happens when we push. You can see that those 2 structures move separately. This is beside the ovary, or so it's an ectopic pregnancy. If they move together, we would have concluded that it's in the ovary and probably just a corpus luteum. Here's another similar case. A woman had an ultrasound for pain and a positive pregnancy test. As you can see in the upper image, there's the uterus, nothing in it. And in the adnexa, we can see that there is this thing looks like the ovary. Here's a mass, but is it in the ovary, just hanging off, protruding out from inside the ovary, in which case it's corpus luteum, or is it outside the ovary? Well, we pushed. And when we push, you can see they move together. They don't move separately. So we concluded that this is probably just a corpus luteum inside the ovary, and therefore she doesn't have an ectopic pregnancy. And fortunately, we didn't give her methotrexate. She wasn't given methotrexate because we thought that this was a corpus luteum. And sure enough, on follow-up, she had an intrauterine pregnancy. It was just too early to see on the initial scan. So the way to avoid confusion between an intraovarian mass and an extraovarian mass is to push with the transducer and see if the mass moves with the ovary, in which case it's probably a corpus luteum, or moves separately from the ovary, in which case it's likely an ectopic pregnancy. Another mistake to avoid in the first trimester is undercounting pregnancy number prior to 6 weeks gestational age. The mistake that you can make here is to say, congratulations, you have a 5-week singleton pregnancy. And we'll see in a minute why this is an erroneous statement that you have to be careful about. So this is a woman. We did an ultrasound. We looked, she had positive pregnancy test. We did the ultrasound. We see an intrauterine gestational sac. There's faintly visible within it a yolk sac. So this looks like she has a singleton intrauterine pregnancy. But actually look, on follow-up, just a few days later, she actually has twins. There's 2 yolk sacs, 2 embryos. So in the first scan, we told her, looks like you have 1 baby, but we're not completely sure. And in fact, she has 2 babies. These were twins that were undercounted on the initial ultrasound. Here's another case in which we did an early pregnancy. We, at about 5 to 5.5 weeks, we see 2 gestational sacs. So we could say to this woman, you're having twins, but in fact, there's a 3rd gestational sac a week later. And in fact, within about a week or 2 after that, there were embryos in all 3 gestational sacs. And she had normal triplets, which were undercounted on the initial scan as twins. So undercounting pregnancy number at 5 to 6 weeks gestation happens, and not that infrequently, because prior to 6 weeks gestational age, you don't yet see the embryo or consistently, or the yolk sac, and the gestational sac is very small. You may miss a yolk sac or a gestational sac. So realize that a pre-6 week ultrasound may undercount pregnancy number, which would lead to an appearing twin or appearing triplet on subsequent scan. In a study that I did together with Dr. Carol Benson, published in the Journal of Ultrasound Medicine in 1998, we found that multiple gestations were, when they happened to be scanned prior to 6 weeks, were undercounted 14% of the time. I just showed you a couple of examples on the prior slides. So how do you avoid this mistake in terms of assessment of pregnancy number? When an intrauterine pregnancy is seen on a first trimester ultrasound, you should always make an assessment of pregnancy number, twin, singleton, twin, or whatever, but recognize that the final count may decrease due to the vanishing twin phenomenon, but also may increase due to what we've called the appearing twin phenomenon. So as long as you explain to the patient that and recognize yourself that the number that you're counting, the pregnancy number that you're determining on a pre-6 week ultrasound, is a preliminary estimate that may go up or down, you won't look foolish when you say clearly it's this number and more show up on a subsequent ultrasound. Continuing on our mistakes to avoid, another mistake is misinterpretation of a follow-up scan after methotrexate is given for a tubal ectopic pregnancy. And the mistake you could make here is to say, well, I'm scanning a woman who was treated with intramuscular methotrexate for ectopic pregnancy 1 week ago. She now presents with pelvic pain. I do an ultrasound. The adnexal mass representing her ectopic pregnancy is now larger and more vascular than it was just prior to treatment, so I'll report the scan as indicating treatment failure. This would be a mistake. Masses of an ectopic pregnancy will often increase in size and vascularity in the 1 to 2 weeks following methotrexate for ectopic pregnancy, even when the pregnancy is successful. Here's an example. This is a woman who had an ultrasound for pelvic pain, positive pregnancy test. We did the ultrasound. There was nothing in the uterus. There's the ovary. And we saw an adnexal mass, a right adnexal mass, sitting between the ovary and the uterus. And we said correctly, it was the correct thing to say, this is an ectopic pregnancy. You can see that it's measuring about 1.48 or about 1.5 centimeters. Because of the diagnosis, she was given methotrexate and was having quite a bit of pain, so was sent back for a follow-up ultrasound a week later. And on the ultrasound a week later, this mass has grown from 1.5 centimeters to over 2 centimeters. You can see it's rounder, fuller, bigger than it was prior to methotrexate. This is 10 days later. It's quite vascular. So it would be a mistake to say this has grown and therefore methotrexate treatment that was given initially failed. You should give it again or go in and do surgery or laparoscopy. This is the typical appearance, not the appearance of failed methotrexate, but the typical appearance after methotrexate. In fact, ultrasound following methotrexate in the week or two is usually non-contributory because the mass usually increases. So in terms of the interpretation of an enlarging adnexal mass a week or two after methotrexate treatment of ectopic pregnancy, the adnexal mass often increases in size and vascularity after methotrexate may take several weeks to resolve. So the increase in size and vascularity of an adnexal mass 1 to 2 weeks after methotrexate treatment for ectopic pregnancy should not be mistakenly interpreted as pregnancy failure. Another mistake to avoid is confusion between a corneal ectopic pregnancy and an eccentrically located intrauterine pregnancy. So this is a schematic diagram of a corneal ectopic pregnancy. There's the body of the uterus and the endometrium or decidua of the body of the uterus. There's no pregnancy there, but there is a pregnancy in the cornu of the uterus. This is a cornual or interstitial ectopic pregnancy. Note that it's very eccentric relative to the right to left side of the uterus. This is the middle, it's way off to the side. But you can get pregnancies off to the side in other situations. You can get a pregnancy, sometimes the uterus is normal, but the pregnancy, instead of bulging inward, bulges a little outward. So you get an eccentric pregnancy, but it's within the uterus. It's just a normal pregnancy, and as this grows, it will grow into the center. Another situation that you can have an ultrasound that's eccentrically placed relative to the left to right side of the uterus is if you have a bicornuate uterus, as shown here, or a septate uterus. In all these three cases, the uterus is the pregnancy or gestational sac is eccentrically located, but it's not a cornual ectopic pregnancy. This one is an emergency. This can lead to severe or even life-threatening bleeding to the mother if the cornea ruptures. These need no treatment and may well go on to a normal to a normal baby. Just by way of example, this is a cornual ectopic pregnancy. There's the body, the decidua or endometrium in the body of the uterus. Way out on the left side of the uterus, there's a gestational sac, and you can see that it bulges the edge of the uterus and that the bright echogenic tissue around it extends all the way out to the edge, serosal edge of the uterus. This is abnormal. This is a cornual ectopic pregnancy. You can see here there's a heartbeat, there's a live embryo in it, but the echogenic tissue around the pregnancy extends all the way out to the edge. This is not intrauterine, this is in the cornu. This is a cornual ectopic. On the other hand, what we see here is an eccentric pregnancy, an eccentric intrauterine pregnancy in a normal uterus. And the difference here is that the bright tissue called trophoblastic tissue doesn't extend all the way out to the surface. There is myometrium around the edge of the pregnancy here. So this is just an eccentric intrauterine pregnancy in a normal uterus. And in fact, 2.5 weeks later, it had moved into the center. Everything looked completely normal. So you have to distinguish by looking at whether it bulges and whether there is myometrium around the edge. Again, here we have on the left, this is a cornual ectopic pregnancy. The bright trophoblastic tissue extends all the way out to the serosal surface here, and also on the video clip where you see the live baby, but you see the trophoblastic tissue extending out to the serosal surface. On the other hand, these are 3 different eccentric pregnancies. Here on the right side, this is a septate. This turned out to be a septate uterus, but there's myometrium around. Here, this was a bicornuate uterus with myometrium around it. This was a uterine didelphus or didelphic uterus. There's myometrium around it. These are all these pregnancies are eccentric, but only this one is a cornual pregnancy. So the diagnostic criterion to avoid this mistake is if you see an eccentric gestational sac bulging the uterine contour with little or no visible myometrium, which is hypoechoic tissue around the superior or lateral aspect, it's a cornual ectopic. If you see myometrium around the entire gestational sac, it's an intrauterine pregnancy, maybe in a duplicated uterus like a septate or bicornuate, or maybe not. But in any case, if you see myometrium around the entire gestational sac, it's an intrauterine pregnancy. If you're not sure and the patient is stable, 3D ultrasound with coronal reconstruction can give you the answer, or you can try following up. These are two different women. The ultrasounds look pretty similar. In both cases, you see an eccentric sac, bulges a little bit, the bright tissue, clear, looks like it's coming all the way to the serosal surface. Here it may also be. So these are two different women. The ultrasounds both are the same, but when we did 3D ultrasound with coronal reconstruction, here you can see that the gestational sac, this is this gestational sac on a coronal reconstruction from a 3D sonogram, is in the cornu. That's cornual ectopic. This one clearly is continuous with the endometrium and the body of the uterus. It is a intrauterine pregnancy that happens to be off to the side. And this one had to be treated, and this one didn't because she had an intrauterine pregnancy. And she looked completely normal on follow-up a few weeks later. Another potential confusion is between a cervical ectopic pregnancy and a spontaneous abortion in progress. Cervical ectopic pregnancy is implanted in the cervix, and this is an ectopic. It's emergent. It's an emergency situation. This can lead to severe bleeding if you don't do anything. In fact, if you just try to scrape it out, there could be very severe bleeding, life-threatening to the mother in this case. A spontaneous abortion in progress is when the pregnancy started up in the body of the uterus but is now passing out through the cervix. This is a spontaneous abortion in progress. Passing through, this is implanted in the cervix or cervical ectopic. This is an emergency situation. This is not nearly as emergent and requires no serious treatment because it will come out on its own. So how do you tell the difference? Well, schematically, note that a cervical ectopic pregnancy is likely to be a normal appearing gestational sac, often has an embryo, may have a heartbeat, whereas a spontaneous abortion in progress is a flattened, irregular sac that's sitting in the cervix. Here are two examples. The case on the left, this is one case where on sagittal view you see the pregnancy inside the cervix, and it looks like a normal gestational sac. It has an embryo with a heartbeat. The only thing abnormal about it is that it's sitting in the cervix instead of the body of the uterus. This is a cervical ectopic pregnancy. On the other hand, here you see a flattened gestational sac, little material in it, what looks like a yolk sac but no heartbeat. This is a spontaneous abortion in progress. So the diagnostic criteria to use here to make the distinction between a cervical ectopic and a spontaneous abortion in progress are if you see a well-formed gestational sac in the cervix with a prominent echogenic rim around it, especially if you see a live embryo, it's a cervical ectopic pregnancy. If it's a flattened and irregular sac with thin or absent echogenic rim and there's no live embryo, you're dealing with a spontaneous abortion in progress. If it's equivocal, if the ultrasound findings aren't clearly this or this, you can wait 1 or 2 days. If it's equivocal, if the ultrasound findings are equivocal and the patient is stable, you can wait a day. And if it's unchanged, you're dealing with a cervical ectopic pregnancy. If it's changed or absent, you're dealing with a spontaneous abortion in progress. Here's an example. This on the initial scan, here in the body of the uterus, we see nothing. In the cervix, we see a gestational sac. There's an embryo, but no heartbeat. There isn't much of a decidual reaction or echogenic rim around it. We thought it was probably a spontaneous abortion in progress, but we weren't completely sure. So we waited, and shortly thereafter, on follow-up, the gestational sac was gone. So this was a spontaneous abortion in progress where the diagnosis was made by serial scans, suspected on the earlier scan, proved by serial scans. Yet another mistake to avoid in the first trimester is failure to diagnose a cesarean scar implantation, a gestational sac implanted in a cesarean scar. The distinction we're trying to make here is between a pregnancy in a cesarean section scar as compared to a spontaneous abortion in progress or a low implantation of a pregnancy. This one is an urgent situation because pregnancy in a cesarean section scar that's all the way up into it and up to the serosal surface can lead to uterine rupture as it grows. So is a very different situation than a spontaneous abortion in progress or low implantation. So the diagnostic criteria for a C-section scar implantation is the patient has a prior cesarean section. The gestational sac is located low and anteriorly in the uterus, just above the cervix, where the scar is, in other words, and the gestational sac and the surrounding echogenic rim, which represents trophoblastic tissue, extends to the serosal surface of the uterus. And this is an example of a cesarean scar implantation. You can see here the cervix ends around here, so the gestational sac is low in the uterus, just above the cervix. It looks like it's extending with the bright tissue all the way up to the serosal surface. When you look closer on this close-up view, you can see the bright echogenic trophoblastic tissue is actually extending not only up to the serosal surface, but even bulging it. This is a cesarean scar implantation. Now, the reason these are emergent and have to be treated is you can see on this sequence of scans, this is a woman who we diagnosed a cesarean scar implantation at 5.5 weeks. The cervix ends around here. Low in the uterus is a gestational sac. The trophoblastic tissue is extending up to the towards and probably all the way to the serosal surface. We suggest that this woman be treated. One of the possible treatments is to inject potassium chloride or methotrexate into the gestational sac, but the woman declined. When she came back 2 weeks later, you can see it's grown, there's an embryo, but now it's starting to bulge that surface. And she was having quite a lot of pain. And we said, really, we strongly suggest that you treat this again, probably by injection into the sac, so that the sac will then stop growing and shrivel up, because you may rupture your uterus. She said no, and 4 weeks later you can see now she was having very severe pain, bulging the uterus, and she actually came to require a hysterectomy to save her life at this point, whereas a less invasive treatment earlier would have saved her uterus. So these are important findings to diagnose and consider management early on. Another mistake to avoid in the first trimester is incorrect follow-up of first trimester bowel herniation. Two mistakes you can make here are, one would be to say, well, bowel herniation at 10 to 12 weeks is part of normal embryologic development, so I always report it as normal. If you always report first 10 to 12 week bowel herniation as normal, you'll miss the odd case of omphalocele that comes to you on for a 10 to 12 week scan. The other mistake you make in the other direction would be to say 10 to 12 bowel herniation at 10 to 12 weeks occasionally represents an omphalocele, so I always recommend a follow-up scan to rule out omphalocele. This would lead to all sorts of unnecessary scans and worried mothers who are scanned at 10, 11, 12 weeks who are told they may have an omphalocele, but will need to check you in a few weeks to see. So to never do a follow-up or always do a follow-up would be a mistake. Here at about 10.5 weeks, you can see a mass protruding from the anterior abdominal wall seen here and here. Do we need to follow it up? No, this is just physiologic bowel herniation. If she did have a follow-up, not for that reason, for a fetal survey, and you can see that the umbilical cord insertion site's completely normal at that point. This was just physiologic bowel herniation. We didn't warn the mother that she may have an omphalocele and needed a follow-up because we were confident that it was physiologic bowel herniation. So how do you tell? You don't want to follow these all up, but you don't want to miss the odd omphalocele that comes through. Well, to answer or avoid the mistake, let's summarize the relevant literature, which says that in the normal fetus, an echogenic mass protruding from the abdomen is seen between about 8.5 and 10.5 weeks, almost always 10.5 to 12 weeks sometimes, and greater than 12 weeks virtually never. The upper limit of normal for maximum diameter of the protruding mass is about 7 centimeters. So this gives us a clue as to what our recommendations should be, and they're shown here. If you see an echogenic mass protruding from the anterior abdomen and it appears prominent at 8 to 12 weeks, measure it. And if the measurement, either anteroposterior or transverse diameter, is less than 7 millimeters, just report the scan as normal and no need to rescan, like in the case that I showed you a slide or two ago. On the other hand, if it's greater than 7 millimeters, greater or equal to 7 millimeters, then it may be an omphalocele, and she should be rescanned in the second trimester to rule out omphalocele. So here's a case where the maximum diameter, here's a herniated mass. The maximum diameter is less than 7 millimeters. It is about 5.5 in both dimensions, as well as about 5 millimeters across, transverse. This is normal. This should be reported as normal, and there's no need to rescan. On the other hand, here are two different women where the herniated mass is measuring over 7 millimeters. Here it's about 11 or 12. Here it's a little over 7 millimeters. These went in the infrequent case that they're over 7 millimeters, we recommend a rescan for a possible omphalocele. This one had one on follow-up. This is an omphalocele. And this patient on follow-up has a nice normal cord insertion. Another mistake to avoid in the first trimester on our long list of mistakes, it relates to the fetal heart rate early on. When the heart rate is slow between 6 and 7 weeks of gestation, there's a fairly high chance that the heartbeat is going to stop, that the embryo will die. Slow heart rate is a bad finding, indicating a high likelihood of subsequent fetal death. So when we see a slow heart rate, we recommend a follow-up ultrasound. And most of the time with a slow heart rate, the follow-up ultrasound will show no heartbeat. But what if the heart rate is slow on a scan today? We recommend a follow-up in 10 days, let's say a week or two later, she comes back and the heart rate's normal. Does that mean that the risk is gone? So, in fact, it doesn't. And the mistake would be to say the embryonic heart rate, which was slow a week ago, is now normal, so the prognosis for the pregnancy is fine. That, unfortunately, is not the case. Here's an example. A woman had a slow heart rate under 90 beats per minute at 6 weeks. Here it is actually going at 89 beats per minute. It's a little slow. So we said, heart rate slow. We're worried about the prognosis for the pregnancy, suggested a follow-up. At about a week and a half later, at 7.7 weeks, she came back. Now the embryo's grown. The heart rate is fine. It's in the mid-100s, 163 beats per minute. Does that mean that her prognosis is fine? We were worried here, but now it's fine. Well, the answer is this worrisome finding, even when the heart rate's normal, her chance of demise is still somewhat elevated. And notice that at about 10 weeks, there is fetal demise. So unfortunately, when the rate is low on the initial scan, follow-up scan with a normal rate doesn't mean that the chances are completely normal. We did a study at our hospital, published a few years ago, and when the fetal heart rate is slow on the initial scan and then follow-up is normal, there was still a 25% chance of demise, which is still pretty high. So you want to avoid false reassurance when a slow heart rate reverts to normal on a follow-up scan. When a slow heart rate is seen at 6 to 7 weeks, the embryo is at increased risk of demise by the end of the first trimester, even if the heart rate is normal on a follow-up scan 1 to 2 weeks later. The risk of demise by the end of the first trimester remains high, about 25%. When is the woman when does the increased risk end? The answer is that if you have a slow heart rate early on and the fetus is still alive, there's still a heartbeat at the end of the first trimester at 13 weeks, then the risk reverts to normal. And yet another mistake to avoid is failure to recognize a thick nuchal translucency. The two mistakes you could make here would be, I'm doing a 12-week scan on a patient who isn't planning to have a serum screen, so I'll ignore the nuchal translucency. Or I'm doing a 12-week scan and I'm not NT certified, so I'll ignore the region behind the fetal neck. You should always do as complete an evaluation on any ultrasound that you do, and that includes looking at the fetal neck, even if the woman isn't having a serum screen or you're not NT certified. Here's a scan on a fetus at about 12 to 13 weeks. Apparently normal looking fetus. Say she's not planning to have a serum screen and or you're not NT certified. Does it mean you shouldn't look at the region behind the neck? Not at all. And if you look carefully at the region behind this fetal neck, you'll see, I don't see the second line I should be seeing. You normally see another line in here, which is the skin surface, making you wonder whether this whole thing is a thick nuchal translucency. And in fact, when the baby jumps up, you can see that she has a thick nuchal translucency. That led to concern that she might have a chromosomal abnormality. And in fact, this fetus turns out to have trisomy 21. So don't ignore looking at the nuchal translucency, looking at the region behind the fetal neck in cases when a woman isn't planning to have a serum screen or if you're not NT certified. Here are 4 different fetuses with thick nuchal translucency. This one proved to have trisomy 13, trisomy 21 in this one. This one had demise 2 weeks later after the thick nuchal translucency. And this one, even though the nuchal translucency is very thick, over 5, is normal. So the nuchal translucency doesn't tell you what the outcome has to be, and in fact it can be normal even with a thickened nuchal translucency. But the risk is high, and you should always look at it regardless of the situation. So I've come to the end of the tour of mistakes that can be made in the first trimester. Making these mistakes can lead to bad outcomes to the embryo or fetus, or bad outcome to the mother. You really want to avoid these mistakes, and I hope I've given you some clues as about how to avoid some of these mistakes in the first trimester.